Assalamu alaikum and good morning. My name is Dr. Juma Al-Kabi and I would like to welcome you all to this morning session. It's a great pleasure for me to welcome again our first speaker, Professor Peter Nash, who is going to talk to us about the JAK inhibitors and small molecules facts and fiction. Professor Peter Nash is a professor at School of Medicine, Griffith University, Associate Professor at Department of Medicine at the University of Queensland, and Director of the Rheumatology Research Unit in the Sunshine Coast. Prof. Nash has chaired the Professional Affairs Committee and the Therapeutic Committee the NHS MRC, musculoskeletal balance, panels and SAFEs on the Scientific Advisory Committee of the Australian Rheumatology Association. He is a former member of the Therapeutic Committee of the Australia and New Zealand Bone and Mineral Society. Prof. Nash and his group at the Rheumatology Research Unit have been involved with better registration clinical trials of all modern targeted synthetic and biologic therapies. He has published more than 200 peer-reviewed papers and 5 book chapters and acts as a reviewer for a number of journals. He has recently been recognized as the Australian Rheumatology Research Leader with the most citation in the top 20 journals in rheumatology over the last 5 years. Without further ado, please join me in welcoming Professor Peter Nash. Please.
Thank you very much, Mr. Chairman, and thank you to the organising committee for the very kind invitation to join you. Today, I'll be talking about JAK inhibitors in particular and the oral surveillance study and what should we make of this. And unfortunately, there'll be a lot of numbers, and I hope you'll bear with me. These are all my own thoughts. Next slide, please. Whoops. So that's our brand new $1.5 billion hospital, and we're very proud of our hospital. I thought we would cover 4 major sections in the limited time that we have. This is Janus, the god of doorways, looking backwards and forwards, and we need to look forwards with the JAK inhibitors. So why are we even talking about them? Tofacitinib approved almost a decade ago. The oral surveillance study was commenced in March of 2014. Baricitinib approved around 2018, upadacitinib around that period of time. I'll remind you of the ENTRACT study, which we will use to compare MACE and cardiac safety, compared tocilizumab with etanercept. I'll remind you that EMA in 2020 put a label on tofacitinib to be careful with VTE in patients over 65 and infection, and to think of the JAKs post-TNF. They have now just this month or last month commenced a review of all JAKs, and then the oral surveillance study, which has caused a lot of concern around the world. Very comprehensive clinical trial program for all the JAKs in all the groups that you and I have to look after: treatment naive, MTX-IR, conventional synthetic IR, and BDMARD IR. And they really have followed thousands of patients in clinical trials over a decade. Yesterday, we talked about the, next slide. We talked about the reasons why the JAKs have been so popular. Oral, non-inferior or superior to methotrexate and adalimumab in many studies, no immunogenicity if you stop and start. The potential generically, I think, is important. The monotherapy space is also important and understudy in many diseases. We now have 5 around the world that are approved and being used. The Japanese have approved peffercitinib, which we don't have in our country. Rux is used for myelofibrosis. This is a TYK2 inhibitor that is going to be approved for psoriasis and psoriatic arthritis, but there's so many more. We need to know a little bit about how safe JAKs are. And you can see that there are 400 kinases. And in rheumatology, we have tried to block many of them. The P38 MAP kinases didn't meet their primary endpoints in rheumatoid arthritis. The spleen kinases also didn't work successfully. BTK, Bruton tyrosine kinase, it's interesting, one worked, one didn't work. The one that didn't work was the covalent irreversible bind to turn off B cells and hopefully turn off lupus and turn off rheumatoid factor. But the short-acting reversible one did work. So we'll hear more about the BTK inhibitors, but we won't have time to go into them today because we're going to focus on the JAKs. One of the things that we have learned, if this thing would change, is that this simple little cartoon that we've all gotten used to isn't as straightforward as we thought. Because these stats, signal transducers, are indiscriminate in the cell, they're promiscuous inside the cell, and you'd think JAK1 should bind to STAT3, but in fact it can bind to others and turn on other forms of transduction. JAK2 should bind to STAT5, but again, there's a degree of promiscuity and they bind to each other, and what seems like straightforward cartoon isn't so. We've learnt that we want to block 1 and 3 because they're the things: inflammation, B cell switching, T cell, NK cell differentiation. That's what we would like to do. And we would like to leave JAK2 alone because it's involved in erythropoiesis and myelopoiesis and etc. But what have we learnt? Selectivity is the way many companies have gone. You can see if you push the dose with this one, you'll start to impinge on the other JAKs. Barry has always been JAK1 and 2. Filgotinib, very different. There's a 10-fold difference before you start blocking the others, and a 3-fold difference with UPA. And what we've learned is that they all have very individual cytokine inhibition profiles. So if you take interferon as an example, and this is 100% of the dosing cycle, this blocks at 60% of the time, this might block at 40, 50, and so whichever cytokine you pick, each one has a very individual profile. They're all very different, very much like we're now used to the TNFs all being very different. If you just take IL-21 as an example, this hardly interferes with IL-21 at all, whereas this one blocks it for half of the dosing cycle, this one for a third of the dosing cycle, etc. So you can't predict without doing the clinical trials. And if you push the dose, blue is reaching ACR 50, and purple is when you start to inhibit erythropoietin, you start to inhibit JAK2, you start to see anemia. So as you push the dose of UPA upwards, you're starting to block JAK2. So it might be selective, but it's not 100% selective if you push the dose high enough, and 15 is the sweet spot with minimum JAK2 inhibition and pretty good ACR 50 in the range that we're used to seeing. So the only point I'm trying to make is the higher you push the dose, the more likely you are to get a pan-JAK effect. Remember that these cytokines are not inhibited by the JAK kinases directly, but there's a lot of overlap in the cell, and you turn off upstream and you start to change things downstream. Efficacy, everybody knows about efficacy. We talked about it yesterday. The first drugs to beat head-to-head the gold standard of adalimumab plus methotrexate, whether you look at ACR, signs and symptoms, pain, function, quality of life. This is baricitinib, and it does exactly the same. This is filgotinib. Sorry, this is looking at the CDAIs where you take the CRPs out. And filgotinib is the same at DAS28 remission. So really the JAKs have established themselves as non-inferior or superior. And again, it's this interesting thing, the swollen joint counts are the same, baricitinib in red and adalimumab in blue. Physician global drove the statistical significant difference, as did patient global and pain. So these drugs are very effective for pain, and we're going to start studying them in other painful conditions. And you can show exactly the same with upadacitinib, no different swollen joints, but there were differences in pain scores and those other things because IL-6 and GM-CSF is involved in the peripheral nervous system, and we've learnt that inhibiting those will have a profound effect on pain. We talked yesterday about switching. There's a Barry study about tapering the dose, and many patients can stay in a good state. And if you lose efficacy, you can add the higher dose back in, and people then do respond. But everybody wants to talk about this study, which is oral surveillance, because this was a TOFA versus adalimumab in RA patients with a cardiovascular risk factor who had failed methotrexate. So the kinds of people who were eligible, the risk factors was current smokers, hypertension, elevated lipids, diabetes, family history of coronary artery disease, a number of other things along those lines. No prior issues and no prior malignancy. They compared the two doses, 5 and 10, and after a period of time, they found that 10 was associated with DVT, so all 10s changed to 5, and it was an event-driven study, went about 5 years, and they had to have enough events to make statistical comparisons. And the primary comparison was a combination of TOFA doses versus the TNF, and the non-inferiority margin was 1.8. And there are lots of other secondary comparators. So that was the study everyone is concerned about. And it was powered for cardiovascular issues. But if you just look at funny things like smoking status, current smokers, there's a 4% difference between the two. And if the results are lung cancer malignancy and cardiac events, things like the number of smokers, if they're out of balance, might affect the results. Even if you look at the use of cardiac aspirin, there was an imbalance where the TNF patients had a couple of percent more who were taking cardiac aspirin to protect themselves from MACE events. So what kind of numbers would we expect in an RA population when we're thinking of major cardiac events? This is from the clinical trial program with tofacitinib, and the 5 milligram dose is the only dose that's approved, except in ulcerative colitis, and the only dose we'll discuss. And the number's about 0.4 per 100 patient years. So if you treat 1,000 patients for a year, you'll get 4 events. This is from Corona, where they had real-world evidence of thousands of patients on tofacitinib, and there's the number there, which I can't read from here, but that is the kind of result you would expect. It's 0.54. I mentioned the INTRACT study because that gives us an idea of background MACE events. And here, the TNF caused 1.42 per 100 patient years. And tocilizumab, the IL-6 inhibitor, no different, but it was up around the 1.7 range. And so that's what you got in that study. This is looking at all the different biologics, saralimumab, certolizumab, tofa. They're all around that 0.4, 0.5 range. So what do they get in oral surveillance? Suddenly it's 0.9 and the TNF is 0.7. None of this reaches statistical significance, but the incident rates are different. So the number needed to harm is 587 patients. You treat 587 patients for 1 year, you'll get 1 extra non-fatal MACE events. and the absolute difference was 0.18. We expected about 0.5, we got 0.9, 0.7. That's real world head to head. Lots of things could have been responsible. And if you look, the difference was 47 events out of 1,400 and 37 events out of 1,400. And if you shift 5 patients either way, you would change the entire results. What drove the difference? Smoking, lack of aspirin use or aspirin use, and age, males, diabetes, the usual kind of risk factors. So that was the difference that led to all the fuss, as did the issue with malignancy. Same issues. What numbers would we expect in a rheumatoid population? It's around the 0.8s, the corona registry a little bit higher, about 0.9, but that's what you see in real world evidence, and that's what you see in the RA clinical trial program. That's looking at all the other agents, and again, 0.7, 0.8, 0.9. What did they get? 1.13 compared to the 0.8. And now you only had to treat 278 patients for a year to get 1 extra malignancy. Now we know that both JAKs and TNFs cause non-melanoma skin cancer. We're the skin cancer capital of the world. So we're very cognizant of melanoma. We're very cognizant of skin cancers, and all our patients get formal skin checks once a year. But again, this is the incidence, 62 out of 1,400, 42 out of 1,400 didn't reach statistical significance, but they had differences of 0.36 per 100 patients treated for 1 year. 278 was the number needed to harm. Now, malignancies in RA are increased, particularly lymphoma, but these other ones as well, like lung cancer compared to the normal population. And they're the kinds of differences they found in oral surveillance. If you like less melanomas, the TNF caused more melanomas, and the JAK caused more lung cancer, which drove the difference. So if there is a smoking difference, maybe that affected the lung cancer numbers. They looked in this particular registry because malignancy is a very serious issue. If you have a patient on a JAK who develops a malignancy and they go online and see the lawyers advertising, they'll be asking you questions about, did your treatment cause my cancer? This was a retrospective study, but they looked at the claims database of 27,000 people who they duplicated the risk factors of oral surveillance, and 83,000 people who had real world evidence, and they really couldn't show any difference between tofacitinib and the TNF as far as malignancy is concerned. The difference was quite small. Didn't seem to have any increased difference in cardiovascular risk, but that was retrospective study. Again, if we've got to talk VTE because of the whole baricitinib issue, you can see these are the rates we expect. The numbers are around 0.6 to 0.8. I'm sorry, it's all about numbers. This is a publication, look at the entire TOFA clinical trial program. And again, they hardly saw any difference between adalimumab and TOFA-5BD. And they published this as didn't seem to be any difference. And this is what they got in oral surveillance. 9 out of 1,500 on TOFA-5BD and 3 out of 1,500 on the TNF. And you only had to shift 1 or 2 either way and you'd have changed the whole result. Again, it didn't reach statistical significance, but the incident rates are different. What about the other JAKs, Barry, UPA, and Filgo? We all know there's a zoster signal of about 3 per 100 patients per year. That's serious infections. That's the 0.9 we're talking about for malignancy and the 0.5 for MACE. There didn't seem to be a huge signal. Oral surveillance stood out as being different. What drove VTE? Having a history of VTE. So we are careful with JAKs if there's a history of VTE. Being on the pill, using steroids, being obese. I don't know why antidepressants got in there. Hypertension, males over 65. So the risk factors are as you'd expect. Over 65, obese, with a history of VTE, you might consider an alternate. Serious infection is just about to be published in the Annals of Rheumatic Diseases from the oral surveillance. Whoops. Please change. And the difference versus the TNF, you had to treat 283 patients for a year to have one extra serious infection with the JAK inhibitor. We know that if you have an RA patient on prednisone and methotrexate, their rate is 3 per 100 patients per year. And here it's about the 3.6 per 100 patients per year. If anything, the TNF, treating disease activity, was a little protective. So they're all about the 3s, the TNF a little bit lower. So maybe they're better at treating the disease activity, which decreases your risk. You need less prednisone, you get less serious infections. They tell me zoster is not a big issue in the Middle East. It's a huge issue in the Asia Pacific because China, Taiwan, Korea, Japan, they get 8 per 100 patients per year with zoster. In our country, we get 3. But the group who have the highest risk are all your lupus patients from the youngest age. The rate for rheumatoid really starts to go up over 50, and that's when zoster becomes an issue the older and older you get. But all our lupus patients on all their immune suppression are the highest rates. And in this study from the TOFA, they looked at the patients who were not on methotrexate, who were not on prednisone, and their risk came right down from 3 down to 1/2. So it's the concomitant steroids and the concomitant background therapies that are just as important in driving zoster as the JAK inhibitor is, but there's no doubt that the JAKs do increase the risk. Just to finish, baricitinib has now published long-term safety out to 8 years, and again, the rates are exactly as we would expect with the JAK, and the rates are less than we're seeing in oral surveillance. And the same has been done with upadacitinib, also 5,000 patients out for 4 to 8 years. And again, the safety signals are what you'd expect without anything standing out. This is just to show you TOFA in psoriatic arthritis does not have increased rates. So for the FDA to slap the black box on all JAKs for all indications is really not very evidence-based. So I apologise for all the numbers, but there's no other way of trying to get your head around what oral surveillance means, but we need a few take-home messages. So the JAKs are here to stay. We need to learn how to use them, the monotherapy patients, the patients who failed lots of other therapies and are in real trouble, those patients that are needle phobic, the million reasons why you might think about a JAK, someone who's going to stop and start their treatment, someone who needs a short half-life drug because of elective surgery, because of pregnancy, etc. And we have to weigh up risk and benefit for each patient, which we do every day. So we should think about cardiac risk factors and a history of VTE and think about treating high lipids and controlling blood pressure. Smoking drives lung cancer, smoking drives cardiac events, and we really don't do a lot about getting our patients to stop smoking. We do yearly skin checks anyway for melanoma and non-melanoma skin cancer, and we'll think about whether we need to give patients with VTE a JAK or not, because they're the ones who are at increased risk. As we showed you, age, obesity, and a history are the biggest risks. And we like to keep the lymphocyte count above 500 because then patients are less likely to get opportunist infection. And that applies not just to JAKs, but to leflunomide, mycophenolate, azathioprine, cyclosporin, all the immune suppression drugs that we use. I recommend trying to keep the lymphocyte count above 500. So we've raced through mainly the JAKs, and we tried to think about where we're going to use them in the future and what that oral surveillance study meant. And like everything, when the new mechanism of action comes in, we're very excited. Then we start seeing a few side effects and we get very disillusioned. But eventually, we learn where to place these drugs so that they're most productive. And that'll take a little bit of time and for the dust to settle. Because we don't want to throw the baby out with the bathwater, but we don't want to spin it so that we're making excuses for important adverse events. So I thank you very much for your time. Thank you.
Thank you, Professor Nash, for this excellent talk. Now the floor is open for questions. So take from the audience, if any, and then from the online. So let me just start. Prof, why they included the 5 milligram dose also in their box warning, the FDA? We are familiar with 10 milligrams, so why they combined them?
Well, they looked at those preliminary results and they showed a difference in the incidence rates, and they decided to be conservative. I think they have been burnt in the past. The Vioxx thing burnt them. Some of the other things that happened with romosozumab, with some of the other drugs. So they're taking a very conservative approach. For example, in FDA, you can't get 4 milligrams baricitinib in the US, you have to use 2. So they have turned very conservative, and I think they were just being super careful.
Right, okay. Dr. Walid?
So I just thank you very much for a nice talk. In the US, they have Bari 1 milligram as well, and it seems to be effective.
I think that's the question: how effective?
If it comes to effectiveness and safety balancing, so will there be an age group specification for the dosing in the future?
Well, I think they've looked to see if you got less DVTs with 2 milligram Bari compared to 4, and there wasn't a difference. So in most of the TOFA, there's a dose response, 5 to 10. So you'd predict a lower dose might have less, but with Bari, they didn't see a dose response. So quite tricky to say that a lower dose is safer for you until they've done the work.
Thank you, Prof, for this nice talk. There's a recent paper in the Seminars of Arthritis recently published in December of 2021 about the risk of DVT with methotrexate. There was a 2 times fold when compared to hydroxychloroquine. So what's your thoughts about that?
2 times fall or 2 times increase?
2 times fold increase in the risk of DVTs with methotrexate versus hydroxychloroquine.
Well, one of the important studies came from Sweden, where they showed many of these risks are driven by disease activity. So methotrexate is superior in controlling disease activity to reduce risk, whereas Plaquenil may not be that as effective in controlling disease activity. So I think it is that controlling inflammation that changes the risk with one drug or the other. It is increased in rheumatoid by itself, and then it's modified by which medication you take. So I'm not aware of that particular paper, but it's driven, for example, lymphoma risk is clearly driven by disease activity more than the drug you treat the patient with. So I think the answer will be tied up in that rather than something to do with the medication itself.
So we are running out of time. There is just one question. We'll take one question from the virtual audience. would you advise high-risk patients to take aspirin if they are on JAK inhibitors?
Unfortunately, aspirin prevents arterial thrombosis and not venous thrombosis. And this issue is a DVT pulmonary emboli risk. So really the question is, do you ask the patient to take anticoagulants like warfarin or the newer agents or Clexane or one of those agents? And aspirin by itself shouldn't make a huge difference, but it does protect cardiovascular risk. And we have had a number of patients, difficult, rare patients, who have failed all other drugs except the JAKs, have a strong history of recurrent venous thrombosis, and they're treated with full anticoagulation and a JAK. But that's not a very common patient, but we have needed to do that in a few, even commencing the anticoagulation to guard against this small risk of venous thrombosis.
Okay, thank you, Prof. I think we are running out of time. Thank you very much for your excellent talk. Now we will go to our next speaker. Okay. So I would like to welcome Dr. Pooja Mehta. Dr. Mehta is a rheumatologist and is undertaking a basic science PhD in post-COVID interstitial lung disease at University College of London. Respiratory division. She's a strong opponent of cross-specialty walking and has wide clinical practice. Her main research interests are rheumatic-associated interstitial lung disease and immunotherapeutics. She has experience in drug development and the industry-academic interface, having designed a clinical trial in rheumatoid arthritis during a pharmaceutical industry fellowship and a background in academic hematology. She's a member of the COVID Euler Task Force and is current clinical chair of the Early Career Research Network Committee and member of the Athena Swan Committee at UCL. She supervises and teaches MCS and medical students at UCL and Imperial College. Please welcome Dr. Mehta. The floor is yours.
Thank you so much. Again, it's such a pleasure to be here. And today I'm going to be talking about vaccinations, which will be a very practical guide to vaccines. So a slightly different pace to the talk that I delivered yesterday. So these are my disclosures, none of which are relevant to what I'm talking about today. So in terms of an overview, I'm going to talk first about vaccine development and then vaccine responses in patients that we look after, the immune-mediated inflammatory diseases and the effects of our drugs, how we can try to optimize vaccine responses, the third primary doses as well as boosters, and current clinical challenges, drug pauses, should we be pausing immunomodulation, breakthrough infections, and adverse events and flares of rheumatic disease. And I'd be interested in your thoughts in the discussion. So we need to start by acknowledging that the pace of vaccine development for COVID-19 is one of the most remarkable achievements of modern medical science, hinged on a spirited collaboration between academia, the pharmaceutical industry, and public and private sectors. During COVID, there was a massive investment in technology and infrastructure to design and deliver vaccines on a global scale. And although it's been patchy with vaccine inequity, we mustn't forget that it has been such an incredible achievement. And the design and delivery was only possible due to pre-existing experience starting in 2005 with the SARS pandemic. So as a reminder, SARS-CoV-2 binds to the ACE, the angiotensin converting enzyme 2 receptor, which is in green in this diagram here, after activation of the spike protein by the transmembrane protease serine 2, which is in pink. The SARS-CoV-2 spike protein, demonstrated in this figure, is composed of two subunits. The S1 subunit, which spans here, has a receptor binding domain, the RBM, which is in red, that engages with a host cell ACE2 receptor. And the S2 subunit mediates fusion between the viral and host cell membranes. This is a summary of the vaccines, the sponsoring companies, the target protein and dosing regimens. And I just want to remind you that we have nucleic acid, mRNA, the Pfizer-BioNTech and Moderna, viral vector, which is the non-replicating adenovirus, AstraZeneca Oxford, and Janssen, which is the one and done. It's the only one where you only need one dose, and protein-based vaccines as well. So let's talk about our rheumatology patients who are at increased risk of severe COVID and mortality. Is that disease activity and or the drugs? We'll talk about that shortly. Variants emerging with prolonged infection due to our drugs and poor vaccine responses. So first of all, vaccine responses in patients with immune-mediated inflammatory disease. So this was a very nice EULAR systematic literature review, which included one of my colleagues, Pedro Machado, who's going to talk later. Now, in general, patients with rheumatic and musculoskeletal disease, it seems, according to EULAR, do not face an increased risk of contracting SARS-CoV-2, which was about 26 studies, or a worse prognosis with COVID-19 than individuals without rheumatic disease. And that's discordant to the Rheum COVID analysis, which I'm sure Pedro will talk about later. Something that's really important to bear in mind, that disease activity is associated with worse COVID prognosis, possibly explaining the increased risk seen with glucocorticoid use. And steroids greater than 10 milligrams per day may actually reflect confounding by indications of disease activity rather than the prednisolone dose itself. Undoubtedly, rituximab's B-cell depletion is associated with worse COVID-19 prognosis and possibly JAK inhibitors as well. Now, vaccination, which is what we're here to talk about. Vaccination in immune-mediated inflammatory disease is generally immunogenic, but the antibody responses are lower than in controls. And in this study on the right, we have the first graph showing antibody titer and the second neutralization. And most of the 133 participants, nearly 90%, and all 53 immunocompetent participants developed antibodies to the mRNA-based vaccine, although patients with chronic inflammatory diseases had a numerically lower titer of the anti-S IgG. Vaccine immunogenicity, it seems, therefore, is associated with immune responses, but it's lower in our patients. And finally, vaccine immunogenicity is negatively associated with older age, rituximab, and mycophenolate. So these are the big drugs to be aware of if your patients are on and we're giving them vaccines. So moving on to vaccine responses with immunosuppression. Before we talk about this, this is a really nice schematic, which was published in Nature Reviews Rheumatology just a couple of weeks ago. And protective responses generated by vaccination require sequential activation of several immune cells. So first of all, following delivery of the vaccine, the immunogen, dendritic cells activate CD4 positive T cells, which polarize into a number of cells, T helper subsets, including T follicular helper cells. And these soluble immunogens also activate naive B cells, which encounter TFH cells. And this interaction is critical to generate the germinal center response. And this generates a pool of mature B cells harboring a diverse array of B cell receptors with high affinity for the immunogen. And these mature B cells can then further differentiate into memory B cells or antibody secreting cells, the ASCs. And our immunosuppressive medications influence both T cell responses, B cell function, and antibody responses. And there are some in this green box that have no effect whatsoever, like hydroxychloroquine. You can see that B cell depleting therapies affect both the T cell responses and B cell responses, as well as the antibody responses. So they really are the most impactful. First of all, methotrexate, which is our anchor drug. It's the most commonly used DMARD. In two independent cohorts of patients with immune-mediated inflammatory disease, we have New York on the left and Erlangen on the right, methotrexate was associated with adversely affecting humoral and cellular immune responses to COVID vaccines, suggesting that we do need strategies to improve vaccine responses in methotrexate users. And these were standard doses that we use for all of our patients, so they were not particularly low. This study looked at anti-SARS-CoV-2, the spike antibody titer. So these are the graphs on the left, the antibody titer, and then neutralization on the right, to assess humoral responses after vaccination. The first column in each of the graphs is the immunocompetent patients, followed by the CIDs, which are chronic inflammatory disease without the drug, and then CID with the drug. So the top left is prednisolone, and then we have our standard TNF inhibitors, JAK inhibitors, and B-cell depletion. And essentially, anti-S IgG antibody titers after vaccination in participants with chronic inflammatory diseases were lower in patients receiving glucocorticoids and B-cell depletion. The measures of immunogenicity differed numerically between those who were receiving TNF inhibitors and JAK kinase inhibitors, but the 95% confidence intervals were wide and overlapped. And therefore, in summary, compared with non-users, patients with chronic inflammatory diseases treated with glucocorticoids and B-cell depletion seemed to have both lower SARS-CoV-2 vaccine-induced antibody responses and neutralization capacity. So we know that B-cell depletion results in almost complete B-cell depletion, but what about T-cell effects with patients receiving anti-CD20 B-cell depleters? In this study, they looked at patients with multiple sclerosis, and healthy volunteers are seen in gray, and the patients with multiple sclerosis in mustard. And they had a vaccine dose at T1 and then again at T3. Now, the vaccine responses are impaired in patients with B-cell depletion, 50% response by at least 30 days, which is T5, and treatment with B-cell depletion resulted in significantly reduced spike-specific and receptor binding domain-specific antibodies. But by contrast, in patients with multiple sclerosis treated with anti-CD20, they generated CD4 and CD8 T-cell responses after vaccination. But treatment with anti-CD20 resulted in skewed responses, so it compromised circulating follicular helper T cells and responses, augmenting CD8 T cell induction, whilst preserving Th1 responses, cell priming. So to summarize, T cell responses may be preserved, but they may not be protective. So it isn't as straightforward as saying, whilst we may wipe out the B cells, preserve the T cells, that's okay. So there's still a lot of work to be done. However, T cell responses seem to be preserved, but functionally abnormal. So how can we improve these vaccine responses? I want to focus on third primary doses and then boosters after that. So here, we're going to look at COVID vaccine responses and the potential effects of immunosuppression. And each data point is a participant, and the solid lines, which you can see across the data points, show the group median. And the top graph is first vaccination without previous SARS-CoV-2 infection. So these patients had not had a previous infection, but had had a vaccine. And then the second graph is second vaccination in the same patients. So patients treated with methotrexate, that is the fourth group that I'm pointing to here in purple, and anti-CD20 therapy, that's the penultimate, so that's this group here, had significantly lower seroconversion rates than healthy controls, which is the first column. But patients on TNF inhibitors in green and patients on prednisolone monotherapy, that's right at the end, did not have an impaired immunosuppression therapy, and seroconversion rates were numerically lower in all groups compared with healthy controls. After a second COVID-19 vaccination, seroconversion was seen in the majority of patients in controls, and these rates were predefined groups, except for patients on anti-CD20 therapies. Only 3, that's 43%, were seropositive. So it seems that second or repeated exposure to either SARS-CoV-2, which I've not shown here, the actual infection, or vaccination, does improve humoral immunity in patients treated with immunosuppression. So our patients should not have a delayed of the second dose COVID vaccine. And this was a strategy that I'm not sure whether it was employed here in the UAE, but was employed in the UK, where vaccine doses were spaced out and different to the randomized controlled trials. And then because of data, we then reduced it back to in our patients with immune-mediated inflammatory diseases, and the data does support this. So what about a third vaccine dose? Here we have the CDC data, and vaccine efficacy in patients without immunocompromising conditions, so our healthy controls, improved from 82% to 97% with a third dose. And then if we look at patients with immunocompromising conditions, they had a 69% response after the second, which rose to 88%. And this supports giving our patients a third primary dose. In the UK, we also had estimates of vaccine effectiveness after hospitalization, against hospitalization with the third doses. And you can see that after 2 doses, you have waning immunity. And then with a third dose, we have improved protection. And this was either Pfizer or Moderna as using this booster. And therefore, decreasing effectiveness is therefore regained after the third dose, and efficacy rises. And this then supported giving third doses, which we're doing now in the UK. But this is very confusing for patients as well as physicians in terms of who to give the third primary to. And I was part of the EULAR COVID-19 task force, and we produced a guidance for patients, which was recently published in the Annals of Rheumatic Disease. It was led by one of my colleagues, Hans Bilsma. And here is a summary table of who to give the third vaccine dose for. And you can see that rituximab, mycophenolate, we advise the third vaccine dose. Prednisolone, if you have a prolonged period of greater than 10 milligrams. And methotrexate, there's no data, but we suggested giving this above a methotrexate dose of 20 milligrams weekly. The others, nearly all of them do advocate a third vaccine dose, abatacept, JAK inhibitors, not azathioprine, but maybe if the dose exceeds 2 mg per kg per day. Cyclophosphamide, yes, and leflunomide if the dose is high, so greater than 20 milligrams. But I must say that the majority of these guidance is eminence or consensus-based rather than evidence-based. So what are our current clinical challenges and what are we doing in clinical practice? The first thing I want to cover is pausing immunosuppression. So right at the beginning of the pandemic, we wondered whether we should be pausing methotrexate doses based on data that we had from influenza vaccine. And I published this paper here, summarizing the state of play with influenza. And this focused on methotrexate strategies. The first study I put in this table here, these 4 strategies. This was the control group, the methotrexate continue. Methotrexate holding 4 weeks before the influenza vaccine, holding 2 weeks before and 2 weeks after, and then methotrexate holding 4 weeks after. And this group found that the best strategy to optimize vaccine responses was the methotrexate hold 2 weeks before and 2 weeks after. And in a post hoc analysis, they showed that the short-term discontinuation of methotrexate 2 weeks was safe, but discontinuation for 4 weeks resulted in increased rheumatic flares of the RA. So therefore, in the second study, they took forward the strategy of withholding for 2 weeks after the influenza vaccine. And they showed that the influenza seroconversion was higher and flares were not increased. So we had suggested at that time that perhaps with respect to COVID vaccine translation, we should potentially withhold methotrexate for 2 weeks after the vaccine. Very recently, the American College of Rheumatology created guidance for what to do with drugs regarding the COVID vaccination. And this was born out of necessity because of a lot of physicians in clinical practice holding immunosuppression with variable strategies. And although some of the guidance is intuitive, some is counterintuitive as well. And this has had a lot of debate as to whether this is appropriate and reasonable. But we have to commend our colleagues that they created this guidance out of necessity with a paucity of data, and therefore this was appropriate. We also did the same with EULAR that I'll show you shortly. But before I show you the EULAR vaccination and management recommendations, This was published just, I think, 4 days ago. So this is very hot off the press and very, very relevant to what I've just mentioned. So I just threw in this slide here. Now, this study looked at exactly what I was talking about, which was pausing methotrexate for 2 weeks after the COVID vaccine. And here they showed that, yes, there was increased seroconversion for the COVID vaccine, but it was associated with increased disease flares. Now, this has made us pause in terms of what we're supposed to do, but the only thing that I would contend with respect to translating this to clinical practice is that this was a primary vaccine series, and the interval between the two vaccines was short, and therefore the strategy of pausing is probably appropriate for the booster vaccines, where you've had a longer interval, at least 3 months, between the third primary and the booster. And in practice, it's far longer, and usually patients in the UK have had about 6 months in terms of the third primary vaccine series and then the booster. And so hopefully this increased disease flares will not be seen with the booster vaccine. So although this is really important data, right now we're in the state of play where most people have had the third primary series, so perhaps this isn't as clinically relevant as where we are right now. So this was the EULAR COVID-19 Task Force publication that we recently published just a couple of weeks ago. And I direct you to this. They have a 10-point plan, and the pausing is loosely outlined in this paper here. But this really is a clinical decision in terms of your individualized patients. I'm not going to say any more than that. What about breakthrough infections? Now, the CDC define a breakthrough as a positive COVID test at least 14 days after the initial vaccine series. And remember, the initial vaccine series is now 3, so 1, 2, and then a third vaccine. And this is an emerging problem because of Omicron and also reduced COVID restrictions. We're now, majority of us, unmasking, and also in the UK, they've completely dropped all COVID vaccine restrictions. And if someone has a positive COVID test, they do not need to self-isolate, which is absolutely ludicrous, but it's frightening for our immune-compromised patients that will be circulating with people with positive tests that do not need to isolate. So this, again, very hot data was just published a few weeks ago, was a study from India, and they tested antibody titers 4 weeks after 2 doses of the vaccine. They had 600 patients in their study, and at 5-month follow-up, 7% had breakthrough infection, and this was majority Delta wave. And having no detectable post-vaccine antibody titers, so remember that's 4 weeks after the second vaccine, predicted the risk of having a symptomatic breakthrough infection. So this calls into question about whether we should be measuring post-vaccine antibody titer. And in the UK, we're not measuring this, and I wonder what you're doing here. And I think my own feeling has changed in terms of, at the beginning, we thought we were measuring them. We didn't really know what to do with them. We weren't actually acting upon any of the results we were getting. But given this paper, maybe we should be, and at least collecting the data to then decide what to do. This is another study looking at breakthrough infections, and here they had a slightly different definition. So they defined breakthrough infections at least 7 days after the second vaccine, and these patients had to be hospitalized. So in 150 patients, 25% that had the breakthrough infection had poor outcomes. Mortality was high, 22%, but the majority of these patients had comorbidities, 95%. And of those, 40% were immunocompromised. And risks for poor outcomes were having a higher viral load, B-cell depletion therapies, that's a unique unifying theme, and having a low titer anti-spike IgG was not statistically significant, but was numerically different. Vaccine-related adverse events are something that we've all seen, and rheumatic disease flares are something that we need to warn our patients about, but also discussing the benefit risk. And of course, the benefit of being vaccinated and protecting our patients from COVID, I think, outweighs the risk. In terms of the data, the literature, apart from our anecdotal experience, the literature shows that self-reported flares are higher in patients with rheumatic-mediated disease, but medically confirmed flares are lower. So in this study, we had about 20% of 1,000 patients having a self-reported flare, 20% after the first dose, 43% after second dose, and a third after both doses. Lower in 11% of 1,300 patients. And then with respect to lupus, so these two were inflammatory arthritis, and the last was lupus. 3% of the N of 696 and nearly 700 had a medically confirmed flare. And the only thing I wanted to just mention with respect to self-reported flares, it's important to tease out whether patients have an expected arthralgia after a COVID vaccine rather than a true rheumatic disease flare and synovitis. And sometimes it's quite difficult to tell. So I'm not sure about any of you, but when I had a COVID vaccine, I was really ill for about a week with quite significant joint pain. So it's always important to warn our patients that actually having a COVID vaccine may induce arthralgia that may not be their rheumatic disease that warrants an increase in immunosuppression like prednisolone, which may dampen the vaccine response. So to summarize, COVID vaccination in patients with rheumatic diseases, we have a generally immunogenic response, although the antibody responses are lower than controls. The immunity after 2 vaccines wanes, and therefore a third primary in that series is important, and giving boosters as well. And generally, COVID vaccination is safe and well tolerated. Vaccine immunogenicity is reduced with older age, and particularly B-cell depletion and mycophenolate. Now, there's still a lot more to learn, and in terms of future directions and unanswered questions, it's not clear about the role of T cells in B-cell depletion. I've shown you that we have preservation of T cells, but the function may be impaired. What do we do about pausing immunomodulation, methotrexate, particularly 2 weeks post-vaccination? We think that this definitely improves seroconversion of the vaccine, but does it compromise disease activity? And does it destabilize disease control that may warrant an increase in immunosuppression, and therefore may that compromise the vaccine response? So it's a catch-22. And there's lots that I have not covered that is beyond the scope of this, but there's strategies going on with respect to mixing the vaccine response, the vaccine doses. So giving a mRNA vaccine followed by a different type of vaccine, does that actually improve vaccine responses? Varying the route. So there are studies ongoing with respect to inhaled vaccines and the intervals between the vaccine. Improving vaccine seroconversion may depend on the interval between the 2 vaccines, and almost certainly patients are going to require boosters in the future. And what do we need to do in terms of our immunomodulation and intervals? We don't yet know. So I'd just like to end there and thank you for your attention. Very happy to answer any questions. Not very well. I think the microphone's not working.
Okay, I think it's working. Thank you for that talk. I just was wondering about your thoughts on Evusheld, which is authorized in the US and in the UAE also for prophylaxis for COVID, and whether it is something that you do in your practice and what your general thoughts are.
Yes, it's a very good point. So Evusheld we do use in the UK, and as you say, in the UAE as well. And this has been a huge advance in how we managed COVID. And I've seen anecdotally very good responses with respect to prophylaxis. But I fear that the guidelines are now going to change shortly in the UK with respect to where we can use Evusheld. I'm not sure if that's still the case here. It definitely, particularly with patients with B-cell depletion, so rituximab, has a a big role. With respect to the others, I'm not as convinced, but definitely B-cell depletion. And the cohort that we worry about the most is rituximab. And where I work at UCL, we have a massive cohort of patients with rituximab. So we do use Evusheld quite a lot and have had good outcomes.
Would you recommend or would you use this on a patient with cyclophosphamide therapy? I know this may not come from data, but just what you would do in your experience.
Yeah, so that's a good question. And again, this is not data driven. I have a big cohort of patients with interstitial lung disease, with rheumatic associated interstitial lung disease, who have been treated with both rituximab and cyclophosphamide at some point because of their ILD. And in those patients, I am using Evusheld, but the rationale is more based on the rituximab than the cyclophosphamide. So with respect to your question, if a patient was just given cyclophosphamide, I think depending on comorbidity, so if they were older, if they'd had MMF as well, then I would want to give Evusheld because of the combination of the cyclo, the age, and the MMF.
Thank you.
Thank you very much for the interesting lecture. I do concur with your data because we do have similar data about the vaccination response in our autoimmune disease in Qatar. So specifically with rituximab, so we did not see any response post third dose in our population. And now we are coming and asking our population, specifically, if you go to the US now, they are giving the 4th dose for the immune suppressed patient. So are we gonna ask them to take also the 4th dose, our rituximab patient that we knew that there is no much response for them and the seroconversion is very, very low actually. So, so are we gonna give them something different? Are we looking for monoclonal antibodies to be given for those population, or we still ask them to take the vaccine as per also sometimes government regulation? So there is a lot of like issues around our rituximab patient, though even if the rituximab dose was not given 8 or 6 months ahead.
Yes, it's a very, very good question. Rituximab is our biggest challenge with respect to vaccines. There's no doubt about that. Is my microphone on? Yes. And you're right that the vaccine response is very low post-rituximab. In the UK, we have the authorization to give them the 3rd primary vaccine series and a booster. So the 4th is described as a booster. It's not part of the 3rd. It's not part of the primary vaccine series. And that's what we can do. So we're not allowed to give anything else. What we can try to do is time the rituximab, which I'm sure is what you're doing as well, to try and optimize. Whether it works or not, I don't think, it depends if we can increase the interval to a point where it could work, depending on what their indication for the rituximab is. So if it's RA, it's a little easier. If it is a life-threatening condition like ankylosing, then obviously difficult. We are also trying to switch our patients from rituximab to other biologics, like abatacept is mainly the one that we go to, which itself may have problems. And the data is probably the most limited with all of our biologics. And we are actually collecting that locally. And I'm sure other groups will do the same. So either try, when you first select a biologic, try not to select rituximab. If they're on rituximab, try to switch them to something else. If it's not possible, then optimize the interval. And maybe, as we say, with all of the COVID data, it's a rapidly moving field. And one of my colleagues describes it as building a plane as it's going down. So in time, with all the data that, as you described, such low vaccine responses, then maybe that 4th dose specifically for rituximab patients may be incorporated in. I don't know. I really don't know what the answer is. Rituximab is a massive challenge, which is why we're now trying to see T-cell responses. Could that be more reassuring with respect to protection from COVID? So even if you don't see the antibody, could the T cells be helping? It's just unclear. So I don't have a good answer to that other than try other things. And if you are able to give the 4th in the UAE, if it was me, I'd probably want that. So for myself and also my patients, and that's what I would suggest.
I got very important, lots of questions. But yes, thanks, Pooja, for the very interesting presentation. You know, you emphasized on mycophenolate and how it can suppress the B cells and can affect, and that's what we expected. But there's no clear recommendation about how should we stop it? Should we hold it for how long? And as we are just allowed for one question, I'm going to add depot, which is commonly used drug. And would you give, how much time span you would give after depot before you give the vaccine?
Yes, so this is difficult. With respect to mycophenolate, there is no good strategy in terms of pausing the immunomodulation prior to or after the vaccine. With methotrexate, we have had lots of different things that we have seen in the data, as well as what we're doing in clinical practice. In practice right now, although we know that mycophenolate does impede vaccine responses, we're not pausing mycophenolate in our lupus patients, mainly is where we give mycophenolate, and also in my ILD patients. So we're not doing that, and I'm not sure what you're doing here. And your second part of the question was?
Time span after depamedrone.
Yes, depamedrone. So depamedrone, we've tried to avoid as much as we can in COVID because of the fact that so we've replaced depamedrones for flares of RA, for example, with oral prednisolone doses because of the fact that we could stop it and it would wash out faster, whereas once you give a depot, it's in for, we say, at least 3 months. There is no good data, as far as I'm aware, about depamedrones prior to vaccine responses. And the only thing I would try to suggest is that controlling disease activity is the most important in terms of optimizing vaccine response, as well as reducing the need for immunosuppression after a vaccine if it causes a flare. So it's really just about timing the vaccine in a state of disease quiescence. With respect to a time frame, which is really what you were asking, I can't give you a specific time frame because there's just no data. So unfortunately, I can't give you a good answer with respect to when, but I would really try to use oral prednisolone rather than a depot if you can. I'm not sure what your experience has been.
Yeah.
Thank you very much.
Thank you very much. The next talk will be by Professor Convergence, and it will be actually combined sessions, so this session and the next session. So we can start to introduce our speaker. He's the head of hematology at the Professor of Medicine and Hematology at the Royal University of Germany. He studied human medicine at the University of Montreal and Germany. Professor Barales received his official board degrees in orthopedic in 2007 and internal medicine and rheumatology in 2014. Among the best tuberculosis, won the award in 2005.
I can use this one.
Yeah.
This one? Yeah. Yeah, you can use that one.
He holds membership in the authority for research within society. Also, associated with the number of million these 100 plus.
Yes, thank you very much. No, it's not. I appeared all of a sudden. No, I'm here and I'm happy to be here indeed and be able to see people in person again. And thank you for the introduction. So I will try to do you a favor and keep it shorter as we're running out of time, since 2 sessions in one is also a little bit tough to follow. And what I have done was to indeed put all this information that is being mentioned in the title together based on different abstracts from the ACR, as also the title says. So you will see a little bit of everything. I've also put 1 or 2 abstracts from EULAR last year, in here because I think that thematically they fit very well into that. And I will then start with that. So that's the agenda. I will speak about the diagnosis, the clinical information that we have, how we collect clinical information and what it means for the patients. And of course, then there will be a lot of things about treatment, how to use treatment, are there any new treatment modalities, and how this fits to the diagnostic paradigm. Now, starting with the diagnosis, by the way, the first couple of slides, it's many of the things that we have published, but it will certainly not be a presentation that I will be giving based on our data only. And one thing that I would like to start with chronologically, obviously, is by speaking about whether or not, once we do have the diagnosis, patients with axial spondyloarthritis, but also those with psoriatic arthritis, may be dealing with issues of disease activity that may have nothing to do with their disease. So by the way, the slides are similarly being put together. You have also the number of the slide of the presentation at the ACR in the upper left part, and then the title and the first author. So again, we have patients with rheumatic musculoskeletal diseases, especially in the spondyloarthritis field, but we also have fibromyalgia, and we also know that these three diagnoses may overlap. And the question is whether or not fibromyalgia, that we at least ourselves see a lot in daily practice, and patients with spondyloarthritis and secondary fibromyalgia may have an issue in terms of having higher disease activity. And this is what we try to study. We consecutively recruited patients with their respective diagnose, and we also try to find out if there is a secondary fibromyalgia based on diagnostic criteria, the ACR criteria, or not. And we also had primary fibromyalgia patients to compare with. We did all the clinical studies or the clinical assessments that we know that we are using in spondyloarthritis, and also try to assess enthesitis in both diseases. Axial spondyloarthritis and PSA plus and minus means with or without secondary fibromyalgia. Now, this is what we obtained on patients. We had 300 patients altogether, 100 in each group. And you see here that at least when it comes to the age, there is not a huge difference, at least when we compare the mean ages. There might be some significant ones. When you see a p-value, this is the comparison to the fibromyalgia group. However, I would say all these patients that we were able to obtain were certainly older than what the usual, at least spondyloarthritis, axial spondyloarthritis cohort may contain. Otherwise, we of course had patients with or without high CRP, similarly to what we would expect to see in a daily practice, both for axial spondyloarthritis and psoriatic arthritis. And now to the, at least to me, more interesting part of the study, the outcomes. So you see here on the left side, the clinical outcomes, the BASTAI, the question number 1 of the BASTAI for fatigue, ASTAS, BASFI, DAPSA for PSA, fibromyalgia impact questionnaire, the Leeds Enthesitis Index, MASES, and SPARC for enthesitis as well. And what I've put here in red are the patients with a primary diagnosis of axial or peripheral disease without secondary fibromyalgia. And you see that actually almost all, with one exception, p-values as compared to the primary fibromyalgia group are significant, and they are significantly lower. On the other hand, those patients with fibromyalgia or those with axial spondyloarthritis or psoriatic arthritis and secondary fibromyalgia had a higher disease activity and higher scores in all the domains that we assessed. Obviously, adding fibromyalgia secondary or even giving the questionnaires to FM patients primarily leads to higher scores. So altogether, and again, this will be more or less the design of all the future slides that I will be showing you. Very shortly, the conclusion. We need to take care of how we interpret these questionnaires, especially when it comes to secondary fibromyalgia that may occur in long-standing patients, as I showed you, who are a little bit older, especially. This means longer disease duration in axial spondyloarthritis and PSA. The only questionnaire that was able to really capture and obviously significantly differentiate from fibromyalgia, yes or no, to axial spondyloarthritis was asked as CRP. And also something that I didn't show you in the details, the duration, not the severity, but the duration of morning stiffness. This is question number 6 of the BASTI. So obviously, if we want to assess disease activity more properly, this would be one of the ways to do so. Again, another abstract that we presented, and this has to do with the diagnosis. We tried to assess, based on all the information that we had, the images of patients with axial spondyloarthritis, and especially assess or answer the question on whether or not those lesions that we call inflammatory and post-inflammatory, although we don't know if it is inflammation, it is rather bone marrow edema, are similarly seen in patients with spondyloarthritis and patients with chronic back pain, but with no spondyloarthritis. And we know very well that there is a high prevalence of inflammatory lesions, especially in the general populations who have no disease. Now, obviously, we did not want to repeat what is in the literature here, but what we also did was to take the sacroiliac joints of the patients with SPA or no SPA, blind them completely, give them to expert readers, and then subdivide the results also based on age decades. This means patients below 29 years, 30 to 39 years, 40 to 49 years, or beyond 15. Obviously, taking into account that these findings may also occur more frequently, especially the degenerative ones or the chronic ones, in patients with higher age. This is what we found. We had 309 patients, 175 with axial spondyloarthritis, 134 with no spondyloarthritis, but still similarly chronic back pain. On the left, you see the age decade group, as I mentioned before. In the second column is the diagnosis. The p-value shows the comparison within the diagnosis. And then on the right side, on the right 3 columns, you see the numbers of quadrants of the sacroiliac joints that had bone marrow edema, fat lesions, or erosion. We took the number of quadrants per SIJ. This means each patient has 2 sacroiliac joints. 4 quadrants, this means 8 lesions that each patient would be having. Because we didn't want to only know if a patient is positive, yes or no, but also wanted to know the amount of these lesions in general. Because we know that the more we have of these lesions, the more maybe we may think when we interpret the image that this is spondyloarthritis. And it's interesting to see in the bone marrow edema column, I hope I can find it here, and in the erosion column here. In all cases and in all age decades, patients with spondyloarthritis had significantly higher lesions or amounts of lesions. In the fat lesions, which we all know and you've heard from me as well and from other speakers in the last couple of years, where we believe that fat lesions are typical for spondyloarthritis, it seems to be that there was no difference between patients with AxSpA and non-SPA, with exception the higher aged group. This means beyond 50 years of age, which obviously means that at least the amount of lesions that we find, even in people with chronic back pain without spondyloarthritis, does not differentiate diagnostically when we use fat lesions for taking this, for making this differentiation. Bone marrow edema doesn't differentiate, and erosions differentiate as well. What we also did was to take now into account the patients themselves, and not quadrants, but patients. It's a little bit complicated to read this slide, but I will try to guide you through. The solid bars are always spondyloarthritis. The less dark bars are non-spondyloarthritis. It's the same for all of these findings. Here we have bone marrow edema, fat, erosions, and sclerosis and ankylosis. Sorry, here, bone marrow edema, fat, sclerosis, erosion, sclerosis, and ankylosis. And here are the 4 different age groups. So what you see, in order to clarify it a little bit better in your eyes, I would always look at the line that is being drawn here, between the blue lines, between the black lines, the green lines, the gray lines, and the purple lines. Altogether, what we see is that also in the number of patients being affected, there is no big difference in the black lines, which is fat. Whereas the other lines do show a difference between spondyloarthritis or no spondyloarthritis. However, and that's one of the important things that we believe is being shown by this study, although there are some lesions that can differentiate between spondyloarthritis or non-SPA, still we have a high prevalence of all of these lesions in non-SPA patients. So the sole finding of bone marrow edema, of erosion, of fat, does not tell you that there is spondyloarthritis. We need to take into account the age of the patient, and obviously also the frequency of these lesions within one patient. Bone marrow edema and erosions are doing the job, and they are differentiating better to spondyloarthritis. But if I have a patient in front of me, just one patient, I don't have a comparison to another one. Therefore, please take into account that all of these findings that we report frequently also occur, especially with higher age in non-SPA patients. Now, what about clinical information? How we assess it? Does it make any sense to assess it? Is there any correlation to function? And what is maybe the conclusion of what we're doing every day? I'm citing a work that was also done by a colleague of ours, where she tried to find whether or not, based on a large proportion or a large number of patients with early spondyloarthritis from the Desir cohort, I will show you the characteristics later, all of those health issues that we are taking into account, and I will also list them in a second, are able to explain themselves. This means, can you explain functional impairment by high disease activity? Can you explain comorbidities by high age, and vice versa in spondyloarthritis? There was a modeling that was done in these patients, and what was done was to use all the data from the Desir cohort, which is a cohort of patients with short symptom duration of spondyloarthritis, take all those data that we were having available and put them in a network modeling in order to make them visible in a figure. So altogether, almost 400 patients were included. You see here the proportion of patients who are males with the mean age, the symptom duration, and so on. Altogether, we can say that this is a typical cohort of patients with early SPA. And in one slide only, this is the main result of it. What was able to be done in those 400 patients was to make the connections between all of these parameters that obviously seemed to play a role in terms of what is connected or interconnected with what. For example, what came out was that indeed disease activity by the ASDAS is directly influencing BAS-Phi, functional impairment, which is directly influencing mobility impairment. Functional impairment and mobility impairment are different. But you cannot say that a patient with high ASDAS cannot move properly or cannot move much. You can say that if disease activity, for example, is high, then the person who is suffering cannot do the movements properly. But it doesn't mean that he or she may have, for example, impaired chest expansion. We also have seen that BAS-Phi especially implies directly or has a direct influence on ASDAS health index, and this might be influencing the after comorbidity. So if you have this activity, then you get sicker. It's not that you are sick already with comorbidities and then you have higher disease activity and so on. Now this is important because obviously we are now starting to understand the disease better, and maybe by that we're able to intervene specifically to the individual patients when they are, for example, older or younger, when they are higher, have higher BMI or not, when they have high or not BASFI, and so on. So we have a hierarchical order. What is coming one after the other? And this is the important thing of this study. One other thing that I believe was interesting, and this was shown at Euler, partly also at ACR, but I'm using the Euler data here, was the differences between gender in terms of PROs, patient-reported outcomes, and especially when it comes to BASDAI. So we know that overall female patients have higher mean values in all those PROs as compared to male patients. And we also know that female patients may respond differently to biologics as compared to males. This means lesser response. So what was done was to take about 860 patients with axial spondyloarthritis. 25% of them were females, 75 were males, as a typical cohort would look like, and evaluate all the BASDAI, BASMI, BASFI, HAC, and so on. So all of this was taken into account. The comparison showed some interesting results, and I will go into the BASDAI details in a while hereafter. But if you see, looking at, for example, the delay of diagnosis, there was no significant difference between males and females. And this is important because we know that delay of diagnosis per se leads to high disease activity overall as a mean value, but also functional and mobility impairment. However, there were more males with radiographic sacroiliitis, and more males, or the mean values of BASMI were higher in males. On the other hand, BASDAI was higher in females, and this was the same throughout all the BASDAI questions. And if you look at BASDAI specifically, green is females, blue is males. Constantly for all questions, and I showed you the p-values before, females were higher. Now, what was also done was also to ask the patients, what for you is the most severe question? What impacts you the most? And you see that at least when it comes to the least severe to the most severe, those four last ones were the same. But females, when it comes to the most severe, rated fatigue as worse, and males rated spinal pain as worse. And you will see that I will use this data later to explain a couple of other differences between males and females responses. So altogether, it seems that when we evaluate the BASDAI, let's say a BASDAI of 0.55 or a 6 is not the same for a female and for a male patient. They do evaluate, females and males evaluate things differently. What the reason for that is, I cannot tell you, but it seems to be that there is obviously differences here. And especially when it comes to fatigue, females seem to suffer higher and rate this higher, and maybe also scale it higher on the questionnaire as compared to males. And back pain, the last questions of the BASDAI, they are the biggest issue for males. Now, let's go to the larger part of this data, which is about treatment. I will speak first of all about the known modes of action, and then go thereafter into others and how to use them. One thing that was, at least for me, of interest was whether or not we should be using the drugs that we are using. And I'm just taking one drug here as an example. It doesn't have to be certolizumab or an IL-17 inhibitor or whatever. It's not about the the topic. It's not about the compound itself. It's about altogether the biologic DMARD treatment. So we know that TNF blockers, for example, here in the C-optimized trial, TNF blockers, they work very well in spondyloarthritis. Now, what the investigators did here was to see whether or not after having reached remission, we would be able to, and having reached remission for longer times, this means a couple of years, we would be able to then either continue and compare with a reduced dose the outcomes of the patients, again, after 3 years of being in sustained remission, or again, stop the treatment, although we know that stopping the treatment is not an option. And this was followed up, or the patients were followed up for up to 2 years. These are the data that they have obtained when it came to ASTAS, BASTA, CRP, and also they took fecal calprotectin as a more systemic inflammatory parameter. In gray, you see the patients on placebo. This means those who stopped the treatment. In blue, you see the patients who either continued in full dose or reduced the dose by half. And throughout all the outcomes, especially when it comes to BASTA and ASTAS and also a little bit CRP, I believe two things were important to see and were found. First of all, stopping the treatment again is not an option. It increases the values relatively fast, and patients indeed suffer more, although they were able to continue in the study. And you have many more fluctuations of disease activity. Whereas obviously it makes sense to continue the drugs even, and that's the important thing, even in a reduced dose. So reducing the dose is an option, but stopping is not. The other thing that they also investigated and they found, and this is one of the conclusions, was that yes, patients who stopped the drug, so this means they were randomized to placebo, they had numerically higher findings, BASTA, ASTAS, and so on. They had also fluctuations, but they did not worsen significantly. This means, obviously, if we have patients treated early and we have them long time on remission, it might be possible at some point to at least stop for a while or reduce it that much the dose so that patients do obviously get lesser and lesser. And this, for example, is of interest looking at the data when looking at the previous presentation, the data on whether or not vaccination may play a role and whether or not the TNF blocker or other modes of actions of biologics may influence antibody response or vaccination response. Now going to more new mode of actions, we had the data from the bimekizumab trial. It's a new monoclonal antibody that was at least very recently got the approval in EMA, and I don't know how the situation will be here, but you will certainly see that very soon. It's a monoclonal antibody against IL-17 and A and F. This is a mistake here, it should be an F. This means we have a blockade of 2 domains of IL-17. And what was done here was to go beyond clinical efficacy and see what quality of life of patients with axial spondyloarthritis, how it looks like. So it's a relatively easy study to explain. We had a 12-week double-blind control period. Then thereafter, the approved dose of bimekizumab, 160 milligrams, was then given, or the double dose, which is not finally approved, every 4 weeks. And thereafter, patients went into a 160 milligrams every 4 weeks after 48 weeks of treatment. Now, what you see is the data from the different outcomes. This means AS-QOL. This is the PAS here, the physical component of SF-36, the mental component of SF-36 is a little bit small for me to see this on the slide here in front of me. Overall, the lines, the solid lines and the dark lines and the dark lines, the light lines, show the data from the either non-responder imputation or of the observed information. And you see that indeed, also beyond this is activity response, also the quality of life outcomes respond very well and behave very well, obviously showing that indeed we are able here to have one more biologic DMARD coming to place, especially now blocking IL-17A and F may be of interest in some patients who have not responded to the previous treatment so far. So we need to understand why A or F may be playing a role. Another thing that, again, I believe is important, especially when we talk about IL-17 inhibition, was the differences between gender and the responses here. And I showed you before the differences in BASTA interpretation and in other outcomes between males and females. So this is the study with ixekizumab over 52 weeks, where patients received either placebo for a couple of weeks and thereafter changed to ixekizumab, or they went on and received the drug immediately. Almost 380 patients were included. Here you see the group with ixekizumab, which was divided in males and females, and the control group with placebos doing the same thing. And then the evaluation of the treatment was based on gender. The interesting thing was looking at the ASAS 40 responses at week 16, placebo control, and at week 52, both for non-radiographic in the upper part and for radiographic in the lower part of the slide. And if you look at the numbers and the response rates, you will see a difference between this group and that group. These are the females and the males, the females and the males. At week 16, the plateau was reached already in males, and it continued up to week 52, both for non-radiographic and for radiographic. Here we even had a slight decrease. On the other hand, for the females, there was a huge improvement over time, and week 16 was not enough to reach the plateau or the ceiling. So obviously what it means is that, as I mentioned also before, females may suffer more and with higher severity on specific findings of axial spondyloarthritis, including fatigue, as I mentioned earlier. It seems to be that in the long term, both males and females respond similarly to IL-17 inhibition, but obviously females need longer to reach the peak. And what that means, of course, that's important for us in daily practice to know if or not we should reevaluate or maybe even change treatment in females earlier as compared to males. What we also did, and this was also shown at ACR, was to take patients with axial spondyloarthritis and with psoriatic arthritis and compare them upon escalation of treatment here with upadacitinib, again, as a proxy for any drug that goes beyond NSAIDs or methotrexate now, biologic DMARDs, JAK inhibitors, I would put that together. We know that those two diagnoses have overlapped in symptoms, and we know that we have drugs, and that's the interesting part. We know that we have drugs that are approved for both indications. So what we did here was to take more than 2,000 patients, those with PSA and those with axial spondyloarthritis or ankylosing spondylitis. And those with PSA, they had axial involvement or without. And those with ankylosing spondylitis had peripheral involvement or without. And we did a subgroup analysis. And the final result is very clear. If we have patients who obviously have either PSA with axial or without axial involvement, or ankylosing spondylitis with peripheral or without peripheral involvement, and look at the ASDAS here, ASDAS low disease activity or inactive disease, there is in fact no difference in response in these two outcomes. The main essence of this is that very clearly, if we have a drug that is approved for both indications, it can be used safely and well in both indications and similarly. This seems to be that we may go back to the fact that one size fits all. And if we have any kind of drug that really is indicated for both diagnoses, obviously it makes sense also to use it more or less independent of the primary diagnosis. Now, there have been also new compounds that were presented or shown, and I'm showing you what may come to us in the future, maybe not so much in the near future, but in the future, in the next couple of years. And this is something that we see happening more and more. The companies especially seem to concentrate on small molecules. Now, this is one new approach of how to treat inflammation, especially in axial spondyloarthritis and psoriatic arthritis, which is a kinase inhibition. I'm not going into the details about how exactly this naming was done, but what you see here is the principle that this company has put together, blocking MK2, which is a kinase intracellularly. By doing so, the stabilization of mRNA of all the cytokines that we know that are acting inflammatory in spondyloarthritis would be disturbed. So the destabilization of the mRNA would obviously lead, intracellularly, would lead to less inflammation. What they did, this is a phase 1 study, but I think it's interesting to see what happens in these studies already. They took 37 healthy adults who had different ranges of the kinase inhibitor. Over 14 days, they were treated with 1 tablet per day, and they checked for the safety, tolerability, but also the pharmacokinetics, and also the inflammatory cytokines in the blood. On the upper left part, you see the TNF values in the blood, here IL-6, and here IL-17. And you see that indeed, in those patients who were not getting the kinase inhibitor, we had stable blood levels as compared to those who did get it in different doses, which obviously means that indeed a dose ranging would not work, at least not in that kinase inhibitor, but it seems to be a rationale to at least intracellularly block the mRNA of these inflammatory cytokines. They also did something else. They went into the lab and did a rat experiment and checked whether or not, and that's a maybe even more important thing, whether or not you can block these cytokines early enough. And what they found was that indeed, by giving a trigger to induce the disease, obviously the disease was indeed induced. But having already given the drug before, the disease did not appear, or appeared very, very mildly. And they also tried to find whether or not, for example, after having the disease and treating the rats accordingly, either with a MK2 inhibitor or as comparison with tofacitinib, another intracellular drug, or etanercept, you would be able to decrease the swelling of the paws. And indeed, this happened significantly, especially with a higher dose. So we might even go there and say intracellular treatment may even decrease the disease severity up front, knowing the cytokine levels in the blood of the patients. So overall, again, this is the very new thing that I believe will come to us, and further studies are planned. Now, one other thing that was also important was about monitoring. And we all know about the different apps that come up and whether or not this would be helpful for monitoring patients with axial spondyloarthritis. And what we tried to do in our hospital was to have an approved app for disease activity for spondyloarthritis. So we know that indeed there is an increasing use of health apps in the world. And we also have a law nowadays in Germany that more or less obliges you to at least speak with the patients of using an app and feeding the app with clinical information. Of course, we all don't know exactly what to do with it, but this is another point. So the question is now, if we have an app that is approved, does that help you or help us in daily practice? We had this product that is obviously also certified, and we followed up patients over 6 months. We asked them to provide information about BASTAI, ASTAS, and all the other information that we use in the regular questionnaires. And they had to do it at least every 2 weeks for the BASTAI. This was the minimum requirement, and for the ASTAS, the minimum requirement that we had. We also defined those patients who were adherent and those who were not adherent to the app, meaning that they had to give at least this every 2 weeks one value in the app, which is actually really minimal. And here you see now the baseline characteristics of the subdivision of adherent and non-adherent patients. Looking at the p-values again, the patients who were adherent, this means they really used the app more than the other ones. They were older, although we would have thought that this would be younger patients. And they had, or more of them had, a high ASDAS. Similarly, lesser of them were taking biologic DMARDs and were taking more NSAIDs. And if you look at the numbers of information that was put in the app to check on whether or not this app thing works, you see that at the visits where the patients knew they would come to the doctor, visit 2 and visit 3, this is baseline here, there was an increase in app usage. In between, it really flattened. And who was using the app the most? These were the patients who were clinically active. Those who were not, they in fact left it aside. Which means that overall, at least when we have in this first experiment to check on whether or not an app works, it seems that the usage of it is pretty poor, at least in our example. We had a very poor adherence, and the adherence was higher in those patients who needed treatment. This means needed either to communicate with a doctor or were on lesser biologics which would have lowered their disease activity. Now looking at other things such as, again, being able to taper doses either with or without an electronic tool. I'm citing here the data from Denmark. And these are interesting because you will see that they did not, as the data showed before, just lower the treatment by half, but they used another approach. So it's important to know whether or not we are able to gradually decrease the dose of biologics and whether or not these patients will tolerate it who do that. So these are the aims that were used for investigation. They check whether or not this is successfully done, the tapering of the dose, whether there's any baseline predictors for successful tapering, and whether or not other outcomes may be associated with good or not so good response upon dose de-escalation. So what did they do? They took patients, and that's the important thing. They took patients who were all in remission. They were in remission for a year or longer. And the remission means they were with a low BASTA, low global physician scores, and they did not have any signs of clinical activity in the last year. A little bit more than 100 patients were taken. And at the time point where they were put in the study, 70% only had, excuse me, the standard dose. 1/3 of them had already reduced dose. And what they did was to really do it gradually. In the beginning, when they entered the patients entered the study, they decreased the dose by 2/3. Then by half after 16 weeks, 16 weeks later by 1/3. And after a year, they tried to stop the treatment completely and see what happens. If someone flared, then they went back to the dose that were tolerated before. So here you see the amount of patients and the proportion who were able to stop or decrease the dose based on the different dose regimens. This means a 2/3, half, 1/3. And approximately 15 to 20% did it per arm. So obviously, dose reduction, gradual dose reduction is possible, but this does not happen and does not apply to all patients. Some of them may tolerate it, some better, or some of them may tolerate it lesser good. And interestingly to me, when they checked the predictors of successful dose tapering, independent of how low the dose would go, they found that at least in the multivariable analysis, only the physician's global, and this is completely new to me because I'm not aware of any data showing that the physician can predict what will happen to the patient. So only the physician's global was able to statistically significantly predict what will happen later. In the univariate analysis, B27 positivity was there, but this was not significant. This is shown because this was taken into account, and inflammation was also not significant in the MRI. So altogether, we can say that I would buy this data, trust a little bit more what I believe that is happening to the patient, since we seem to know them pretty well after so long time and having them on a remission. But stopping, again, is not possible. Lowering the dose is possible, but this has to be happening. This has to happen slow. And this is what indeed we're seeing in this study. Now we had other data from a large European ongoing initiative, which is called Serena, with almost 3,000 patients who had either psoriasis or psoriatic arthritis or ankylosing spondylitis and were treated with an IL-17 inhibitor. What the investigators tried to do here was to see that if we now interrupt the treatment, as I mentioned before, either completely or gradually, what will happen to the patients, and especially how long and for what reason they would stop the treatment, and what would happen if they would be retreated. So they took out of these 2,900 patients, those who had complete data. You see here the numbers for each PSA and ankylosing spondylitis. They followed them up over 2 years. And then they took those who had at least for 16 weeks active psoriatic arthritis or ankylosing spondylitis, and they obviously had to stop the treatment. And they had to stop the treatment for at least 3 months and checked for all the different outcomes they would think of, not only the swell and joint count, but also the patient's global and so on. So here you see the mixed analysis for PS, or the single analysis for PSA and ankylosing spondylitis on the left and the right, respectively. Blue is the reason. All these are the reasons to stop or at least withdraw the treatment for at least 3 months. And most of the times it was an adverse event. However, and then that's the important thing of this study, if there was an adverse event and the patient was put again on the same drug, these patients would follow up. So what you will see here after is what's happening if you restart with the same drug. For example, you get with an IL-17 inhibitor, a fungal infection, which is not so severe. You stop it for a little while, and then you restart the treatment. So again, blue is adverse event. Now the orange here is any other reason that was not given in. And for the gray, it is that the data were missing completely, obviously, most probably because the patient did not go to the doctor. And this is now what's happening, for example, for the patient's global assessment and for the BASTAI. And interestingly enough, you see that nothing happened. Yeah. So the patients are here, they stop the drug for any reason, let's say mostly adverse event. They do not worsen, and if you retreat, it doesn't improve either. So altogether, this makes us understand that at least when it comes to one of the biologic dimmers that we have, intermediate treatment interruption does not, first of all, may have many different reasons, but it does not really lead, at least when it's intermediate, to a very severe worsening of disease activity. At least because we do have the loading dose with secukinumab, where this study was done with, restarting does not require a reloading. And that's an important thing, I believe. Now, one other thing is whether or not by using the drugs that we have, we are also able to influence radiographically the disease. And here you see data that we were able to see from the German cohort. On the left side, the old data with all the biologics that we knew at that time, with etanercept, infliximab, adalimumab. The bars go up, means worsening radiographically. This was a little bit lower numerically, but this was not statistically significant to the gray bars, which are no biologic. And we have been able to show that indeed, if you see the long-term radiographic follow-up with patients with on a biologic, in the first 4 years, there is no difference between, for example, TNF blocker and no TNF blocker. But in the second 4 years, patients on the TNF blocker continue without progression, and those without the TNF blocker, they progress. So what happened here was, and since we assess these patients every 2 years, was to take data from our German inception cohort over 8 years of a follow-up. You see here almost 270 patients. They were either radiographic or non-radiographic, and score the radiographic score and see what happens every 2 years based on the treatment that the patients get, a TNF blocker in that case. It is not very complicated, but I will try to show you how we acted here, how the data were collected. We had periods of 2 years where X-rays were collected, and we checked within the last 2 years before the X-ray was done, whether the patient was getting the drug, A, and if he or she were getting the drug, were they getting that for longer than a year or not? This means in the last 12 months or beyond, because this means you are on a drug and you get it continuously. You don't have interventions and interruptions in between. So here you see what happened in those patients, for the example here for the left, on the left side, who were taking the TNF blocker for more than 12 months. This means sustainable or sustained treatment in the current 2-year interval. Or if they were taking it for more than 12 months, also in the previous 2-year interval. This means even longer treatment. The only thing that you can keep from this slide, actually, and this is the essential part, is this one. These are the patients who were treated not only over many 2-year intervals, but also continuously without offs and ons. Because we know, and as I showed you before, there might be offs and ons in the treatment. And much lesser patients here had radiographic progression. You can also see that on that slide. Green means no progression or stopping progression. Blue or gray means no effect of the treatment. And the only part that has 2 yeses is the one that is having also the biggest effect on radiographic progression. This means stopping it significantly. Here you see the confidence interval. And these are the patients who are getting either in the current or in the previous 2-year interval, the TNF blocker for more than 12 months. This means continuous treatment, not off and on, leads to a much better response. And this means a much better outcome in terms of lesser radiographic progression. So altogether, we can say that there is an association of the biologic DMARDs, especially here TNF blockers, in decreasing or inhibiting radiographic progression. We need at least two years intervals to see the effect, and continuous treatment is associated with better effect, which again means, if you ask me, I wouldn't stop the treatment. I would try to reduce the drug, but at least not stop it, also not stop it in between, because this affects also the radiographic progression. So if we go back to the beginning, the title was this one. And the question is now, do we have any future changes in the spondyloarthritis guidelines, especially in the radiographic and non-radiographic drugs, and are there any new treatment paradigms? And this is what has been published already 5 years ago. We're going to show the new ASAS EULAR treatment guidelines for spondyloarthritis at this EULAR's meeting. There will be some changes, but overall we can say that indeed non-radiographic and radiographic status is the same, is being treated the same. And what we have as a development is oral molecules. This means intracellular drugs that will be acting, and we need to see whether or not they may be placed similarly to biologic DMARDs or not. And by that, I would like to end, and thank you very much.
Excellent. Thank you very much, Jonathan. As usual, a lot of updates in the findings, understanding, and treatment. I open the next few minutes floor for questions. I have 3 questions from the virtual, but anyone would like to have direct question from here. The question, perhaps I go by this, and I have my own question as well. One comes from Dr. Mishra, and they say, if the BASDAI has fibromyalgia element in it, why we cannot work on finding a modified or adjusted BASDAI? I understand it's similar to, for example, in FRAX for osteoporosis. There is a male to female gender different calculation. Can the statistics help us to find a modified version male to female?
I think this is a very good suggestion. We have not really thought about that much so far, simply because these data that I'll show you here are pretty new. However, to me, a modified BASDAI may be the ASTAS. We know that out of the questions of the ASTAS, 3 of them are, out of the 5 questions, 3 of them are from the BASDAI. So you can say that there is already the modification. Of course, the problem with the ASTAS is that we have the CRP, which bothers us a little bit because we don't have it always with us. So yes, I can imagine that there can be a modification by weighting, giving a different weight to the questions of the BASDAI. Question number 1, fatigue or peripheral symptoms or low back pain. This needs to be done. But I mean, it's a good solution. I cannot tell you how much this would at the very end help, because we also know that beyond the gender, also the disease duration also may play a role. But overall, I think it's not a bad way to think of. I would rather go for the moment and say, how do I interpret the BASDAI in a male and a female? But this is something certainly that can be worked on.
Right. Next virtual question is, perhaps this been tested before. Any updates to help us in differentiating AS from axial PSA? From Dr. Nada.
Well, that's a mean question because we don't know that yet, but we are working on that. And I believe that this is something that we need to address and answer. This means we need to understand what exactly differentiates on the imaging, especially those 2 diseases. I believe that the pathophysiology of axial PSA is different than ankylosing spondylitis. We have different factors that influence that, and there's more enthesitis in PSA. We also see new bone formation being different in ankylosing spondylitis as compared to axial PSA or patients with PSA and axial involvement. But we are working on that, and that I do believe that this is a very important question, but we cannot answer it yet, maybe in a year or 2.
Right. Another question from me. You said the update, one of the update is a small molecule to be added to the guidelines. Is the data of bimekizumab, is it the sort of, I don't call it selectivity, I call it a better targeted IL-17 inhibition in that sense to go into A and F? Is that open a floodgate of more research into more selectivity in IL-17 therapy? Would that give better results?
Yeah, that's exactly what we have asked ourselves. You're absolutely right. I have to say that I was not so hopeful when I saw the data, or at least the phase 2 data before with bimekizumab, because they were not much different to what we knew from anything else. However, we believe that the adding of the F domain may help for longevity of the drug. Yeah, so you lose lesser patients over time. There are now data from the phase 3 trial. They are being shown in the press release of the company, and they show that actually even the short-term results are better than what we know so far. They're not, exaggerating better, but they are better from what we knew before. So is it the cohort that were used? I don't think so. I've seen pretty many of them in the meantime of this data. It seems to be indeed be that the drug works pretty well. Yeah, so it might be a little bit better in terms of efficacy, but also in terms of stability of the results. But we need to find it, of course, in the extension of the trial.
Okay, thank you very much. The last question just came virtual, maybe to finish this session, is our presentation female with SPA needs longer treatment duration to achieve treatment goal. Is it valid to increase the dosage in that sense?
Yeah, well, in that case, I would, if the question means give higher doses up front, we know that with a very, very few exceptions, for example, golimumab with in higher BMI, or especially based on indication for secukinumab with 300 milligrams with 150 has not worked, that does not make much sense. At least it's not indicated, and the data are supporting this. I would answer a little bit differently. I would not change the dose, especially if it is a female patient and is not responding in the first 3 months, but I would wait a little bit longer. I would not wait that long in a male patient.
Right.
Yeah.
Thank you very much, Professor. And it's always nice to listen to him, always something new. Thank you for coming all the way to Dubai.
Thank you very much for the invitation.
And now I would like to welcome to Professor Daniel Blockmans from Belgium. Again, came all the way to Dubai. Thank you very much for that. He is the Professor of Medicine, head of a clinic, General Internal Medicine Department in the University of Gastwickberg. I don't know if I pronounced correctly, living in Belgium. He also received his MD from the Catholic University of Leuven, and then promoted from associate professor to professor, and then full professor at the same institution. And his interest, systemic disease, vasculitis, and chronic fatigue syndrome. I think the topic came from when we did survey of what people need to hear. Many of them, they need to hear about imaging of large vessel vasculitis, and I find Professor Blockmans the right person, and he offers us to come all the way and to tell us more about the advances in this field. Thank you very much, Prof.
Thank you very much indeed for having me here. It's a very great honor for me to speak here on this Congress in Dubai on imaging modalities in the diagnosis of large vessel vasculitis. As you're all aware, there are two main large vessel vasculitis, Takayasu arthritis and giant cell arthritis. In Belgium, like in most northern European countries, we see much more GCA patients than Takayasu patients. And the rest of my talk will be especially on GCA. But apart from Takayasu and GCA, there is also a form of isolated aortitis, which can be part of IgG4-related disease. This painting by Jan van Eyck, a 15th century Flemish painter, which you can find in the Groningen Museum in Bruges in Belgium, is probably one of the earliest depiction of a man with giant cell arthritis. If you look at the priest, the man who ordered the painting, when you see it in more detail, you can see that his temporal artery is very prominent. Much like this patient of mine. Now, a prominent temporal artery, of course, is not enough to make a diagnosis of giant cell arteritis if the patient is asymptomatic. But when the patient is symptomatic and the artery is pulseless, dull and inflamed, you can make the diagnosis on first sight. There are different ways to diagnose giant cell arteritis. The typical clinical picture is that of an elderly person with headache, jaw claudication, polymyalgia rheumatica symptoms, maybe visual symptoms, and with a high sedimentation rate and CRP level in the blood. As a general internist, however, we see GCA patients with atypical presentations in which fever, malaise, or weight loss prevail. Inflammatory parameters are not always increased, and especially in those GCA patients with visual symptoms, CRP and sedimentation rate tend to be lower. The ACR, American College of Rheumatology classification criteria, date back to 1990. And this was a time when one thought that GCA almost solely involves the cranial arteries. That's why 3 of these 5 criteria are in fact cranial criteria. It was only in 1999, with the work of the group of Connie Wyant, that it became widely known that large vessels can also be involved, even without cranial artery involvement. Another point, which is often overlooked with these ACR criteria, is that these criteria may only be applied in patients with proven vasculitis and not in the general population. And that is something that you see even in studies that they compare to ACR criteria without proven vasculitis. However, I presume that new ACR criteria for giant cell arteritis and Takayasu will appear next month. Since this month, in March, the new criteria for Wegener's disease, so granulomatosis with polyangiitis, microscopic polyangiitis, and EGPA were published in Annals of Rheumatic Diseases and Arthritis and Rheumatism. And I think that the 3 other vasculitides will be published next month, and they will deal with that also thoracic vessel involvement. So in my talk, I will discuss temporal artery biopsy, ultrasound, MRI, FDG PET scan, and I will also say something about the European and American guidelines for imaging, or for diagnosing GCA. When a temporal artery biopsy is clearly positive with hyperplasia of the intima, interruption of the elastida interna and giant cells, and also lymphocyte infiltration of the media, the diagnosis of GCA is very straightforward. However, when the inflammation is restricted to the adventitia, this is in fact where the pathology of GCA starts, then it is much harder to be sure it is really giant cell arteritis. The group of Carlos Alvarani came to the conclusion that the vast majority of patients with inflammation restricted to the adventitia are in fact suffering from giant cell arteritis or isolated polymyalgia rheumatica. In the large Tabul study of Rachid Lukmani, that's a study that nobody has read because it's 238 pages, well, temporal artery biopsy was compared with ultrasound. But something what struck me was the fact that the inter-rater agreement of the biopsies was only 62%. So not all biopsies are very clear, black or white. There is quite some gray also in biopsy interpretation. So this brings me to the second modality, ultrasound. of the temporal or axillary arteries, which was introduced by Wolfgang Schmidt from Berlin in 1997. He described the halo sign, which you can see here in a longitudinal plane or in a transverse plane, and which corresponds to the hyperplastic intima. This search for a halo can also be performed at the axial artery level or vertebral artery level. These are older figures with sensitivities for that halo sign around 55% in a meta-analysis dating from 2005, and specificities around 95%. A more recent meta-analysis performed by a French group found a sensitivity of 68% and a specificity of 81% compared to temporal artery biopsy. And this was based on 25 papers which were included in this meta-analysis. But as you can see, there is a very broad variety in sensitivities, a wide range in sensitivities and specificities among studies. And this is the most recent meta-analysis I could find from the group of Bhaskar Dasgupta. And compared to the clinical diagnosis and temporal artery biopsy, they found a sensitivity of 67% and a specificity of 95%. When the halo sign was combined with other possible signs of inflammation, such as stenosis or occlusion, sensitivity and specificity dropped, in contrary to the older studies, in which sensitivity increased while combining these features. It needs a lot of expertise to perform these ultrasound examinations properly. My personal experience with this technique, as performed in our hospital by a very dedicated technician who went to Oxford to study that and who has a very good experience. Well, my experience is not good. There are many gray results. And also the fact is, as in this study by the group of Carlo Salvarani, that ultrasound-guided temporal artery biopsy apparently does not improve the sensitivity of the temporal artery biopsy for diagnosing GCA. That does not improve my confidence in this technique. Of course, machinery will improve over time, and there are already some reports on very high resolutions ultrasound with measurement of the arterial layer thickness with intimal thickening identified as a 4-line pattern. So probably it will improve, but the experience of the one who does the sonography is very crucial. The next technique I want to discuss briefly is 3 Tesla magnetic resonance imaging. And Thorsten Bley is here the pioneer in this field. And he could visualize vessel wall enhancement in extracranial and even in intracranial arteries in GCA. In Takayashu and GCA, stenotic lesions and dilatations of the aorta, for instance, can be seen, of course, or these clavin arteries. But these are, of course, late complications of vasculitis. Edema and enhancement of the aortic wall may point to more recent vasculitis. A very recent meta-analysis, in this very recent meta-analysis, high-resolution MRI had a sensitivity of 75% and a specificity of 89% with clinical diagnosis as referenced. When referenced with temporal artery biopsy, the sensitivity was 91% and the specificity was 78%. The next imaging modality is positron emission tomography with the injection of fluorodeoxyglucose. And as you know, inflammatory cells like neoplastic cells, that take up more glucose, and hence you can visualize also inflammation in the body. And in the late 90s, our group in Leuven found that large arteries indeed take up FDG in patients with giant cell arteritis. Like in this patient, you can follow the entire aorta up to the bifurcation here in the iliac arteries. You can see the subclavian axillary arteries and the carotid arteries. But I will not talk too much of our own studies, but we'll mention some recent studies, like this study of a Danish group, in which PET was performed after 3 and 10 days of steroid intake, because one of the problems is that you need to have an urgent PET scan, because once you have started steroids, we always assume that then you cannot rely anymore on PET scan. But in this study, 10 days of steroid intake clearly was too long, but after 3 days, FDG uptake was still visible. We always presumed that the temporal arteries themselves are not visible with PET, because these arteries are too small, too superficially located, and in the direct environment of the FDG consuming brain. But with newer PET CTs with higher resolution, it seems that even cranial arteries which are inflamed can be detected. Then there is the problem of remaining PET positivity after months of steroid therapy in some patients. And we didn't know, is this ongoing vasculitis or is it vascular remodeling? We did not find any correlation between lasting FDG uptake and relapse rate, and neither did these investigators. There may be another reason apart from just diagnosing GCA or Takayasu to perform PET scanning in GCA patients. As you may know, GCA patients have a greater chance of doing an aortic aneurysm than age-matched controls, and at the thoracic level, about 17 times more. In this study, yeah, that's already dating from 2008, we asked all our GCA patients who at that time had undergone a PET scan in the past at time of diagnosis to come back to the clinic to have a CT scan to have their aorta diameters measured. And in multivariate analysis, the only parameter which was significantly related to the volume of the thoracic aorta was FDG uptake at the aorta several years before, so at diagnosis. And this finding was confirmed in other retrospective studies, such as in this study of Hubert de Boisson from France. All 9 patients with aortic complications in a group of 130 patients, all these aortic complications occurred in patients with a positive PET scan, with a p-value of 0.003. This picture from one of our patients I want to show to you to demonstrate that PET scan not only visualizes the FDG uptake in the large vessels, as you can see here and here, but in patients who have also polymyalgia rheumatica, you can also see that FDG uptake in the shoulders, in the hips, and in these patients also in the spinous processes of the lumbar spine. So you can visualize giant cell arteritis and polymyalgia rheumatica with one examination in the same patient. And of course, also in patients with isolated polymyalgia rheumatica, you can see this FDG uptake in shoulders, hips, and here in the cervical spine. This is what you find in isolated aortitis or in peri-aortitis. this rim of inflammatory tissue here highly takes up FDG. In this slide, which probably you can't read, I have put all advantages and limitations of the several imaging techniques together. Of course, I didn't discuss here angiography or CT. Because angiography is too invasive. CT, well, we have if you perform a PET scan, it's always combined with CT scan. So ultrasound, it's inexpensive, it causes no radiation, and it can repeat it, but a lot of experience is needed. The aorta itself cannot be visualized. MRI also comes with no radiation, but it's expensive, not readily available, and some of our elderly patients may have claustrophobia. PET offers a whole body assessment, but of course it is not widely available, and it also comes with radiation. Maybe the ideal combination will be the fully integrated PET MRI, and there are already some preliminary results with this new technique. Let me give some personal thoughts on PET and giant cell arteritis. I always say that the positive PET scan for vasculitis is only positive when everybody agrees. So you don't have to, I think, to compare to the liver or whatever, or you should, if you see the picture and if everybody is convinced that this is vasculitis, then it's vasculitis. But like with all techniques, there are also gray results where you can't compare, we can't differentiate with atherosclerosis or beware of the circulating FDG. It should be really in the vessel wall. Try to perform PET scan before steroids are started. The temporal artery biopsy has lost its position as golden standard for the diagnosis of GCA, since the temporal arteries are not always involved. In my opinion, the golden standard for the diagnosis of GCA is the opinion of an experienced clinician who takes into account all available data, and this after 6 months of follow-up of a given patient. These are the OLR recommendations for the use of imaging in large vessel vasculitis. Ultrasound of the temporal and the axillary arteries is recommended as the first imaging modality in patients with suspected cranial GCA. And I fully agree with that. If the picture is really very, very clear, then I think you can start treatment without any further imaging. For large vessel inflammation, PET comes into the picture. In patients with Takayasu who are younger and in whom we want to prevent radiation exposure, MRI is the preferred technique. The recent American College of Rheumatology guidelines still advise temporal artery biopsy. But the Americans immediately admit that this is because they lack experience with vascular ultrasound and they don't get PET reimbursed for this indication by the insurance companies. This is an algorithm proposed for evaluating patients with suspected giant cell arteritis. Patients with predominant cranial symptoms should undergo temporal artery biopsy, ultrasound and/or biopsy. When it is negative and clinical probability is intermediate or high, another imaging technique should be used. When extracranial symptoms predominate, so claudication of the arms or fever or weight loss, PET or MRI is a first technique, and temporal artery biopsy or ultrasound can be performed if these are negative and clinical probability remains intermediate or high. But in patients with very atypical clinical pictures, and they exist, PET surely is the best imaging modality to diagnose large vessel vasculitis when you did not expect it. I thank you for your attention.
Thank you very much, Professor Blockman. First of all, open the stage for questions. Dr. Ahmed.
Thank you very much for your talk. I have actually one debating point and another one is a question. So the debating point about your personal belief in ultrasound, and probably your sonographer didn't like it too much, and your approach that's probably not the best modality to assess temporal arteritis. I've been part of the Tabul study, and as you elaborated yourself, that the biopsy, which should be the gold standard, the interreader reliability was so low. Actually, the ultrasound interreader reliability was higher than that of the biopsies. Now, if the problem with Wolfgang protocol was so complex that people struggled to follow it because it has the stenosis, has the turbulence, you have to have spectral ultrasound. I think the more simplified version now people use that using the halo signs, the compression, wherever, probably would be more useful. And if you think about the price of ultrasound, the ease of use in comparison to PET-CT, which is expensive, really difficult to access. And again, it's not going to tell you about the GCA unless you got the very advanced PET you mentioned. So this is my debating point. My question is, among those with GCA, was there any PET-CT study that said what's the percentage of patients who might have aorta or axillary artery involvement in those who just presented with GCA symptoms, temporal arteritis symptoms? So headaches, high inflammatory markers, and then you do a set PET for them. What's the frequency of those patients might have a set PET-CT inflammation in their other large blood vessels, such as the aorta or axillary arteries?
The sensitivity of the PET scan is also only 60% or so. So that's the problem with all these techniques. All these techniques have a sensitivity of 60 to 70%. So probably we need a combination of techniques to really diagnose every patient with GCA. But I'm not sure if this was your question.
No, my question, if I take every temporal arteritis patient and put them in a PET-CT scan, how many of them will have an inflammation in their axillary or aorta or subclavian arteries? How many of them I'll find some positive findings in the large arteries below the neck? Because I'm not.
Well, that's about 60%. About 60% of them have large vessel involvement on PET scan. Yeah. But I fully agree with you on the ease and the inexpensiveness of ultrasound. But I mean, that's, I think, also why Americans, they choose temporal artery biopsy, because that experience is so important. If I would have giant cell arteritis, and if Wolfgang Schmidt would do an ultrasound with me, then I'm very confident. But I mean, it really depends on that person who does the ultrasound.
The same thing applies on inflammatory arteritis, although it's much easier to.
I think for the other modalities, well, you have this picture. It's easier, I think.
Thank you.
Okay, any other question from the floor? I have one virtual question, or again, could be debating point. About PET scan CT, it seems your final conclusion in terms of probability picking up the disease. The question here saying, is PET MRI could offer a better for localization if you have suspicion of particular artery, localization either cranial or extracranial? Where you see the difference between PET MRI and PET CT?
Well, with MRI, you have this information also on vessel wall enhancement, which you don't have with PET CT. So I think this might be an advantage for the aortic wall, but especially then for the cranial arteries. Yes.
Right.
Yeah.
okay.
You will have,
Any more?
you will have both information, PET and MRI,
Yeah.
while the information you get with CT scan is not so good, so much.
Yeah. Right. That's well. Any other questions? Because we are also running our time. So thank you very much, Professor Blogmans, for coming to Dubai and for this lecture. Thank you very much. Now, the next in this morning session, which is the last in the morning session, is Professor Ingrid Lundberg from Sweden. She is a professor of hematology, Karolinska Institute, combined position senior consultant at the same university hospital, established myositis clinic and dedicated multidisciplinary team in '93. This clinic has formed the basis translational research project and the aim to achieve improved molecular mechanism in muscle weakness and immune reactivity. She is a member of the founding group that developed international multidisciplinary web-based myositis register. The lecture will be virtual, and I welcome Professor Lundberg for her lecture. Please.
First, I would like to check that you can hear me and see my slides.
I can see your slide.
And can you hear me?
And can I hear you? Yes.
Yes, thank you so much.
But there is some echo. Maybe try
good morning.
to
And first of all, thank you so much for inviting me to your interesting meeting. Unfortunately, I could not attend in person, but I really wish I could be there with you, but another time. So this morning, I will discuss management of difficult to treat myositis cases. These are my disclosures. And here are some key references, and in particular, the fourth reference here, there you can read more about the details on what I will discuss today. So I will start by giving an introduction of the different subtypes of myositis and the overall goal of treatment. And then I will present outcome measures to use in the clinic. And then I will discuss refractory cases and a case that has been a challenge to me. So you know that the idiopathic inflammatory myopathies, they are characterized by muscle weakness and low muscle endurance. And typically you find these inflammatory cell infiltrates in the muscle tissue, but a heterogeneous disease, as you all know. And just try. Not most patients actually have other organ manifestations than the muscle weakness. So many patients have a skin rash, or they have lung involvement. They can have arthritis or even heart involvement. So indicating that this is a systemic inflammatory disease. Traditionally, the myositis has been subgrouped into polymyositis, dermatomyositis, and inclusion body myositis, based on differences in clinical and histopathological features. But over the last decades, we have identified several new autoantibodies, and they are specific for myositis and called myositis-specific autoantibodies. And they have helped us to identify new subgroups that are more homogeneous. And they are also likely to respond differently to treatment, as I will discuss. So one of the largest subgroups is the one called antisynthetase syndrome, that's characterized by one of the antisynthetase autoantibodies, of which antigen 1 is the most common. And clinically, this syndrome is characterized then by myositis, interstitial lung disease. They often have arthritis and these mechanics hands. And then we have in dermatomyositis identified 5 different autoantibodies. And one of them is then characterized by less muscle involvement, the clinical amyopathic dermatomyositis, and that's the anti-MD5. And the most important feature of this subgroup is that these patients may have a very severe interstitial lung disease. We have two autoantibodies, anti-TIF1 gamma and anti-NXP2, that are associated with a high risk of cancer in adult individuals with dermatomyositis. Anti-MI2 is a typical dermatomyositis, often with good prognosis, whereas anti-SIE is associated with severe and difficult to treat dermatomyositis. We have two autoantibodies, anti-HMGCR and anti-SRP, that are associated with the clinical feature of severe muscle involvement, and it's called immune-mediated necrotizing myopathy, this subgroup. In inclusion body myositis, we have identified one antibody, anti-CN1A, and then, of course, we have to remember that we also have patients that are still seronegative, so we should not forget them. So the overall goal of treatment for patients with inflammatory myopathies is to improve function and health-related quality of life. It's to eliminate inflammation and prevent damage. And for most patients, it's also to restore muscle strength and endurance. For some, it's to restore lung function. For some, to eliminate skin rash. And for others, it may be to eliminate arthritis. There are few randomized controlled trials to help us in our treatment decisions of patients with myositis. So we have to rely on clinical experience, expert opinion. And I recommend this review by Dr. Odesen Agarwal that summarizes treatment recommendations of today. And here they have presented an algorithm, and as the new subtypes have just recently been presented, this treatment algorithm is based on the old larger subgroups, poly and dermatomyositis. As a first-line treatment, we recommend glucocorticoids in combination with methotrexate or azathioprine. If this doesn't work or patient doesn't tolerate this, then we can switch the methotrexate or azathioprine to mycophenolate mofetyl or tacrolimus or cyclosporin, or combine methotrexate and azathioprine. And as a third-line treatment, we have the biologics, rituximab, cyclophosphamide, or the repository corticotropin injection. For individual cases, we can use IVIG, and I'll come back to that at all levels. But when we follow our patients, it's like for rheumatoid arthritis, it's important to measure the disease activity. And the International Collaboration, International Myositis Assessment and Clinical Studies Group, IMAX, has proposed to use a course set composed of 6 items to follow the disease activity in clinical trials, but this is also helpful in your clinical practice. So this course set is based on the global assessment of physician and patient on a visual analog scale, and a measure of muscle strength like the manual muscle test, and I'll come back to this. A measure of physical function, that the RA-HAC, and a laboratory test of muscle enzymes in serum, like CK or LD. And then there is an extra skeletal muscle disease activity that measure where you indicate involvement, for instance, of the lung and the skin. And you can find more details on this website on the course set. And there is also a proposal of definition of improvement, particularly then for clinical trials, that at least 3 of the course set measures should be improved by more than 20%. And then no more than 2 can worsen by 25%. But the manual muscle test cannot worsen if you want to define improvement. So what's particularly useful in the clinic is to measure the muscle strength using the manual muscle test. And I hope you're all familiar with this. If not, I will just briefly present it. This test that you can do in the clinic, like the joint count, you measure the strength in the upper and lower extremities, in the proximal and distal muscles, and including the neck flexors. So there are 8 muscle groups, and you get the maximum score of 80. And you can find a video on this website where you can get more information on this. Now, there are some limitations with the manual muscle tests, as some patients report that they are weak or cannot function as they did before. And for this reason, we have developed a functional index which measures the number of repetitions. And in this functional index 2, we measure the number of repetitions in 7 muscle groups, again, upper and lower extremities and distal and proximal muscles. Now, this is more sensitive, so to capture, because this is probably where we have more of the problem in the myositis, that the muscles become easily fatigued. So now this takes a bit longer time. So we collaborate here with a physical therapist that in our hospital, they do the measures for us. So now I will go over to present the case. And this woman presented to us at the age of 37. She had no family history of muscle or rheumatic disorder. She was previously healthy, no smoker. And she had a slow onset of progressive muscle weakness of her pelvic muscles. And when I saw her first time, she had a clear reduction of the MMT-8. She scored 70 of 80. And she had no other organ manifestations. Her myopathy was seen on the EMG, where she had a generalized myopathy, including spontaneous activity and fibrillation, indicating an inflammation. On MRI, she had both signs of flat fat replacement of thigh and hip muscles, but also signs of inflammation. We performed a muscle biopsy. It was almost normal, which was, of course, a surprise. No inflammatory infiltrates. She had elevated CK, and here we used the microcathar. So she had 5 times the upper normal level. Her sedimentation rate and CRP were normal. And we tested her myositis autoantibodies at that time, and they were negative. So she was diagnosed as having polymyositis, and we started treatment prednisolone and azathioprine. And then she didn't tolerate azathioprine, so we replaced it by cyclosporine. But after 6 months, she had a slowly progressive muscle weakness, despite that she did regular exercise. And as you can see, her MMT had not improved. So is this a refractory myositis? So then how to proceed? Well, the first question is to determine if this persisting weakness is due to active inflammation or damage. So how do you define that? Well, first, refractory, we say at least after 3 and maybe after 6 months. If the patient hasn't improved, then you have to rethink here. So how to define if there is persisting inflammation or damage? Well, you can see the progressiveness of weakness that would indicate active inflammation, or persisting elevated CK or LD. Or you can do an MRI to visualize if there is still edema, and you can do a new biopsy. And I really recommend here to repeat the biopsy, both to show if there is still inflammation and also for differential diagnostic purposes. So if there is no sign of inflammation, then you can regard this as more damage, and it could also be steroid-induced myopathy. So taper steroids and optimize exercise. If you have indications of an active inflammation, then I would suggest to ask if there is a presence of skin rash, like an active dermatomyositis. And in these cases, we have to go back and consider if there is an underlying malignancy and repeat the screening for malignancy. If there is no sign of a malignancy, then it's a high probability of refractory dermatomyositis. Well, if there is no skin rash, So in our case, we didn't have a skin rash. We had the persisting low MMT, but she had elevated CK. So she has a sign of active disease. Then the question is this a myositis or is this another disease? So we performed a new muscle biopsy. And in this biopsy, we found here, you can see regenerating and some also degenerating fibers. Still, there was no inflammation. With the suspicion that this could be muscle dystrophy, we also stained for dysferlin and calpain, but they were normal. So in this case now, we didn't have a skin rash. So then we asked, so is this a myositis or is this another disease? So then we asked, is there an extramuscular organ involvement or does the patient have any myositis specific or associated autoantibodies that would indicate an autoimmune myopathy? If you don't have any of these, then it's low probability of being an inflammatory myopathy or myositis. It could be an inclusion body myositis, but here in these cases, you should reconsider the diagnosis and think of muscle dystrophy or other myopathy. If you have any other extramuscular organ involvement or the antibodies, then it's likely to be a refractory IIM. Now, this woman, she didn't have any other organ manifestations. Her autoantibodies were negative. So is this an inclusion body myositis? Well, not so likely because she's young, female, and also the distribution of muscle weakness, including absence of finger flexor weakness, argues against inclusion body myositis. So now and in these cases, it's very important to collaborate with the neurologist. So we had a new diagnostic evaluation by a neurologist, including limb-girdle muscle dystrophy and Pompe's disease, and negative, but they performed genetics and enzyme investigations, but they were negative, arguing against any of these limb-girdle or Pompe's disease. So is this a refractory myositis or a limb-girdle? Well, what happened was that this woman had kindly donated serum for research some years back at her diagnosis. And in 2018, excuse me, we had the possibility to analyze sera for a new autoantibody, an antibody targeting HMG-CR, kindly by Dr. Mammon in US. And this patient, then we found that she had anti-HMG-CR autoantibodies. So I contacted her and her neurologist. And then when we summarized the clinics, the muscle biopsy features with regenerating and degenerating fibers with limited inflammation, and the MRI findings is compatible with the anti-HMG-CR positive immune-mediated necrotizing myopathy. So this is a refractory myositis. This woman was then started on treatment with high-dose IVIG, and now her muscle function slowly improved after 13 years of worsening. So now we come to identify this subgroup, immune-mediated necrotizing myopathy. And this subgroup is characterized by pronounced proximal muscle weakness. And patients often have dysphagia, but lung involvement is rare. They often present with high serum levels of CK, and typically in the muscle biopsy that our patient had. Now this is often associated with previous statin use, but can also be seen in individuals that have not been subject to statin treatment. And then we have a third group, the seronegative, where you have to check carefully for an underlying cancer. Now, importantly, this subgroup of myositis is often difficult to treat. So the take-home message in this patient is that in people with suspected but genetically unconfirmed muscle dystrophy, consider immune-mediated necrotizing myopathy and test for this anti-HMG-CR antibodies, even if patients have not been on statins. And importantly, this can also be seen in children and in young people. as they may respond to immunosuppressive therapy. So now, if you have a case with refractory myositis, the first is to address whether the persisting weakness is due to active inflammation or damage. If there is active inflammation, is the diagnosis correct? Because the inflammation could be secondary to a muscle dystrophy. And if we have active inflammation and no other disease, then we have to change therapy. So now I come back to this algorithm. And if we have started with azathioprine and methotrexate, the first step would be to switch between them or switch to mycophenolate mofetil. If the patients then improve, yes, then continue, taper steroids and exercise. If they don't improve, then we have to look at the different subgroups. So if we have a patient dermatomyositis skin rash, there we should consider treatment with IVIG, as now has been approved by FDA for difficult to treat dermatomyositis, or rituximab. And if the patients still don't respond, then we can consider new therapies like JAK inhibitors, lenabasum, or abatacept. Now, if the patient doesn't have skin rash, then we go to test and look for the autoantibodies, as they may guide us in the treatment decision. And this is a bit busy, but I will take you through it. So first, if they have myositis-specific antibody, and then they have one of the anti-synthetase antibodies, yes, then there are several case reports to suggest that rituximab may work in these cases. If you don't have these antibodies, then we have different therapies that have been reported besides rituximab, IVIG, abatacept, leflunomide, anakinra, and the repository corticosteroids. And if the patient doesn't have anti-synthetase but anti-SRP antibodies, their third-line therapy would be rituximab. And as we heard, the anti-HMG-CR antibodies, these patients may respond to IVIG or rituximab. And if the patient is seronegative and has dysphagia, that is another subgroup that may respond to IVIG. And here you also have to consider to induce a PEG. But for all treatment-resistant cases without or with antibodies, then we have different therapies that, depending on what is available in your country, you can try. So then now, to conclude, when you have a refractory case with myositis, again, is the disease symptoms based on disease activity or damage? If it's persistent active disease, reevaluate diagnosis, consider a new biopsy. If active myositis, switch treatment or add another immunosuppressive treatment, consider biologic or IVIG. But it's important now that we individualize treatment, and there are some, at least, indications that different subgroups may respond to different therapies. And these subgroups could be based on the clinical phenotype and autoantibodies. But it's important that all the time combine the immunosuppressive treatment with physical exercise to make the muscles stronger. But still, we need new therapies. Not all patients will respond to the therapies that are available. And for this, we need international collaboration in this rare disease. And that's why we have created this network and the register where we can now perform research. And we welcome new collaborators to this international register, which is now called MAYONET. And we have almost 6,000 patients from all the world in this register. And it's important not only for research, but it includes a helpful tool that you can use in your clinic. So this is an individual's scoreboard. So here we have entered disease activity that the patient has scored, the physician disease activity, the manual muscle test, and you can see here, starting here, 2008, 2009, how the MMT has improved, the physician and patient scoring has improved, and the CK has reduced. And this is a helpful tool in your daily practice with the clinic to make your decision, treatment decision with your patient. And finally, I would like to acknowledge our multidisciplinary team and again emphasize the importance of multidisciplinary collaborations with patients with myositis, including both lung clinic and neurology, neuropathology, and the physical therapist. Thank you so much, and I'm ready to take questions.
Talk. I have few questions, virtual questions, but anyone from the floor want to ask first? Please go ahead.
Thank you very much for your elegant talk. For refractory patients, now, you know, these days, people are getting reluctant to use rituximab for patients with rheumatic diseases because of the COVID. Now, you have a study which was published, I think, in 2018 about the use of abatacept, which is a very good choice. But I've noticed that you've mentioned IVIG repeatedly in your talk. So if you want to consider IVIG, would you consider it like once or like for a few months or indefinitely? So what's your thought about the use of IVIG?
Yes, thank you. The IVIG is now the first drug that has actually been approved for dermatomyositis, which makes it important to consider, of course, in particular the patients with dermatomyositis. In the trial that was presented at ACR 2 years ago, they used IVIG with a high dose monthly for 6 months. And again, we don't have any scientific data on how to use the IVIG. The old study by Dr. Darakas, he used IVIG monthly for 3 months and then every 3 months. So I think you need to test. In some cases, it may be enough with monthly for 3 months, and then you can continue with methotrexate and steroids. For some patients, they may have a more poor response, like the patients with immune-mediated necrotizing myopathy. There we may repeat it monthly for years, but it varies a lot. And I think we just need to try to reduce the dose or prolong the intervals. And but it seems like some patients, we don't have another alternative. And of course, in patients that are prone to infections is an alternative, but it's very expensive and it's not always available. So it's not the only the only drug.
Thank you.
Right. Let's go to some virtual question. One is about the same theme from Dr. Suzanne. Mentioned that patient failed MMF, is a fibrin, allergic to rituximab, and there is some local infection with abatacept. What is your approach for the next treatment? I think you probably answered this between your talks, slides, but what do you do in this specific case?
Yeah, again, I think, again, this is, of course, very difficult, but again, IVIG may be an alternative, but I think you need to find something to combine it with, because it's not really feasible for many individuals to use it over time. But look at the phenotype, the muscle biopsy, autoantibody to guide you.
Right. Next question, when you give high-dose steroids, can you predict who might get steroid-induced myopathy and how to avoid or minimize that risk?
Mm-hmm. It's a very important question, and we don't really have a good predictor for who is at risk. I think it's quite rare if you try to reduce the dose and follow the patients, but it's very important to combine steroids with exercise. I think that's one important way to prevent the steroid myopathy.
Right. The other question about this refractory myositis case, was there a primary muscle pain or with the weakness, or just mainly weakness, or if there is a secondary type of pain?
I'm not sure I follow, but some patients have a lot of pain. They have cramps. Some patients do not really have pain, but there could be pain on exercise-induced pain. And of course, we have some patients with fibromyalgia pain. So, but we should not neglect that some patients really have a lot of pain, and particularly seems to be with the patients with immune-mediated necrotizing myopathy, but also some with dermatomyositis have a lot of pain. And that is something we have learned from the patient focus groups in developing new outcome measures, that pain and fatigue are very important symptoms among patients with myositis.
There are just a few bombarded with few questions, but all I summarize them in one question. How often you repeat IVIG and for long, and how often you repeat rituximab and for how long?
So again, it varies a lot. For some patients, we have used rituximab like first with 2 weeks interval, and then that's all. And then they can continue with methotrexate or MMF. For some patients, we need to repeat the rituximab, and I try to then also sometimes lower the dose. So again, try to prolong the interval, try to reduce the dose to avoid complications with infections. And IVIG again, try to use, at least we start with monthly for 3 months. And then I try to prolong the interval. For some patients, it works to prolong the interval to every 3 months. For some patients, we need to maybe do it every 6 weeks or 8 weeks.
We nearly reach our time. I'll leave the floor for one more question, okay. The last question.
Okay, thank you, Dr.
Yes.
Athir. For those patients who have malignancy-associated antibodies, how often do we have to screen them after the first initial, screening?
We don't have any consensus developed guidelines here. So I think everyone agrees that we screen the patient before we start treatment. But then the question is if we should, if and when we should repeat it. As I think there are large variations. In our center, we have repeated the screening for cancer in patients that don't respond as expected to treatment, so refractory disease, or when new symptoms develop, to guide the screening by the symptoms. But there is an international group now working on this, so hopefully in a year we will have some guidelines to help us.
Okay, thank you, Professor. If I leave it on, they will keep asking till tomorrow morning, so better we'll stop at some point.
But you are welcome to send me questions.
Nice lecture and all the answers, and thank you very much in Sweden. I hope the weather starts getting better now.
Yeah, it's still winter. Thank you so much. But you are welcome to contact me by email, so that's fine.
All right.
Hi, assalamu alaikum. So we carry on with this symposium, this non-CME activity, a symposium of Amgen. And we shift from connective tissue diseases to bone diseases to talk about one of the new drugs that we have available in the UAE. And to talk specifically about the role of romosozumab in imminent risk patients. And for that, we're having with us, I guess virtually today, someone that everybody probably knows, Prof. Serge Ferrari. Professor Ferrari's name is connected to osteoporosis and treatment of osteoporosis. He's the head of clinical service and research laboratory of bone diseases and chairman of the academic department of medicine at Geneva Faculty of Medicine, University Hospital in Switzerland. He's a former chair, currently vice chair of the Council of Scientific Advisors and co-chair of the Capture the Fracture CTF program at the IOF International Osteoporosis Foundation. He's past president of the Swiss Bone and Mineral Society and current president of the Swiss Associations Against Osteoporosis. Prof. Ferrari is well-known and famous for his publications in the field. And without any further ado, we'll start the presentation of Prof. Ferrari.
Very good morning, everyone. I am very honored to talk to you now about identifying and treating patients at very high risk of fracture. And this is in a relationship with the development of romosozumab that just became available for treating those patients. And this is sponsored by Amgen. So, as we all know, there is a wide spectrum of risk in osteoporosis as reflected by these two women. The one on the left never had a fracture. Her risk is most defined by her age and bone density as shown in the bottom graph. The one on the right obviously has already had some consequences of the disease with the kyphotic back, meaning she has vertebral fractures, and the crutch is walking, meaning she has had the hip fracture. What it shows on the right is a reminder that it's not just fractures that increase fracture risk. It's also the recency of the fracture. So if you have a recent vertebral fracture, you have up to 25% risk of a second osteoporotic fracture in just 1 year. And if you have a hip fracture, the relative risk of another fracture is maximum within a year, and then about 2 years later levels off at about just twofold the background risk of the population. So risk of fracturing depends on a number of factors, also BMD, but very prominent factors are age, fractures, and particularly recent fractures. Now, again, the risk of a second fracture following a first major osteoporotic fracture has been very much investigated recently. Again, what you see here is that in women having a major osteoporotic fracture, the risk of having a second one is maximum. This is numbers per 100,000 subjects, maximum in the first couple of years, and then levels off, as I said, at about twofold the background risk of the population. So this time window of the 2 years following the initial fracture has been called the period of imminent risk, imminent meaning the very high risk of refracturing within 2 years after initial fracture. It's particularly true, again, here for vertebral fractures. So what you see is the incidence rate for 1,000 patients with a recent vertebral fracture, whether they're men or women stratified by age. And you see again that it is really within the first year or two that you have a very high increase in the risk of a second fracture if you just had a vertebral fracture. So what is this risk in absolute terms has been shown here in a very large analysis from the Medicare database in the US, patients age 65 and plus. So you see their initial fracture at the bottom, various types of osteoporotic fractures. And then you see the cumulative rate of a second fracture here on the y-axis, and it's stratified by age. So again, if you've had an initial vertebral fracture, you have about 25% of those patients who have a second fracture in a couple of years. And for the major peripheral fractures, it's about 15 to 20% who has a second fracture in just a couple of years. So again, this is a very large risk, 1 in 4, 1 in 5 patients with a second fracture in 2 years. This defines this very special category of patients at imminent risk, who of course deserve immediate therapy to try to prevent the second fracture. And again, this is one of the latest study in this context is the risk of hip fracture specifically after an index fracture. So it's again a very large cohort, this time from Canada. And you see that whatever your initial fracture, about 30% will have the hip as the second fracture. And if your first fracture was hip, 33% will have the contralateral hip as the second fracture in just a couple of years. So not only is your general risk of refracturing very high after within 2 years after your baseline fracture, but among the secondary fractures, hip is often the concern. And as we all know, hip fractures are the ones that are most susceptible to result in morbidity and high mortality. So if we have someone with a recent fracture, particularly a recent major osteoporotic fracture, identified as someone at imminent fracture risk, and we initiate therapy, we need to have a therapy that will be very efficient in a short time frame within these couple of years. And we need a therapy that will be particularly efficient in reducing hip fractures because, again, a third of the second fracture will be at the hip. Now, what are the causes for this refracture risk and this imminent fracture risk? Well, of course, the initial fracture itself is the demonstration that there is a weakness in the skeleton. That's the first reason. But besides that, here you see a list of comorbidities that explain this imminent risk of a second fracture. And particularly the patients who have a history of falls and the frailest patients are the one with the highest relative risk of a second fracture within a couple of years. Of course, age, again, is important for this imminent risk. And as I said, the comorbidities, particularly if you have dementia or other CNS disorders and some medications, as you know, that will potentially cause falls and loss of consciousness. So any one of the reasons will precipitate the risk for a second fracture. And that reminds us that when we take care of patients with recent fractures, it's not just about giving them an appropriate osteoporosis therapy very soon, but it's also about potentially taking care of their other risk factors for falls. That would include, of course, to review the medication chart and discard anything that is not useful, and all these other measures to prevent those falls and refractures. Now, we've talked about imminent risk. So anyone with a recent major osteoporotic fracture is a primary target, and this is exactly why fracture liaison services exist and orient those patients towards a bone specialist to initiate therapy and, as I said, falls prevention. Now, more broadly, how do we find very high risk? And the tool that is used internationally here is FRAX. So this is just an example using FRAX in Switzerland to remind you how the risk is built by age, sex, weight, and height, previous fracture in this case, parental history, other risk factors, plus minus BMD, in this case, not very low, but because of the previous fracture and the age, FRAX calculate a 10 years probability of fracture of 25%. And hip fracture 4.5%. Now, this tool has been used to define various risk categories depending on the 10-year probability of fracture. And as you know, this is from the UK on the left, we define a so-called intervention threshold, which is the 10-year probability of fracture by FRAX, above which a treatment is recommended. Below that, the risk is considered to be more moderate and lifestyle measures are more recommended. Now, the threshold for intervention varies country by country. You see here several countries from the Asia-Pacific region who have established a different threshold to define what's the high risk. Note it's here usually a sliding scale. It's a threshold that depends on age. So, for example, in this case, 10% probability of fracture at age 50 will be considered high risk and deserve therapy. But as you get older, you need to have a higher fracture risk to be recommended for therapy. And this, again, threshold varies country by country. Now, until now, this world of dividing risk by the intervention threshold was a bit black and white. You were either below moderate risk, no treatment, or above high risk, considered treatment. But more recently, this has been stratified further. Stratified further as low, high, and very high risk. So very high risk is a probability of fracture that is way above the usual intervention threshold. And there are several patient scenarios that fit into that. I'll show you a few of them. But what's important here with this sort of super high risk category is to define a group in whom a different strategy will perhaps be helpful to initiate therapy. So as I said before, typically if you're low risk, it's lifestyle measures, perhaps if you're still early postmenopause, hormone replacement therapy. If you are high risk above the intervention threshold, we usually start therapy with anti-resorptives, bisphosphonates, or perhaps denosumab. But now, if you are very high risk, the recommendations here are to consider an anabolic therapy first. And when we say anabolic therapy first in these patients, who are these patients? So this is some examples of who would fall in the very high risk category according to the UK FRAX example. This 70-year-old woman with a prior fracture and a family history of fracture will have a 10-year probability of fracture by about 30%. And she would be considered not only to be above the intervention threshold and deserve therapy, but be far above the intervention threshold and fall in the very high risk category. Another example, still 7 years of age, is someone with a recent spine fracture. We saw before that we call this at imminent risk. Well, anyone at imminent risk is by definition at very high risk. And you can take other examples, 6 years old with a high dose corticoids, for example, for inflammatory disorder, 10-year probability of fracture 15%, but because she's younger, should also qualify for very high risk in this particular case. So having defined this super high risk category, plus those with recent fractures, what shall we do? Well, the recommendations say, here we need anabolic therapy. So when we talk about anabolic therapy, as you know, there is two categories here, basically. We have the PTH receptor agonists, so teriparatide, or in some countries, abaloparatide. And then we have a sclerostin antibodies, romosozumab. And this is to remind you that the mode of action of those anabolics is very different. Teriparatide, and to some extent abaloparatide, they stimulate new bone formation, mostly through remodeling, which means they stimulate osteoblast and osteoclast activity. Romosozumab, sclerostin antibody, in contrast, stimulates bone formation mostly through modeling-based processes. So by activating lining cells that become osteoblasts without the intervention of the bone resorbing cell. In contrast, on the remodeling side, they have negative effects. So they inhibit resorption while stimulating bone formation. So two very different profile of stimulating bone formation. Now, the reason why anabolics first have been advocated in very high-risk patients is shown here. It's because if you rely on the published studies, you would spare more fractures with those drugs compared to your standard alendronate. So what you see here, the black columns, is a calculation of the number of fractures that you could spare with these drugs if you treat 1,000 subjects with a recent fracture. So if you do that, you would spare 20 fractures with alendronate, 40 with denosumab, 45 with teriparatide, and up to 60 with romosozumab. And this is more fractures spared than if you treat patients in the white column who are at lower risk, who do not have a recent fracture. So treating patients with a recent fracture at imminent risk, very high risk, gives you more rewards for your spending because you spare more fractures by treating 1,000 subjects. And if you use parenteral drugs and particularly anabolics, you're going to be more efficient in these very high risk, imminent risk patients than if you use alendronate. So the second part, having defined those patients at imminent risk and very high risk, the question is why romosozumab in particular? And romosozumab, this sclerostin antibody, has indeed several advantages in this regard. First of all, this is an analysis of the FRAME trial. So FRAME is a trial of 8,000 postmenopausal women with osteoporosis who have received either romosozumab or placebo. And you see here the risk reduction of clinical fractures on the left and non-vertebral fractures on the right based on the risk at baseline. So this is calculated by FRAX again. So as you move to the right, you have the women at the highest risk. And you see that the higher the baseline risk, the more fracture reductions you have, significantly so, for both clinical and non-vertebral. Now remember, this is with romosozumab for 1 year, just 1 year, right? And therefore, it shows for the first time that with this drug, we can reduce clinical fractures and non-vertebral fractures within just 1 year of therapy in very high-risk women. That's going to be very useful, right? Because we're dealing with women who have an imminent fracture risk, and we have a drug that can act so quickly that it can reduce the fracture even in those at the highest risk in a very short time frame. This is also shown in this sub-analysis of this FRAME study. What you see again is now is a subset of the FRAME study at higher risk, women recruited in Europe, about 3,000 women in Europe. And you see here the reduction in non-vertebral fractures by 1 year of treatment, Romo versus placebo. It's a significant 53% reduction. And then at 24 and 36 months, it's when the patients romosozumab are then switched to denosumab. And of course, that maintains a greater fracture risk reduction than those who started on placebo and then went on denosumab. This is also true for clinical fractures and even for hip fractures, small numbers, but you see again, even with hip fractures from year one, you have a very interesting trend here for fewer risk fractures on Romo compared to a placebo, again, in just 1 year. And if you go to 2 years, which is romosozumab 1 year, denosumab 1 year, versus placebo denosumab, it's significant. So in these two famous years where you have the highest risk after an initial fracture, you have significant reductions in all type of major peripheral fractures, including the hip, when you start with 1 year of romosozumab. Now, the other reason why it's so interesting, this drug, is because you will regain bone density very quickly and very sharply. That is from the phase 2 study, head-to-head comparison of placebo, alendronate, teriparatide, and romosozumab, again in postmenopausal women with osteoporosis. And you appreciate that romosozumab gives you gains of bone density at spine and hip that are about twice as high as with alendronate or even teriparatide. And again, in just 12 months, gaining 11% at spine, 4-5% at the hip. This is worth like years of an anti-resorptive therapy alone. And to demonstrate that, this is the BMD gain at the lumbar spine with 1 year of romosozumab in green, followed by 1 year of denosumab in blue. So this is 2 years of therapy. Gains of spine BMD are expressed not in percentage, but as real T-scores. So it's a gain of about 1.2 T-score in 2 years of therapy. And to obtain the same on an anti-resorptive, here, for example, on denosumab from the extension trial, it will require 7 years. So with Romo, you reduce fractures very quickly and you regain a lot of bone density in just a year. And if you follow with an anti-resorptive like denosumab, you will gain even more bone density in just a couple of years. So those patients at the highest risk you will sort of restore a virtually normal situation in a very short time frame. Shown differently, this graph shows you the probability to get and regain bone density above minus 2.5, depending on where you started and with different strategies. So say you start with a very low bone density at the spine, minus 3.5, okay? And I give you a alendronate. Well, your probability to go from minus 3.5 to better than minus 2.5, better than osteoporosis, with just alendronate is virtually zero. Maybe 10% will get there. If I use romosozumab first, followed then by alendronate, then I have about 40% of those patients who will eventually get above minus 2.5 at the spine. And then if I use this sequence here in orange, romosozumab followed by denosumab, I can bring 60–70% of patients above the osteoporosis threshold starting at minus 3.5. So this sequence, romo followed by denosumab, gives you the best probability to achieve T-scores above minus 2.5, particularly therefore useful in patients who would start with very low bone densities. And if you look here for hip, if you take someone started on minus 3 on alendronate, virtually no chance to get above minus 2.5. You start with romo followed by alendronate, it's about 40% getting above minus 2.5. And if you start with romosozumab and then go to denosumab, it's something about 60–70% who go from minus 3 to better than minus 2.5. Now, remember one thing, which is the great effects of romosozumab on bone density very much depend on the previous therapy or absence of previous therapy. So what you see here is results from 3 different trials that analyze the BMD gain on romosozumab if you are naive of treatment, that's the green columns. If you were previously on alendronate, that's the orange column, or if you were previously on denosumab. And what you see is that the greatest benefits from romosozumab are in naive patients. If you come from bisphosphonate, the bone gain with romo is about cut by half. And if you cut from denosumab, it's even less. So obviously, the best sequence is romo first and then the anti-resorptive, which you see on the right, and not the anti-resorptive first and then romo. And this is again a reason why the algorithm that I've shown to you indicates that in the very high-risk patients, it's better to start with the anabolic, and particularly with romo, followed by an anti-resorptive, rather than start with an anti-resorptive, wait a couple of years, see that it doesn't really work, and then you add an anabolic, and what you've done, you've lost the full potential of the anabolic therapy. Now, the only problem with romo is that in the ARCH trial, compared to alendronate, it had a few more adverse events of myocardial infarction and stroke. Now, these were very few events if you consider the very large number of patients who were treated, but that has justified some warning. You see here the accumulation of those cardiovascular adverse events with romosozumab in the ARCH trial. And you see here the other groups with the other comparators, including the romosozumab in the FRAME trial. So what was strange, if you like, was these few more cardiovascular events were seen in one of the trials with romo and not in the other. So it is not really sure if it's an effect of romosozumab or chance finding, but the review of these events by the FDA led them to a cautious statement, which is to say that Evenity, which is romosozumab, should not be initiated in patients with an MIO stroke in the preceding year at least. And I would say more globally, better not give this drug to patients with a clear cardiovascular risk, previous events whenever they happen, just because we don't really know if it's a risk with the treatment or not. Now, I'd like to show you what the real patients on Romo look like. And this is from my own experience. So this is one of my patients from last week, actually. She's a woman, age 69. She had a previous history of bronchial carcinoid, but this was benign. However, she had breast cancer, which was treated with radiotherapy and chemotherapy. No aromatase inhibitors because her tumor was estrogen receptor negative. And then a few years later, she presented with spontaneous vertebral fractures, first of the dorsal 8 and dorsal 9. Unfortunately, she had no DEXA, no osteoporosis treatment at that time by her doctor, besides calcium and vitamin D. And then a few years later, at 68, she had new severe vertebral fracture of dorsal level 12, gen grade 3, which means really a crushed, complete crushed fracture. And that's when she was sent to me. So she has no other osteoporosis risk factors than her age, which means postmenopause and perhaps the chemotherapy. And she clearly clinically has those fractures because she has dorsal kyphosis and her costal pelvic distance is less than 1 centimeter. Her DEXA is not impressive, but it's hard to interpret, of course, because her spine BMD, which on average is -2 T-score, actually between vertebrae there is a large range, and at her age there is also some arthritic transformations there. The labs looks normal. P1P is not particularly increased, just a bit higher, and I don't have CTX. So the conclusion is that she represents one of these patients who is at imminent and very high risk. Imminent because she has a recent vertebral fracture, very high risk because she has multiple previous fractures and was never treated. And so she is the typical patient for Romo. She has no history of cardiovascular events, and she's Romo also because teriparatide here is contraindicated because of the history of radiotherapy to her chest for the breast cancer. So she'd be one of them. I'll show you a few more. This is actually 14 patients whose treatment has been studied with romosozumab since about a year. We've been using Romo here since about a year now. The mean age of our patients is 66 with a large range. In 7 cases, there is a recent fracture. So they represent those imminent risks that I explained to you in the beginning. 5 of them actually have a history of multiple osteoporotic fractures, so very high risk. The mean T-score is low, as you see, at spine is -3.5, underscoring that those are typically patients with long-standing, very severe osteoporosis. And of course, by definition, none of them has previous MI or stroke, but we included 4 patients in treatment who had a history of cancer. This is just to emphasize that in principle, and contrary to teriparatide, there is no contraindication for patients with a previous cancer. Now, what happens with the treatment, which is, as you remember, a monthly subcutaneous therapy? The most common adverse events we see is skin reactions. Yes, they do. We see a majority of them. At some point, some irritation at the point of the subcutaneous injections, which needs to be rotated, but they were never major to the point of stopping therapy. In contrast, we monitored them for serum calcium at months 1 and 2. We never saw hypocalcemia. Of course, we never saw a cardiovascular event so far, and none of them had a fracture in the course of therapy. The vast majority is still on treatment, and I don't have the BMD data at 1 year to show how beneficial it was. But what I have here is some profile of the bone turnover markers just to illustrate that romosozumab in naive patients does exactly what you expect. You see the CTX levels at baseline and at 3 and 6 months. So in general, CTX goes down, reflecting the anti-resorptive effect of the drug. And P1NP, the bone formation marker, goes up, particularly at 3 months, illustrating the bone forming effect. Now, I don't think one needs to measure CTX and P1NP to monitor the effects of therapy. We do, be it only for the pleasure to see how well it works. And we are now expecting the BMD data at 1 year in those first few patients that we've treated. So in conclusions, I'd like you to bring home a few take-home messages here. Patients with a recent major osteoporotic fracture are at very high risk of a subsequent fracture. A third of the second fractures occurs at the hip. So we need therapies that are efficient quickly and efficient also on the hip. FRAX is helpful to identify patients at very high risk defined as way above your usual intervention threshold. Now, those patients with imminent and very high risk are suitable for anabolic therapy as a first intention. And in the available anabolic therapies, I've shown that romosozumab provides very large BMD gains within just a year, even better if it's continued by denosumab. And they provide fracture risk reduction in 1 to 2 years, including at peripheral sites, which is really, I think, a breakthrough in osteoporosis therapy for these very high-risk patients. With that, I'd like to thank you very much for your attention, and I'll be glad later to take some questions. Thank you very much.
Ferrari for this very comprehensive talk. Before we take a few questions, I would like to start by asking you and bringing you again to this risk stratification, which is, I think, a major thing, because you have introduced probably a new way of stratifying the risk in those relatively young patients who would not classify as very high risk patients according to the current guidelines and current way of stratifying patients, but in whom you consider that they are at high risk anyways because of the imminent, because of a recent history of fracture. So basically, when you have a 60-year-old female who with a T-score, let's say osteopenic, but who had fractured recently, 2 months ago, a vertebral fracture. So this is a patient that you would treat with an anabolic. Am I right? Right. So 2 questions here. The imminent fracture concept doesn't exist yet in the FRAX. So when you stratify the risk using FRAX, we miss those patients. So do you think that we should revise our way of stratifying the risk in those fractures? And the second question is, this risk stratification, I guess, is something very dynamic, because in that specific patient, the 60-year-old, osteopenic lady who who has been classified, who's been offered an anabolic agent, if within 2 years she doesn't fracture and her T-score doesn't go, significantly low, then you would probably 2 years later re-stratify her risk as moderate or probably just high. Is that correct? That's what I wanted to.
Yeah, well, thank you very much for the comments. Good morning, everyone, anyway. Yeah, so your first question, I think you're absolutely right. I mean, there is imminent risk and there is FRAX. I mean, someone with a major osteoporotic fracture is at imminent risk of another one within a couple of years. So your example, 6 years old, recent vertebral fracture, 20 to 25% of those patients will have a second fracture in a couple of years if we do nothing. In that context, I don't think FRAX is useful, because we already have the hallmark of the severity of the disease. We have a fracture and we need to treat them because they have a fracture. So FRAX is mostly useful to define this very high risk category for those who don't have a recent fracture. Now, that being said, there are now some studies coming out to provide us with an adjustment factor so that when we calculate the FRAX and we, in someone with a fracture, we can take into account if it's a recent one. And for example, in an analysis from the cohort in the Icelandic cohort, for the woman who you describe, 6 years old with a vertebral fracture, if your FRAX calculates a probability of 20-25%, you should actually adjust that probability, multiplying by 1.5 if the vertebral fracture is recent. So there are adjustments for FRAX that are being developed to take into account the recency of the fracture and also the type of the fracture, because it's obviously not the same risk if you have, like you mentioned, a vertebral fracture or a wrist fracture or a hip fracture. So those adjustments are being made as we speak. But from a practical point of view, again, I repeat, the case scenario that you mentioned, I don't need FRAX to treat her. I know she is imminent risk. She has a major sporadic fracture that just happened. And yes, I would start with an anabolic therapy.
Okay.
For your second question, is that an evolving scenario? Yes, absolutely. Because this imminent risk, which is a relative risk that is very high, is within the first couple of years. Then it slowly comes down to about twofold the general risk of the population. So as you say, after 2 years, if you recalculate, well, your FRAX will be negatively influenced because she's now older, but at the same time, she's further away from a base fracture, so you don't need an adjustment for the recent fracture anymore. So the FRAX could actually go down after a while. Absolutely.
Okay, thank you very much. So we have a question here on the floor. Dr. Ahmed Zayat, please.
So, okay, thank you very much for the excellent talk. And I like your trying to resemble romosozumab to Rolls-Royce. You didn't use Ferrari as an example. But anyway, I got two questions. The first one, which is really intriguing, because what we used to see in terms of bone units, whenever you increase the CTX or reduce the CTX, the other one, the P1MP goes down. If you increase it, so whenever you inhibit the osteoblast will be inhibited as well to a lesser degree with medication that we've seen with bisphosphonate, with teriparatide, the P1MP increase, the CTX increase as well to a lesser degree. But here, it's the opposite. You see the B1MP shoots up, the CTX drops down as if you're inducing the osteoclast and inhibiting inducing the osteoblast and inhibiting the osteoclast at the same time. How is that happening with us inhibiting the sclerostin?
Yeah, thank you for the question. Yes, so yes, indeed, the profile of the markers reflects, as I mentioned, a very unique mechanism of action. Remember, the target of romosozumab is sclerostin, and sclerostin is an inhibitor of bone formation in the first place. So when you inhibit sclerostin, you're the enemy of my enemy, and so bone formation goes up from the lining cells that are stimulated from scratch. How inhibition of sclerostin results in an inhibition of resorption is yet not entirely clear. There is one mechanism by which sclerostin usually stimulates rank ligand. So if you inhibit sclerostin, you indirectly inhibit rank ligand from the osteocytes, but that's not the only mechanism. There are probably crosstalks with other pathways that explain how sclerostin inhibition results in an anti-resorptive activity. I think clinically speaking, what's important, of course, is when we think of these anabolic effects, what we call the anabolic window, which is the difference between bone formation and bone resorption. Well, one can easily imagine that if I increase formation and decrease resorption, the difference between the two, my anabolic window, is very large. And that probably explains why the BMD gains are twice as much with Romo than with anything else.
Okay, thank you very much. A second question, Joe, osteonecrosis, what's the risk here?
As far as I remember, it's not been reported in any of the trials during romosozumab. First of all, remember, it's a short-term therapy, it's 1 year. Can be repeated further down the line, but basically the trials are 1 year. Obviously, because of the bone forming effect, this does not seem to be an important risk.
Okay.
Thank you.
Thank you, Dr. Ferrari. I think that we're not having any further question. Very quick question before we close this session. From your experience, do you think that the real world evidence data now with Romo is a bit more reassuring than the clinical trials with regards to the cardiovascular risk?
Yeah, well, definitely from the real world reports data that we have, particularly there is a very large number of patients on Romo in Japan, because we were the first to prescribe. It doesn't seem to increase the cardiovascular risk. Now, as you know, in real world, it's I mean, if the patients are properly selected from the beginning, and you discard those with high cardiovascular risk, you may not see that. But yes, you're right. It's very reassuring so far.
Correct. I think we're having one last question before we close. Yeah, please, Diana.
Thank you very much for the lovely talk. I just want to ask you that do you have any data of using this Evenity in premenopausal ladies?
In premenopausal.
So the answer is no, and the indication is postmenopausal osteoporosis. Now, that being said, there are other sclerostin antibodies which are now in a trial in osteogenesis imperfecta, and with potentially interesting results. So stay tuned, there may be more indications in the future.
Okay, so with this, we come to the end of this session. I would like to thank our speaker, Dr. Ferrari from Switzerland, and invite all the audience for the lunch. We'll be back here at 1:30 for another symposium before we resume the semi-sessions at 2 p.m. Thank you.
عندما يتقدم بنا العمر تصبح عظامنا ضعيفة مع الوقت من دون أن نشعر، وتعرف هذه الحالة طبياً بمرض هشاشة العظام. وعادة لا تكتشف هذه الحالات إلا مع حدوث كسر في العظام نتيجة اصطدام أو وقوع. تتحلل عظامنا وتتجدد في توازن مستمر، وتحدث هشاشة العظام نتيجة اختلال هذا التوازن، مما يؤدي إلى ضعف العظام مع تقدمنا في العمر. بالنسبة للنساء، يحافظ هرمون الإستروجين في أجسادهن على توازن هذه العملية، ولكن بعد انقطاع الطمث يقل هرمون الإستروجين، مما يؤدي إلى اختلال هذا التوازن. بعد سن 50 تعد 1 من كل امرأتين عرضة لكسور الهشاشة، بينما في الرجال يبلغ المعدل 1 من كل 5 في نفس المرحلة العمرية. لذلك فإن الوقت هام جداً، لأن العظام المكسورة تصبح عرضة للكسر مرة أخرى، وإذا لم تعالج هذه الكسور بالشكل المناسب فإنها قد تعوق الحركة، وقد تؤثر سلباً على النشاط اليومي المعتاد. ولكن الخبر السار هو أنه أصبح لدينا أدوات متعددة للمساعدة على التشخيص المبكر وعلاج ومقاومة مرض هشاشة العظام عن أي وقت سبق. اتباع نظام غذائي صحي والتمارين المنتظمة يساعدان على تحسين صحة العظام. تحسين نمط الحياة عن طريق تجنب بعض العادات السيئة وتبني أخرى صحية يساعد أيضاً على تفادي الإصابة بالكسور. هناك أيضاً العديد من الأدوية المتاحة والتي تساعد على تحسين قوة العظام وتقليل احتمالية الإصابة بالكسور. يقوم الطبيب بوضع خطة العلاج الأمثل بناء على كل حالة ونتائج اختباراتها، ولكن الأهم هو الالتزام بهذه الخطة لضمان أفضل النتائج المرجوة من العلاج. لا تدعي مرض هشاشة العظام يكسرك بسهولة، واستشيري طبيبك الآن لتحمي مستقبلك.
So thanks for staying with us. So moving to the next session, our next talk is about biosimilars, Back to the Future. Our speaker here is Dr. Gerd Burmester. Professor Burmester is Professor of Medicine in the Department of Rheumatology and Clinical Immunology at the Charité University Hospital, Free University, and Humboldt University of Berlin in Germany. Probably you've seen Professor Burmester in multiple few events and talks. He's very well-known figures in EULAR, as he's been a board member in multiple EULAR committees and meeting, has been the president in EULAR from 2015 to 2017 and served as immediate post-president of EULAR until 2019. Professor Burmester is going to speak to us about biosimilars today. Thank you very much.
So thank you very much, Dr. Zayat, and it's a pleasure for me to be here, at least virtually. As Dr. Alton pointed out, I would like to be with you in presence in beautiful Dubai, especially at this time of the year. But of course, we'll have to wait a little bit until the pandemic might be over, at least better controlled as it is currently. And we still have a number of cases, quite a high number of cases in Berlin. So traveling is very difficult. I've been asked and honored to give you two talks, and one is pertaining to biosimilars. And a little bit later, I will talk to you about some highlights, which I believe was important in rheumatology in the last year. But let us start with biosimilars. And these are my disclosures. And when we look into the hallmarks of treatment of rheumatic diseases, I think we have several milestones. Obviously, on the left-hand side, you see the glucocorticoids, and then the methotrexate in 1988, and in dark green, you see the biologics, and finally, the small molecules, but maybe a little bit unnoticed, but I think it's also some kind of a revolution, an important milestone, are the biosimilars of various biologic DMARDs. And so you see here the EMA approval, FDA approval of many of the biologics we use in rheumatology. And around, let's say, like 2015, depending on various countries, we had the biosimilars regarding, for instance, in infliximab, but also adalimumab and etanercept, so the TNF blocking agent. And that I think is very important because due to the lower cost, these very important drugs can be made available to more patients in the world. So you see here that there are quite a few approved indications for biological therapy. And that, of course, is extremely important, that diseases that were very difficult to treat in the past, many resistant cases, now be quite nicely controlled using biologics, and of course, later on also the JAK inhibitors. For those of you who are interested in the changing landscape of biosimilars, they are referred to this particular paper, which we published a number of years ago, but many of the items in that paper are very valid still and pave the way to the usage of biosimilars. So what are they? They are biotechnology produced protein-based imitation drug substances that are approved after the patent period of an original active ingredient has expired. The active ingredients of these novel technology products, unlike the classic molecular structure-defined drugs, are not completely identical to the original active ingredient. So that's why they're called similar, not identical, and therefore require more complex approval procedures and monitoring measures than the classical generic. So it's easy, I will point out later, to produce an aspirin generic, but to produce an identical molecule to a biologic is basically impossible. You can only do it in a very similar way. Why is that so? Well, the main reasons for these differences are the different cellular systems on which the target proteins are expressed, and the other procedures used, such as separation and purification, and common differences are different glycosylation patterns and several others. And the drug substance is an active ingredient that is identical, usually very identical, exactly the same in amino acid sequence to the original, but how this is processed and other glycosylation issues and so on are different. So the definition here is of the WHO. A biosimilar is a biotherapeutic product which is similar in terms of quality, safety, and efficacy to an already licensed reference biotherapeutic product, with similarity defined as the absence of relative difference in the parameter of interest. And what the parameters of interest are, I will point out later. Obviously, due to the tremendous success in some of the biologics that we are using, are the most sold drugs in terms of volume ever on Earth. So there is a tremendous economic item to address. And that's why, for instance, here in the German JAMA equivalent, it says the race is really in full swing, was at the was presented in 2014 already, when this race really started. Please note that unlike the biologics that we have in rheumatology, like infliximab, for instance, many other biologics had already been used, such as somatropin, filgrastim, erythropoietin, and so on. So it's not a new context to have these biosimilar, and so therefore we have to take into account that there is quite a tradition already in biosimilars. However, of course, the monoclonal antibodies are the most complex molecules to produce. So in 2016, you see here how the development phase, the race really started with, of course, our standard drugs in rheumatology like adalimumab, etanercept, infliximab here. Various companies embarking on that. Not all companies succeeded in having ready-made products, but many of them did. So biosimilar entries, of course, are highly challenging. It's not like aspirin generic that you can easily introduce into the market. So there is an extensively regulated item with long-term commitments. That is important, long-term commitments. So you cannot just found a company and close it a couple of months later. No, that needs complex approval systems and so on. So this may also be country-specific, obviously. So there is heavily competition with high interest from the originators. Obviously, the originator companies don't have a tremendous interest that biosimilars are also coming to the market, competing with their products. So there have been several interesting items here being raised by the original companies. Also, the physician didn't know much about it in 2013. As you see here, this has, of course, changed a lot. You see here, they were quite, they had never heard in 2013 of them, what is substantial they had heard, they couldn't define it, and they were not very familiar, but that, of course, has changed. And a very important question is, are there any incentives for the prescribing physician or the patients to accept new products? So this is very important. So why should a physician prescribe a new product that the physician is not aware of, hasn't heard about it so much, and the patients, why should they accept a new product when they are used to the older ones? Obviously, that needs to be addressed as well, and I will come to that later. Biosimilars are biopharmaceutical that are extremely similar to the reference drug. You see here the composition, and biosimilars can be marketed after the expiry of the market exclusivity, but they must be very similar to the reference biopharmaceutical in terms of quality, safety, efficacy, and immunogenicity. That is not easy. Now let's have a look into an aspirin molecule. So this is just 21 atoms. On the right-hand side, you see how this refers to a monoclonal antibody, which is more than 1,000-fold larger, much more complex. So you immediately realize that it's so much more difficult to produce a monoclonal antibody of biosimilar nature compared to an aspirin molecule. What does it involve? So first of all, of course, antibody development, then the expression system. You have to take the appropriate media. The cell culture system is important, purification, protein analysis, then the formulation into the aseptic bulkware, finally dosing and filling, what syringes, which pens do you take, and so on. That's certainly not trivial, and you see all this machinery that is involved here. And also you have to realize that a biologic is a mixture of isoforms and inherently variable. Just take a few items like glycosylation, chemical modifications. I will not go into all the details. Basically, you have 10 to the 8th possibilities to produce different molecules. Nevertheless, you see the amino acid sequence is exactly the same. So the modifications can change the protein. And the FDA used the fingerprint example, which I think is very nice. So you have the overall structure, glycosylation pattern, and also the chart of the protein. And the non-identicality is an intrinsic property of the biologic molecules. As I mentioned, we have more than 10 to the 8th potential variations. You have to realize that different batches of the reference preparation are analyzed to determine the range for each quality characteristic. I will come to that even the original products are not identical. The importance of the different chemical isoforms should be understood. And finally, each quality characteristic forms the analytical fingerprint of the reference drug and defines the target points of the biosimilar. And so you see here that this process involves the variability which is inevitable even for the original or reference products and the biosimilars. So you see here a normal variability in quality attributes, the trend and the shifts here that you have to take into account when you look into biologics. And also manufacturing changes have been a part of the biologics all along. So even, let's say, etanercept, adalimumab, and infliximab, and so on, and you see here many other biologics went a number of changes, even caught with so-called high risk or with moderate risk or no risk. And it's very important to take into account that even the original products, due to the complicated production system, underwent these changes. So you have to address physical chemically characteristics such as glycosylation. There are some in the constant regions. There are, of course, also biological characteristics such as binding, effector functions, and of course, immunogenicity was a real concern initially. One example, for instance, this is the biosimilar is called SP4. Some aspects of the development, analytical characterization, And you see here that 151 lots of reference etanercepts were taken from the EU, United States, and some other parts of the world, and they were characterized using state-of-the-art assays, and a biosimilarity range was established for each CQA using appropriate statistical methods. And you see here that they're already within these lots. However, within defined margin, there's quite a variability in the etanercept lots. Yeah. So what can this be based on? Structural characterization, electrophoresis, glycan profile, and so on. So the physical chemical analysis, taking all these into account, is quite complicated and actually requires more than 55. So here you immediately understand that it's not trivial for a biopharmaceutical company to produce a biosimilar, and it costs several hundreds of millions to produce a reliably, finally approved, FDA or EMA approved. So what you have binding assays, you have Fc mediator function, and some non-mechanism of action biological assays that we use. Then you establish the comprehensive biosimilarity. The results support then the biosimilarity conclusion. And in the case of SB4, as an example, the EMA explained that there is no issue that could question the biosimilarity claim of SB4 to reference it. Basically, was very similar. So what are the requirements for approval? So it's a molecular and structural characterization, test system like ADCC, PK, and so pharmacokinetics and pharmacodynamic similarity with original, and you need to do at least one trial. And I'll come to that later because they say the trial could have been performed in rheumatoid arthritis and is then extrapolated, for instance, to inflammatory bowel disease. And that was a very difficult concept step initially. Now let's have some looks into our example, SB4 compared to etanercept. And when you look into these curves, like the PK, serum concentration, the curves are entirely superimposable. It doesn't really matter if this was EU or United States material. Also, going back to the clinic, you see that the action was very similar in terms here of ACR 20, ACR 50, and 70, and also the deaths. I will be very quick because it's very simple. You see that immediately that all these curves are basically superimposable, even looking into the radiological destruction using the total Sharp score. Then you, of course, may ask, well, what about the safety? And if you look into the etanercept biosimilar as before, and the etanercept, you basically see very, very similar numbers, if not identical in several aspects. Also, the safety profile is good. And when we look into another example, this is called SB2, and infliximab, again, you see these superimposable curves regarding here in this mean test 28, again, modified Sharp score, and the safety. Well, very similar comparing SB2 and infliximab. Next question, and that was quite a concern initially. I didn't really have this concern because the immunogenicity is usually caused by the idiotype. There is not so much variation in that part of the monoclonal antibody, and that is corroborated by the immunogenicity data that you have no difference in antibodies. You may ask, oh, okay, these were the anti-TNF agents. What about another agent that we use? Rituximab, and here you see a biosimilar called AVP compared to the original rituximab, either purchased in the US or in the EU, and basically looking into the DES28 in patients with rheumatoid arthritis. Next question is, okay, but how to switch? To put a new patient on a biosimilar is quite easy, but the switch is a little bit different because the patient is used to the original drug, the physician is used to the original drug. So what about switching? And that was addressed in several very important studies. One, the NOR switch study was really like a classical study already presented in 2016, and many colleagues went to Tor Green, who was one of the investigators, and said, well, Tor, what about the data? We're really waiting for it. I will not go into all the details. I will just read the conclusion to you. Northwich trial demonstrated that switching from infliximab to the biosimilar CT-E13 was not inferior to continued treatment with infliximab. Here, when you look into the various diseases, very similar. So you can actually switch from the original product to the okay, that was infliximab in that case. And what about another study using SP2 with infliximab? And you see here that also here switching was possible, no different data. So in conclusion, this SP2 phase 3 trial demonstrated that there is an equivalent with the original Remicade in terms of ACR 20, and also in other items, the incidence of side effects was similar, infusion reaction was similar, and there were a little bit higher, not statistically, higher anti-drug antibodies in SP2 compared to Remicade. You will always find, because you can never be exact, some subtle differences. So the conclusion was both SP2 and SP4 that I showed you were well tolerated, comparable immunogenicity and comparable efficacy, even up to week, quite substantial already. So how did that change in the access to biological DMARDs in Europe? And you will see here that there are some countries where it is quite easy to get a biologic, and in some countries it is intermediate, in some countries it is very difficult, as you see here. And so we hope, and in Germany actually in the middle range, because it was not so easy to prescribe these drugs, because there were some regulations in Germany and the fear for litigations by the health insurance companies, so that Germany is not like the UK or Spain or the Scandinavian countries. The next question, of course, ranges already addressed it to extrapolation. So if you have a drug that is working in rheumatoid arthritis, or let's say psoriasis, does that also work in a quite different disease, like, for instance, inflammatory bowel disease? You need adequate evidence of comparability and satisfactory scientific justification that was provided. And here you see what was already analyzed as a solid base for extrapolation. Again, an example, but you can take other examples as well here, the infliximab SP2. So finally, the EMA said, well, extrapolation of data is an established scientific and regulatory principle. EMA approved the extrapolation, especially if there is adequate clinical evidence for the similarity of the biosimilar. Then extrapolation to another indication is clinically and scientifically sufficiently justified. And EMA stated, well, we have already done that, for instance, in the cancer anti-HER2 monoclonal antibodies. What are important items here? Well, virtually all data demonstrate that switching, transitioning from an original biological DMARD to an EMA FDA-approved biological synthetic DMARD is a biological DMARD is safe, so the biosimilar DMARD. Cost saving is a major issue, potentially resulting in better access for more people. That is, of course, important if you have a fixed budget in a country and you can only treat so many patients with a biological with that limited amount of money. Then if you have a less expensive product, you can simply treat more patients. That is very important. Nevertheless, there might be a potential nocebo effect. The patient knows, well, I took my original product for many years. It helped me so tremendously, but now I get a strange product which sounds different and maybe a different package insert and so on. And the patient is a little bit worried that it doesn't work as well as the original product. So that needs a good communication to our patients. And of course, we need more data, even though we have a few already that show how many switches, actually, that is important, are possible including going back to the originator, because the originator molecule may be less expensive than a biosimilar, because the company said, well, we want to compete with our follow-up product. So where are we now? And you see here that in Europe, we have quite a few biosimilars with many, many names. And that is obviously also a challenge in daily clinical practice. I mean, in the beginning, you just had the original products. You needed to memorize just a few names, but now you need to memorize quite a bit. You see here, adalimumab, the name could be Amdevita, Imraldi. I specifically read them to you because they are used like this in the registries also in order to find out particular items and so on. So you really have to memorize them, and which one to pick is not so easy. In Germany, probably it will be that they are in the computer of pharmacists, and maybe the least expensive at that particular time point may go up and may have to be performed. So there are some ideas in Germany, for instance, how to get the least expensive product to the patient in order to save money. And this is actually, and I can secretly tell you, was not based on rheumatology so much. We are expensive, but by far not as expensive as the oncologists, where you sometimes pay huge amounts of money for monoclonal antibodies. And in order to get access to more patients, therefore, it is important to look into the cost issues. And here is a nice example in a shift from adalimumab originator to biosimilar in Denmark. You see on the left-hand side the quantity sold to patients in adalimumab. So that didn't really change when the biosimilar was introduced. What changed after the red dotted line is actually the cost. So it's really a tremendous cost saving, because adalimumab biosimilar was 5 times lower in cost than the branded version. And you can imagine that with this amount of money that you save, you can potentially treat many more patients or allocate other healthcare resources to other populations. So in summary, in Europe, the development of biosimilars is regulated by the EMA, in the United States by FDA, and that requires a stepwise approach in confirming the similarity of the biosimilar to its reference product. I have told you that this is not a trivial process. It is really very, very difficult. It takes the skills of biochemists, biologists, and so on, trial specialists. So really quite complicated. And biosimilarity of biologics to the reference product is ensured by the identification of critical characteristics of the reference product, precise matching of the reference product using fingerprint method I showed you, and to establish the confirmation of molecular comparability in qualified, also the clinical studies, of course, because the chemistry, the biology may be one thing, but how do they fare in clinical applications in clinical trials may be a different matter, but even here we saw very, very similar. So with this slide, I'm going back to the future. So that means that we go back to stage 1 when the drugs were developed and analyzed and then made available to our patients, and hopefully giving more patients access to these great products. With these words, I thank you very much for your attention. And I'll be happy to answer any questions.
Thank you very much, Mr. Master, for this session on biosimilars that I'm sure will trigger a lot of discussions. But for the sake of time, we'll keep the questions till the end. And we will get back to you for a year in rheumatology, so please stay with us. But for now, we're moving to another interesting topic about COVID-19 complications. And we will be talking in particular about the pulmonary intravascular coagulopathy related to COVID-19, one of the complications in which sometimes us as rheumatologists are asked to help with those patients. It's going to be very interesting to know how distinctive and unique is this coagulopathy, for example, in comparison with what we know about macrophage activation syndrome and disseminated intravascular coagulation, for example. And for that, we're having with us Prof. Connell Koenigel, sorry, from Leeds. Prof. McConaughey, I think that, he's known to all of us. He's a honorary consultant rheumatologist at Leeds Teaching Hospital, professor at Leeds Institute of Rheumatic and Musculoskeletal Medicine, and his seminal work and concepts have greatly changed the way diseases and of the immune system are viewed by doctors and scientists in the UK and internationally. Without any further ado, Prof. McConaughey, please, the show is yours. Thanks.
Can you hear me, everyone?
Yes.
Yeah. And can you see my slides?
We don't see you though.
You don't see me?
Do you?
I do see you, Enes.
Okay,
I
hi,
see you.
Gerd. Well, if
Yeah,
Gerd
hello.
can see me.
I can see you
Gerd.
well.
Morning, everyone.
I can see you also.
Very good. Thank you. Well, let me get cracking, everyone. Thank you for asking me to present. This was my ACR talk, and I've modified it a little bit because the world has moved on. Some good, some bad. So thank you very much for asking me to talk. Some relevant disclosures because I collaborate with companies that are in the cytokine storm or autoinflammatory area. So basically, I'll be giving you an up-to-date view of the pathogenesis of COVID-19 pneumonia and the immune activation and immunothrombosis, and why this is actually a unique pathology that wasn't recognized prior to 2020. And we were using old language to describe something new, and it didn't come across very well. And I think it's all unraveling now, and I hope to communicate that. And of course, one of the great things that's helped unravel this is the use of rheumatological drugs such as steroids, tocilizumab, and JAK inhibitors, particularly baricitinib, where most work has been done, although there's work on tofacitinib as well. So obviously, I do eye clinics, and when we treat, for example, herpetic uveitis, and we misdiagnose a herpetic uveitis as autoimmune, and we give the patient steroid, that is very, very bad. So steroids are very bad for active viral infection of the endothelium. I've seen it. I do eye clinics, and it's a big worry for people treating inflammatory eye disease. Yet steroids have been very good for this pneumonia. So at the beginning of this pandemic, and these were citations in 2021, around the time I gave the talk. Here we have a couple of papers that highlight this idea of a cytokine storm. And indeed, we have people that died here had interleukin-6 levels in the range of 10 nanograms per mil. We usually measure cytokines in picograms, 1,000-fold lower. This is like eye-catching, eye popping out. And this led to the idea this was a cytokine storm. And one of the interesting things about this pneumonia is that people tend to die in the second and third weeks of disease, which gives doctors time to scratch their head and think, what can we do? So a relatively slow evolution. And the word cytokine storm got into the literature. And then this paper in PNAS from China showed that all of these severe patients in ICU with this alveolitis. So again, alveolitis is something we rheumatologists are very familiar with from interstitial lung disease and in scleroderma and lupus and myositis, this ground glass basal change that strikes a chord with us as an immune-mediated phenomenon. So this relatively non-destructive alveolitis, profound hypoxemia, and nearly all of the cases got better in this study with tocilizumab. Everybody got better. So by the time this was being fed back to us via the internet and email and communication from China. So before this hit Europe, we had the idea of a cytokine storm and rheumatology drugs at the helm to transform the treatment and management of these conditions. The only problem with this paper, though, was that the IL-6 levels were almost 1,000 times lower. They were now in the picogram range, or at least 100 times lower. So there was massive difficulty with doing simple things like measurement. And of course, the critically ill patients dying with COVID-19 had multi-organ involvement, particularly cardiac and brain disease and intestinal disease and skin rashes, and many other things that are on this slide that are analogous to that which is seen in a macrophage activation syndrome that we might see in Fulman-Still's disease as rheumatologists, or the oncologists see after chimeric antigen receptor T cells. So these gain of function T cells which kill tumors and particularly lymphoid tumors where this therapy is most advanced. So there were similarities in the phenotypes, and this slide I showed at the ACR, and the authors tweeted it that I was citing their slide saying this was all a cytokine storm. But what I said was, we think this was a cytokine storm, but I'm going to show you why it's not a cytokine storm. And that's what I propose to do. So before I get into the data, the other interesting paper that broke at the beginning of the pandemic was this Siddiqui and Mehra paper, which provided a roadmap. And what it said was, look, early on, it's all viral replication. And then from week 2 on, it's all an exaggerated host immune response. So hit hard here with the rheumatological drugs, and you're going to cure all these people. So this was the emerging narrative. So everyone, you have a virus in the first week, then you have a gain of function hyperinflammatory response encompassing a DIC pathology with thrombosis and bleeding leading to death. And this can be headed off by rheumatological drugs. But again, I'm speaking to a Middle East audience, and these are fine Arabian steeds from the Arabian Peninsula, no doubt, or at least their ancestors were. And this is Charlton Heston. So I used this slide in the United States saying, please hold your horses on the cytokine storm. Because in a true cytokine storm, the levels of IL-6 indeed are in the nanogram per mil range. And this is what you see with the CAR T cell therapy. And remember, this was reported in one of the original studies, and we took that at face value, but the cytokine levels are not particularly high. And in this very large paper from China, where they looked at all of the critically ill patients, again, the cytokine IL-6 levels were very modest. This isn't nanograms, it's picograms. It's 1,000 times lower than the true cytokine storm. Now, nobody ever used the magnitude of cytokine levels to diagnose cytokine storm. It tends to be a clinical diagnosis, and it hits quickly and you have to treat, and then your cytokine levels come back from the research laboratory and they're very high. So the actual levels never really mattered that much. Historical and criteria to call a cytokine storm or mass are not based on cytokine levels. And my friend here, Luca Cartusio in Udine in Italy, he works very close with intensive care unit doctors. And in his cohort, the patients that who required oxygenation or those that required ventilation, their IL-6 levels were modest at under 100 picograms per mil. So this is relatively low. So I'm going to have a look now at the pathology. And again, this is a picture my friend sent me, and you can see this early disease ground glass opacification. Now, I was on the ward in Leeds, and we had all of these patients who did not have COVID pneumonia, but were in hospital with PEs, but negative CTPAs. This was a pregnant woman who's 32, and she had all of these changes, these wedge-shaped inflammatory or infarct type changes adjacent to the pleura. And it turned out that these patients actually have a very mild COVID-19. And this was a graphic from our paper. It's to highlight that you inhale the virus, it gets into the alveolar territory, and it immediately and quickly triggers immunothrombosis, which is a physiological state to contain the virus. Better in your lung than in your frontal cortex or Broca's speech area, I always say. So basic lung anatomy is the surface area of the lung covers an area the size of a badminton court. And this is 1 micron away from at least 20 billion capillaries. So this is an amazing network. And you can see here we have the type 2 pneumocytes, these plump ones, which are the target of the preferential entry site of the SARS-CoV-2 virus. Now, this is a patient who has no symptoms, who is going for lung cancer surgery. Here's the lung effusion from the cancer. And they're having a staging CT on the morning of the cancer, and they have no symptoms. And here we have the classic subpleural ground glass changes of the coronavirus. And this was sent off to the lab because the cancerous lung was excised, and then the pathology was published. And what you see is lots of early surfactant release. But I draw your eyes to all of this macrophage filling of the alveoli. So there's lots of an alveolitis where it looks like the early type 1 interferon response is overcome, and then the macrophages come in to clear up the mess. But of course, this is linked to the thrombosis. And this is just the pathology of the lungs in this amazing textbook. I can send anyone this chapter if they want, but it's to highlight that this amazing complexity of the ACR network with the alveoli and the capillaries juxtaposed to each other, and then this juxtaposed to small arterioles and venules is the battleground state. Now in flu pneumonia, this is the trachea. You can see the cartilage, we're all rheumatologists, and you get relatively large vessel necrosis and dehiscence, and patients can die very quickly, and they get a nasty bronchopneumonia. And they can also get an alveolitis, but it's typically a bronchopneumonia. And the influenza disease is maximal near the airways. And of course, there's all of these bronchial arteries running in the airways, where the coronavirus disease is maximal in the actually alveolar network. So there's different battleground states. So we pointed this out in the Lancet Rheumatology in 2021. We said, hey, these are completely different diseases. There's a propensity to attack the alveolar network with COVID. And of course, the type 2 pneumocytes are very close to the massive capillary network. So we pointed out that what is being reported in the literature, this beautiful New England Journal paper by Ackerman with all the lymphocytes adjacent to the capillaries, this isn't necessarily a viral endothelitis. It's actually where the lymphocytes are getting out of the circulation into the front line of the battle in the alveolus, where the initial interferon responses haven't contained pathology. And then there's this extensive thrombosis, not just in the capillaries, but on all of the small blood vessels. And all of this thrombosis from this excellent paper from Germany showed that this thrombosis is linked to extensive pulmonary infarction. This is unlike flu, so you get massive infarction. So then you have a very rich soup of self-tissue to be passaged off to the regional lymph nodes. And this is probably why there's so many autoantibodies, which are all secondary to the disease and all go away when all the damaged tissue is hoovered up. So here you see all of the necrosis and immunothrombosis that's all emanating from this alveolitis territory. Another paper from the USA from Fox showing the severe alveolitis, and then all of the adjacent vascular thrombosis, including megakaryocyte accumulation, which is well known in the lungs. So we just made the point that, hey, all of this immunothrombosis is completely different from DIC and a systemic immune activation. It's part of an immune thrombotic process to try and contain the virus in the front line in the lung. And of course, one of the fascinating things that these clots are different from DVTs. They're full of neutrophils and platelets, and particularly netotic neutrophils, which is what you see here. And interestingly, when you treat these people that are critically ill, anticoagulation makes no difference. In fact, they do slightly worse because you're probably facilitating the dissemination of the viral debris, which isn't good. And also the anticoagulation probably doesn't work for the immune-driven clots. Now, on the right of this slide on milder disease, there's a small incremental benefit for anticoagulation. So the vascular pathology is very different from DIC and macrophage activation syndrome. So first, I made the point, This is not a macrophage activation syndrome. If you look at the cytokine levels, there's a 100 to 1,000-fold difference. And in this paper, we coined the term PIC, pulmonary intravascular coagulopathy. Other authors have covered it, called it different names like microclots or CACs, which is a rude word in English. Anyways, so the key difference here is that in a DIC, the liver is involved and you stop synthesis. But in this situation with PIC, the liver's intact, so fibrinogen is normal or elevated. So it's a completely different immunopathology to a DIC. Now, it's very important to point out when these people are critically ill and dying, they can get a DIC, but it's a pre-terminal event. So it can occur, but it's not the normal. So here we have a DIC with diffuse thrombosis and diffuse bleeding, and this can occur in pre-terminal COVID. But in this situation, you have the pathology in the lung, and you get extravasation of erythrocytes, and these are phagocytosed because they're in the wrong compartment. And this is different to a mass scenario when the erythrophagocytosis is performed by macrophages in the sinusoids of the liver, the spleen, and the bone marrow, where the macrophage is sitting in the endothelial wall with 1 foot in the circulation and 1 foot, so to speak, in the organ. So this is a completely different scenario to the pathology in the lung, where there's breakdown of the vessels and microbleeding in the lungs and erythrocytes being taken off to the regional lymph nodes, and pathologists see hemophagocytosis, but it's completely different. So very important to get that. Now, I mentioned at the start that the idea was that this pathology was due to viral infection and replication in the endothelium. And all of you will know that if you have somebody with a herpetic eye infection, which you miscall an autoimmune uveitis, steroids are very bad. So obviously, when we saw the good data coming with steroids in the treatment of this virus, you immediately become suspicious that this isn't an active endothelitis. So the only good evidence for viral endothelitis comes from electron microscopy studies, and people have lost the knack of doing these. So this was a correspondence in the Lancet. And this correspondence in the Lancet said that this was all wrong. They were confusing organelles. And this correspondence was only cited about 1% of the frequency of the primary erroneous data. So it's very important to get the erroneous information out first, because it's so hard to overturn. And this paper has never really got much traction. So this is one of many papers. So just read the title. There's lack of ACE2 expression. That's the receptor, the primary receptor for SARS-CoV-2. And it's very hard to get this virus to infect endothelial cells. So at the top here, we infect, not my lab, but other labs infect these Vero cells, which have no type 1 interfering machinery. And you can get 300 million viral particles. This is active viral replication in 48 hours. Down here, if you infect the human primary endothelial cell with the virus, you get virtually no replication. So the virus isn't really replicating in the endothelium, it's replicating in the alveolus. And again, in 2020, in our Lancet model, we pointed out there's at least 8 reasons how you can have immunothrombosis and endothelopathy without actually having a virus. So it's all immunologically driven, or what is known as immunothrombosis. Now, if you speak to an academic hematologist, you'll be surprised. First thing they will say, the primary function of coagulation is immune containment of infection, and hemostasis is secondary. That's what some of them will say, which is quite amazing, but evidently true. So I'm just giving a bit of context to this hyperinflammation. So Michael McDermott and myself here on the left classified immune disease along a continuum from innate to adaptive. And Gratu and colleagues said you can also then classify it along a gain and loss of function. And when you look at a cytokine storm in children with hemophagocytic lymphohistiocytosis, they have a defect in the perforin pathway and they can't kill virally infected cells. You ultimately get dysregulation of dendritic cell T-cell crosstalk because you cannot kill the infected cells, too much interferon, and this drives macrophage activation. And this is immunodeficiency. But the same happens with CAR T-cell therapy and Still's disease, where there's a hypersensitivity reaction and you get the same cytokine, but of course you can treat this very effectively with immunosuppression. But you cannot treat this, if you give this immunosuppression alone, it doesn't work. You have to treat the infection and you have to do a bone marrow transplant. But the initial phenotype looks the same. So it all converges on the macrophages. So innate and adaptive and loss and gain of function are basically pointing at the same target macrophage. And so the cytokine storm is completely different. Now, the other really important thing is that we talk about, oh, let's give these patients lots of steroid. But in people that die, they actually are shedding the virus strongly by 3 weeks. So that original slide I showed you, the viral shedding stops at week 1 in people that are fairly well. But in people that die, they keep shedding the virus. And why are we immunosuppressing them? And this is another paper looking at the cytokine elevation. So the people that are dying are those that have high IL-6 levels plus measurable viral RNA in the blood. So it's PCR in the blood. So it's not replicating virus in the blood. It's usually subgenomic RNA or RNA debris or RNAemia. So the point of making everyone is our rheumatological drugs are the people that are destined to die have the highest IL-6 and the highest viral replication in their nose and throat and detectable RNA in the blood. And this is just to look at this. The people with the highest IL-6 are the same people with the highest viral RNA in the blood. And these are the ones that are critically ill. So we're treating everybody as the same. And we're ignoring the fact that the ones that are the sickest actually likely have RNA or have viral replication. But of course, many of these people are being given antivirals. So there's 2 types of cytokine storm in the peripheronopathies or the classic inflammatory diseases. One where there's loss of immune function and one where there's gain of immune function, which we see in Still's disease or the like. So in the loss of immune function, sorry, my phone has made a funny noise. So we pointed out in 2020 that if this isn't really a cytokine storm and that there is active viral replication, then you really need to be careful going in with lots of rheumatological drugs, and you could actually do harm. And of course, the recovery study said that if people have mild disease, the mortality looks to be higher if they're given steroids. So I have no idea why they were given steroids in the first place, but this is what the data showed. But of course, for the more severe disease requiring oxygen, the recovery study showed a great impact. So all of this viral replication, we just published a paper this year pointing out that this viral replication needs to be considered when you're giving rheumatological drugs. So people that are not clearing the virus very quickly need to be identified, and immunosuppression needs to be carefully balanced with other strategies, including antiviral therapy. And this is just the graphic from our figure, highlighting that if you have cleared the virus and you have thrombosis, then rheumatological drugs will get the blood flowing again. And this is good if you have a high BMI and you're hypoxemic, it'll probably save your life. But if you've got high cytokine levels and viral replication and virus going around the body to your brain, for example, you're going to end up very sick and the treatments may not work. So I've mentioned the immunodeficiency state. Now, what about this gain of function that we pointed out might be occurring in COVID-19? So in this scenario, people rapidly clear the virus, their lungs are not too damaged, and they have a hypercytokinemia. And in fact, this actually emerged in the course of the pandemic with a Kawasaki-like shock syndrome or a toxic shock syndrome type pathology with rashes, abdominal symptoms, and myopericarditis. And this looks not dissimilar to the CAR T-cell pathology. And the interesting thing, all of these kids, you cannot find the virus by PCR, but most of them are antibody positive. And this reflects an immune hypersensitivity reaction to the virus. Now, kids are more likely to die from MIS-C than they are from actually the COVID-19 pneumonia unless they're immunosuppressed. And the jury's out as to whether the vaccine spike protein is actually the antigen or super antigen that is driving this pathology, because it can occur after vaccination in kids. So it's an interesting idea that the world has rushed to vaccinate children who are most at danger from a hypersensitivity reaction that no one knows what the antigen driving it is, but people suspect it could be the spike protein. Again, I'm absolutely amazed that we are where we are. So just to finish up, one of the things people have said, there's a vasculitis, and this paper shows lots of vasculitis in the severe and fatal pneumonia. You can all see the coughing of lymphocytes around the vessel, but what we think's happening here is the exogenous inflammation is leading to immune cells invading vessel walls. So it's Virchow's triad, but it's outside the small arteries in the lungs. So this is a paper in Press highlighting this, that all of this alveolitis is triggering the thrombosis in the vessels. And it looks like vasculitis, but it's not. It's just the severe alveolitis and pneumonia. And this is Sammy Giris, who's a fellow in our lab who's done this. One of the things we saw, we did a literature review, and we found that Goodpasture syndrome appears to be more common with COVID pneumonia, but you don't see it after vaccination. And we believe the reason for this might be the basement membrane damage in the lungs, leading to liberation of the basement membrane antigen, leading to a glomerulonephritis. This is a type of vasculitis. It's seen as the pernio, lupus pernio type vasculitis that occurs in young children, and it's linked to perivascular coughing in the skin and elevation in the MX1 protein, which is an interferon-driven pathology. The other pathology in the skin is thrombosis without immune infiltration, or posse-immune, and this is work by Cynthia Magro. And again, this is a retiform purpura in a patient who's very ill. Another example of this cutaneous vasculitis in critically ill people. And what you see here is posse-immune vascular immunothrombosis. And again, in another paper, we proposed that all of the pulmonary venular territory thrombosis that is distal to the alveolar territory leads to clots breaking off and going systemically. The second mechanism is the RNA not being contained in the lung goes systemic as well and gets into the venous circulation, including microveins, leading to a vasculitis mimic. So we pointed out there's two types of vasculitis. There's a vasculitis mimic, an RNA debris leading to a posse-immune disease. And then there's people with very mild COVID, but they have a dramatically elevated type 1 interferon response, and they get a vasculitis by poorly defined mechanisms. So these vasculitis mimics are nothing to do with DIC. They are due to they're due to this immunothrombotic tendency, and they lead to all of these manifestations that look like vasculitis, including strokes and intestinal ischemia. So just to finish up on therapy, it's clear that rheumatological drugs work, and I was part, and Gerd were part, both myself and Gerd were part of Euler task force, and we reviewed this evidence for Euler. And again, we agree with steroids and tocilizumab, and data has emerged since showing that baricitinib is unequivocally very good. Now, we did the Euler guidelines, and I have to say that the Euler guidelines get highly cited, but our guidelines haven't been really cited because it's not so much primary rheumatological research. So this is just to say, if you look at the RCTs of tocilizumab and COVID, this drug is curative in a cytokine storm in CAR T-cell therapy. The biggest trial recovery, it showed efficacy, but as you can see, there are many negative studies of tocilizumab, and some phase 3 studies were stopped for futility. So it's really a very marginal call, but there's just overall, there is a slight benefit for the IL-6 therapies, and also for saralimumab. But again, it isn't a whitewash with these drugs, reflecting the complexity and the timing of administration and issues around viral replication. And yeah, so this is a study, another study showing similar thing for steroids. Again, benefit. This was the first baricitinib study showing benefit. Another baricitinib study showing benefit. Again, this has been put down to the fact that baricitinib knocks down the inflammatory response, but it also blocks kinases involved in the viral life cycle within the cell. This one, AAK1. Tofacitinib doesn't block that particular kinase, but it also reduces mortality in this study in the New England Journal from Brazil. So there was other studies, of course, other agents being used, anakinra, Dury still out as far as I'm aware. I just want to highlight to you, this is a preprint, it's online, it's from the Recovery UK, 8,000 patients. They were randomized to baricitinib or not. Most were on steroids, a third were on tocilizumab, and the introduction of baricitinib reduced mortality from 12 to 10%. So a small but definite benefit. So this is effectively triple immune therapy. So this clearly again speaks to there is a benefit of therapy, but I believe it's because of this immunothrombosis. This is a Nature Medicine paper on anakinra. And again, it was driven by this UPAR urokinase plasminogen receptor plasma levels. This is not widely used, but this study showed a benefit with anakinra. So it's other drugs have been used. Colchicine has been largely negative. So to summarize on my last slide, our last few slides, so we've put together a pathophysiological model, a primary viral alveolitis that is not contained by type 1 interferon. This then leads to a local macrophage and neutrophil inflammation in the alveolus. This quickly triggers immunothrombosis. The immunothrombosis is sustained by then the B cell and antibody responses that fire up the macrophages further and T cell responses. And this basically quickly clears the virus. But in some people where there's this extensive immunothrombosis, particularly if they have cardiac risk factors and obesity, they're more likely to do badly. So there's two compartments. There's the viral compartment in the lung tissue from your nose to your alveolus. And then there is the physiological immunothrombotic compartment in your alveoli, pulmonary arterial, venous circulation, and also the terminal branches of the bronchial artery circulation. And all of this thromboses and acts as a sarcophagus, if you like, a concrete to keep the radioactivity isolated. Reminds me of Chernobyl reactors, which are obviously the forefront of our mind at this terrible time. But the point is, the immunothrombosis is physiological and it's in a different compartment. And we're targeting that with our drugs. And we're stopping this immunopathology. It's not a viral endothelitis. We basically have recognized, the world has recognized a new class of viral immunopathology that's distinct from influenza. And these excessive immune responses can be treated, but we really need to figure out the patients with ongoing viral replication and how to time therapy. So lots of people have been involved in this work. Our work in Leeds and the chest pain, Stephanie Harrison, I was a fellow that did this. And then my colleagues in what I call the rest of the world, because I was in Leeds and I could go nowhere for 2 years. So every place outside of Leeds was the rest of the world. So with that, I'd like to hand you back and thank you for listening to my talk.
Thank you, Prof. Magune, for this amazing overview of the intravascular coagulopathy, the unique vasculopathy related to COVID-19. We're going to make an exception because Prof. Magune is going to leave, has to go. So we'll take the questions for this session right now. Dr. Ahmed Zayat, for the first question.
Dennis, fantastic.
Hi, Ahmed. How are you?
I'm fine, thank you. Yourself?
Good, thank you.
We need to see face to face next time. So it's actually a really amazing theory. And I think it agrees with everything going on. But this, at the same time, if it's immunothrombosis, then that makes sense that you suppress the immune system through using steroids, or actually what you do with IL-6, you're stopping the chemotaxis and pro-inflammatory response to IL-6. Not necessarily the direct IL-6 effect, is actually you're stopping calling the cells to come to cause the inflammation and stop the thrombosis process. The same thing with JAK inhibitors, possibly with other immune suppressant, is actually, as you use examples from going on, you're trying to stop two superpowers making a World War III inside your body. By, okay, leave the virus, do what it likes, it takes some time and then we'll go away. Because the virus doesn't kill, it's our immune, that thromboembolic effect. So actually, that way, probably steroid has a useful effect as well as other immune suppressive effect. We shouldn't be worried about the steroid or the effect of steroids that we get less immune response. Actually, that's what we want.
Yeah, no, absolutely. But the key thing is, if they have mild disease, the steroids will make things worse. And if you take the immune system out of the equation, although the virus isn't particularly destructive, and it doesn't lead to like tracheal dehiscence or severe bronchopneumonia or massive bronchial hemorrhaging, what it does do is it will destroy so many type 2 pneumocytes that you will basically lead to an inability to, the type 2 pneumocyte replenishes the alveolus. So what will happen is when you destroy enough type 2 pneumocytes, you will get a fibroproliferative response, and that will lead to ARDS, and that will lead to death. So these people that are dying slowly of ARDS have ongoing viral replication, and the steroids could be making that worse. Remember, the immunosuppression and steroids tends not to help people that are on ventilators or after a few weeks of disease. So the virus will likely kill a lot of people if if they're the more severe cases, if you don't target it, and steroids could potentially make that worse in those people.
Thank you very much.
Thank you. Any more questions? I wanted to ask you, is Professor Kane still with us?
Yes.
Yeah, okay, yeah. Just a quick question, because I find it interesting that there is no real evidence, or at least there is very little evidence of a structural endothelial damage in those patients, unlike in primary antiphospholipid, for example, which is, there are some similarities at least with the two syndromes. Does this mean that there is no evidence of any chronic pathological endothelitis or endothelial damage post-COVID, and those people who recover from COVID are do not have any higher risk for cardiovascular disease?
No, of course, that's a $1 million question. And you can throw the vaccines into that question as well. So to answer your question in more detail, yeah, there is definitely endotheliopathy. You see endothelial necrosis and death, but a lot of this is down to the magnitude of the cytokine inflammation, the local cytokine inflammation. As you say, antiphospholipid antibodies may arise, and some of that's due to the tissue necrosis, and it's not the same as primary antiphospholipid syndrome. So there's multiplicity of mechanisms of endothelial damage. There may be many other antibodies that could be playing a role in endothelial damage, after the initial necrosis and the movement of self-antigens, including endothelial antigens, to the regional lymph nodes, which could lead, I believe that's the mechanism of beta-2 glycoprotein 1 antibody development and the likes. Of course, there's many other antibodies like anti-PF4, which is linked to a HIT or a VIT type phenotype. So these are important issues. How long may this effect last? I'm not aware of any good long-term data yet. The other critical thing is that there's lots of good experimental data that the spike protein will bind to ACE2, and that may lead to nicely to dysregulated endothelial biology and could contribute to disease. My colleague from Dublin, James O'Donnell, published a paper showing that people a month after COVID who've recovered have very high levels of endothelial markers in their blood, including von Willebrand factor and ICAM, VCAM. So there's lots of things going on, and this may have a big role in so-called long COVID and the diffuse cerebral abnormalities that are being reported. So it's a great question. And then, of course, the vaccines make spike protein, and the Pfizer vaccine RNA and protein is in the lymph nodes at least a month after vaccination, and spike protein in the circulation could bind to ACE2. And we really don't know. We really need long-term observation to see what the outcome of all of this is going to be. It's fascinating.
Yeah, thank you. Thank you very much. Very interesting indeed. And now we'll go back to Professor Mister for an overview of the year with the most important highlights of this year in ACR.
So thank you very much again. And I would also like to ask if the questions directed to my talks could be immediately after my talk, because unfortunately I'm involved in another parallel session. And so I will have to leave after the discussion, unfortunately, because there is such a condensed time. So thank you very much for the invitation again. And when you commit yourself to give a talk about a year in review in rheumatology, you're honored, but you already know that it will take many hours actually to compile this. And and also you will not make everyone happy, because many colleagues may think, oh, he didn't cover this or it didn't cover that. And obviously there is so much going on in rheumatology, not least due to COVID, as we nicely heard at this excellent talk previously, that it's very difficult to cover everything. And so these are my disclosures. And so I will basically cover what's new from EULAR and ACR. And actually there were quite different things being covered at EULAR and at the ACR, both, of course, virtual congresses. And I will start with EULAR, which was supposed to take place in Paris, but unfortunately, again, had to be virtual. And I will follow up a little bit now, a little bit later on, with regard to SARS-CoV-2 in rheumatology, because that was a major focus at both talks. And I think you have been nicely introduced into the COVID area. And of course, that has changed a little bit, luckily, due to the Omicron emergence, which may not be as dangerous to the lung, but as the other original strains. So one very interesting presentation was given by Jeffrey Sparks from Boston, but on behalf of a huge registry outlining the associations of baseline use of biologics or targeted synthetic DMARDs with COVID-19 severity in patients with rheumatoid arthritis. So this is the Global Rheumatology Alliance. And as you know, there is intense interest throughout the pandemic. How do patients fare if they get corona? What about COVID treatment? What about our treatment? How does it influence? We didn't have any ideas when this terrible disease started. So the aim was to investigate the associations of baseline use of biologics and or targeted synthetic DMARDs with a range of poor COVID-19 outcomes in rheumatoid arthritis. So what he showed actually was just this particular disease. Obviously, we have more data in other diseases like AS and so on, but I think it was quite nice to concentrate and focus just on one disease so that we don't have other items here. So Global Rheumatology Alliance at that time had more than 15,000 registered patients. Germany alone contributed a lot of them to, and EULAR did. And so there's a lot of work going on. Exposures, meaning drug treatment, either biologics or JAK inhibitors, like abatacept, rituximab, and tocilizumab, JAK inhibitors, and TNF inhibitors. These were the reference group. And so mutually exclusive factorized by most severe levels reached during the course was actually the ordinal COVID-19 severity scale, which is very helpful. So one is, let's say, the easy patient group, not hospitalized, Group 2 is a little bit more difficult, but no oxygen needed, but just hospitalized. 3 is getting dangerous because you need oxygen or even ventilation, and the worst one, of course, is. So when we look here, and this is the overall outcome, you immediately see when you look into the non-hospitalized patients that quite a few were on IL-6 inhibitors and on TNF inhibitors. However, when you look into hospitalized with oxygen, ventilation, or even death, rituximab really stuck out here. And when you look into the associations of baseline DMARDs with COVID-19 severity, again, rituximab came out and also did the JAK inhibitor. So when you are on either rituximab, then you really have a problem, and we all know this subsequently. Also, the JAK inhibitors appear to have a problem. We do not know, even though this was calculated and there was a propensity score, if that reflects a more difficult patient population being put on the JAK inhibitors, maybe higher comorbidity or longer disease scores, having failed other drugs, or if this is truly intrinsic to JAK inhibition, or even both items. So here you see another version, hospitalized, and this categorical score, again, rituximab and JAK inhibitors. So the conclusion based on this global registry was rituximab has a 4-fold risk of ordinary COVID-19 severity. JAK inhibition has a 2-fold, no consistent association with abatacept or IL-6 inhibitors compared to TNF inhibitors. And so we need to look into prioritization of risk mitigation strategies for patients, especially on rituximab and JAK inhibitors. And the next question was actually, how is this in children? And because we already heard in this nice presentation by Dennis that there are particular items pertaining to children, but the reassuring data, I will not go into all the details here, that the survey data showed that there was actually no real problem in the children with rheumatic and musculoskeletal diseases. They usually showed mild disease with good outcome. So that was very reassuring for this also difficult patient group. Following up on what Dennis said, there was an interesting presentation by Dr. Heibel and colleagues. We had treated in the very beginning, when COVID arose, patients with tocilizumab and anakinra in combination. And that is, of course, a very, very bold approach. And however, they could show that in this limited number of patients, there was a treatment success. And as you know, both tocilizumab and subsequently also anakinra have been approved for COVID-19. Next drug that is quite interesting, again coming out of the rheumatology world, is mavrilimumab, a drug that we've been working on quite a lot, which is directed against the CSF receptor. And you've seen the many macrophages by Dennis' presentation just previously. And you see here, probability of ventilation-free survival was higher with mavrilimumab. So that indicates that this potent inhibitor of the MCSF signaling may have added clinical benefit on top of the current standard therapy, and that is currently being analyzed further. So not only IL-1 inhibition, IL-6 inhibition, but maybe also the MCSF inhibition may be important in that particular stage of COVID. The next question, and that was also an exciting presentation at that time, and there still is, of course, since we didn't have much data, because our Israeli colleagues, they started very early with a very comprehensive vaccination program in Israel, and together with a very highly laudable investigation of the antibody responses and many other items. Here are patients with autoimmune inflammatory rheumatic diseases, and how was this vaccination success as determined by seropositivity rate, by immunosuppressive treatment. Obviously, it cannot be exactly translated in the clinical outcome, but it's a good proxy, we believe, the seropositivity rate. So you see again here that methotrexate led to somewhat more lower response in terms of vaccination compared to anti-TNF. But what was particularly poor in terms of a vaccination response, again, a drug that we know was already leading to the worst outcome of COVID was anti-CD20, namely rituximab. Also, abatacept was lower, and the JAK inhibitors were intermediate, while anti-IL-17 responses really didn't show much influence. So very important data. Obviously, that was the start, and many other trials follow. Next question, frequently asked by the patients is, doctor, what about adverse side effects? Can I get a flare? Will my disease get worse when I get a vaccination? But very reassuringly, I will just go quickly because it was just published recently by Machado, who subsequent talk, there was no signal of more side effects and only 0.1% severe adverse events in this registry, only 2. What about disease flares? And so also no particular signal that had already been shown by the Israeli group. There was not a particular signal, and the same was true here. So yes, a vaccination in our patients is very safe. Okay, so much about COVID at EULAR. I will come back to it when I look into the ACR. And also some rarer diseases where we can learn quite a lot from were presented at EULAR. And one was quite interesting. It was intravenous immunoglobulin in patients with dermatomyositis, with a particular preparation that subsequently was approved also in EU for that particular indication. And you see here that it actually led to a higher strength, muscle strength compared to people. So yes, we can use that. And that, of course, is very important because in these particular indications, it's no longer offered. Another rare disease, and I have seen a number of cases where that disease actually prior to it was really exactly described, because we saw patients with vacuoles. When you looked into the histology, we saw some strange autoimmune features, some strange skin and pulmonary reactions. But then the American group at the NIH, when they did sequencing, they found out, well, this is a very interesting syndrome, which is X-linked, it's autoinflammatory, and it's based on a somatic mutation, and therefore, of course, only occurs in males with extremely rare exception. And one presentation here showed that relapsing polychondritis may be a feature of this particular excess syndrome. You see on the left-hand side all these manifestations. So if you see a patient with polychondritis, obviously a male patient, then we should also always consider access and look for other features. Now, another very interesting item that was presented here at EULAR was the GRAPPA new treatment recommendations. They were presented, and as you know, they're a little bit different, and I would say actually complementary to the EULAR recommendations, because here you particularly look into manifestations, or they say indications, such as peripheral arthritis, axial arthritis, axial PSA, enthesitis, and so on, nail involvement, and then you make specific recommendations for these particular domains of psoriatic arthritis, and then weigh them. Is there strong evidence, conditional evidence, or no evidence at all, even against it? And then when you have these manifestations, you have the algorithms to treat these patients. And I think these, together with the EULAR recommendations, are very helpful in treating our patients with psoriatic arthritis. And then regarding psoriatic arthritis, and we all believe that psoriasis has a strong link to the microbiome. So therefore, this Danish presentation, which has subsequently been published, was very interesting, because here there was a stool transplantation, fecal microbiota transplantation, in patients with psoriatic arthritis. And when you look into that, you say, oh, this is a great success. But then you say, oh, what happened? Well, actually, the fecal microbiota transplantation fared worse, had more treatment failures than the sham transplantation with dual. That was quite sobering because we would have hoped for the opposite, but in conclusion, it was actually the first interventional randomized controlled trial. Our Danish colleagues are really highly to be commended for doing that. And actually, fecal microbiota transplantation was inferior to sham in treating active peripheral PSA. So we really have to look into that much more in the future. What about new aspects of treatment? And so we will look into other drugs. And we will now come to the JAK inhibitors, and there I will come later to the oral surveillance because that was covered at the ACR, but quite reassuring data with regard to the JAKs represented by the German registry by Anja Schwagfeld, actually showing that elderly patients are not at increased risk of serious infections when receiving biological DMARDs or JAK inhibitors compared to conventional synthetic DMARD treatment. When the signal popped up, it was due to comorbidity, not to the JAK inhibitor. So the conclusion was treatment with JAK inhibitors as well as treatment with biological DMARDs was not associated with an increased risk of severe infections in elderly patients of 70 years of age. What really mattered was comorbidity. And at the very same time, when EULAR came out, we published our paper on tofacitinib in patients with rheumatoid arthritis, PsA, ulcerative colitis, and psoriasis, covering more than 30,000 patient years. And we already knew that at that time, a press release that had shown the oral surveillance data, that tofacitinib in the oral surveillance data had not met non-inferiority regarding malignancies at MACE. However, when you look into these huge patient data, you do not really see that signal. If we go to particularly malignancy here, I just picked that out. Actually, when you look into the standard incidence rate compared to the normal population, actually it's towards F. So we will discuss that later when I come to the oral surveillance study, second part of my talk. Others also focused on the safety profile of JAK inhibitors, and they found that there were maybe more serious infections, but that maybe due to that patients were older and presented higher comorbidity, as also shown by the German registry group. What really comes up is herpes zoster. That is certainly more frequent in patients on JAK inhibition. And this study also looked into the efficacy in a very comprehensive nationwide study showing that this was always treated significant difference between JAK inhibition and biological DMARDs. Now we look into the integrated safety profile of another drug, upadacitinib, here with up to 4.5 years of exposure. You saw the nice data by Dr. Alten just in the first talk, corroborating these data. And because with upadacitinib, again, this could be compared to methotrexate alone, adalimumab as a and then 2 dosages of upadacitinib. And really what came up as the only indication of a signal was a herpes zoster and CK elevation. The latter, we believe, is not really relevant. There's also the newcomer, which is also an important drug in the JAK field, the filgotinib. And that was here compared using infections and serious infections. And again, you see here no signal. What came up again was herpes zoster, especially in the Asian population. So this is truly something we see upon JAK inhibition. But luckily, we can vaccinate our patients ideally before any treatment in rheumatoid arthritis, covered against the herpes manifestations, but again, you can still vaccinate these patients when they are on drugs. One item that was leading to, let's say, pulmonary involvement was also addressing tofacitinib in a limited study, because of course the patients are not that frequent, that are treated with ILD and have a JAK inhibitor. But these data from Turkey look that JAK inhibition, in this case tofacitinib, is maybe a promising option for rheumatoid arthritis, interstitial lung disease. But of course, we need more data to really show the influence of JAK inhibition on ILD in patients with rheumatoid arthritis. What is much more clearer, it was based on the inbuilt trial, is that nintedanib was better than placebo. You see this here also in patients with rheumatoid arthritis, ILD, and can use that drug in Europe now because it has been approved in RA. Just briefly, what are novel compounds? And unfortunately, like let's say like at the ACR or at EULAR, you saw plenty of novel compounds to treat, for instance, rheumatoid arthritis. Now there are not that many anymore. One that is addressing important items was presented by Frank Puttereit at the Charité in our unit, and demonstrated the clinical efficacy of a drug that is actually linked to a glucocorticoid compound, and that may be quite interesting and will be used in the future well. Now let's shift gears a little bit and look at the risk factors. That was a very exciting study, which also has been published in full by now, presented at EULAR, and really raised a lot of attention, showing that you read it in the conclusion, in this large population in France, the authors reported that passive exposure to smoking during childhood or adulthood increased the risk of RA. So if you are exposed as a child to smoking because the mother or the father is smoking, the odds getting rheumatoid arthritis are higher. So that is something again in favor of our campaign against smoking, showing that even passive smoking, being exposed to smoke as a child, leads to rheumatoid arthritis. An item which is unfortunately neglected frequently in rheumatology is sexual function, and so therefore I believe this study is very important, showing that in the study with filgotinib, and again, I would like to commend the authors for having tackled this important item, because they could show that baseline disease activity negatively impacted sexual function in both males and females with RA, but that this could be improved on successful treatment, and the reduction in the negative impact of RA on sexual reduction be reduced. So this also is a very important, which is unfortunately frequently neglected in our daily life. Finally, to wrap up the EULAR material, I think it was very interesting to look into another disease, namely osteoarthritis. And here there was a very interesting article, presentation on a wearable transcutaneous nerve stimulation, compared as good and was even more effective and better tolerated than weak opioids in the treatment of knee OA, chronic pain, and would be a very interesting alternative to drug treatment. Okay, so much for EULAR. And now I will proceed to the ACR, which also was a good meeting. And I will again, of course, I have to start again with COVID-19. And here it was again reassuring the presentation that COVID-19 vaccine not associated with severe disease flares or serious adverse events in patients with rheumatic diseases. So very important, the disease or did not rise, pretty much showing what also the initial study at EULAR shown. However, again, patients treated with rituximab and mycophenolic acid had reduced humor responses shown here. So that was also corroborated. Rituximab is certainly a problem in vaccination and so is mycophenolic acid. We have to design strategies to overcome. Breakthrough infections is another subject, especially now with Omicron, which of course was not covered in detail yet and will be analyzed only now, since we now have the Omicron ability to screen for Omicron, to fight for it, or look antibodies specific for Omicron. So this pertains to the previous strains, showing that patients treated with antimetabolites, and again, B7 therapies, they represent a high-risk population and may need additional protection, which also could be monoclonal antibody products. So what we in our unit looked for was a pausing methotrexate, which may improve immunogenicity of COVID-19 vaccination. I've taken this out of the ACR presentation because I think it's important and has been just accepted for publication in the annals. And here we compared patients who had methotrexate therapy and no therapy due to their autoimmune inflammatory disease. And you already see that methotrexate lowers the neutralizing capacity. That's what we're looking for in our laboratory assays, because neutralizing virus obviously is most important. And you see here, if you, in the middle, if you continue methotrexate, you have a lower vaccine response compared to holding it. And we found out that holding it for about 10 days is most important. And on the right-hand side, you see that this mostly pertains to individuals above 60 years of age. So the lesson of this observational study, and this was also corroborated by a trial in Brazil, where they used another vaccine, that pausing methotrexate for 10 days is helpful in having a higher vaccine response. And if the patients are well controlled, I think we can do this and then have a better response. So shifting gears, now let's go to IL-23 pathway. And so there was an interesting study on guselkumab treatment with this directed and specific for IL-23, showing lower rates of radiographic progression in this 2-year trial called DISCOVER-2 in a significant number of patients, giving important numbers on the radiographic progression. Very interesting abstract was presented at ACR by a French group looking into unsupervised machine learning to identify 8 clusters of PSA phenotypes with significant clinical and demographic difference. And I think this will be part of our future. So as you all know, PSA can be quite diverse. And so why not let us, the computer, help to cluster them into various special entities? And that was done. And these colleagues could really identify clusters that fared worse here or better with regard to the treatment, in this case, guselkumab. So that especially those with small employee involvement seem to have a later response to guselkumab treatment directed at IL-23. And this is just the beginning. I think it needs to be studied in other trials, but I think this will be very, very interesting approaches to tackle these diseases. Next question that arose regarding IL-23 inhibition, this was tackled by a German group. Do we really need methotrexate in patients being treated, in this case with secukinumab against the IL-23? Again, in active PSA patients were taken, either treated with secukinumab plus methotrexate or with placebo. And so the group could already have methotrexate that was continued, or they could be methotrexate naive, then it was introduced. We basically have 4 groups. The bottom line is, you can see that here, addition or withdrawal of methotrexate had no impact on the efficacy of this IL-23 inhibition in active PSA. So I think we can safely either discontinue methotrexate in these patients or do not have to implement it. And what about the JAK pathway? And I promise you to go to the oral surveillance study, which is a direct comparison of biologics with a JAK inhibitor. And that was mandated by the FDA. And there was a very interesting presentation at the ACR by an FDA member, and he said, well, when we approved the drug in the early 2010s, we mandated that there should be a controlled clinical trial to evaluate the long-term safety of tofacitinib in RA patients. 2 dosages of tofacitinib should be employed and an active comparator, and look into cardiovascular adverse events, opportunistic and malignancy. So that was mandated and done in the tofacitinib trial, where patients with moderate to severe RA who had at least one additional cardiovascular risk factor and were above or equal to 50 years were either treated with tofa 5 twice daily or 10 twice daily, or a TNF blocking agent. In some countries, adalimumab, and others, anacept. It all had methotrexate on board. As you may know, subsequently, tofa 10 was switched to tofa 5 twice daily because of the pulmonary embolism issue, the VTE issue. And so that when you look into tofa 10, actually, some patients at that time, tofa 5 twice. When we look into the baseline characteristics, this is really a difficult patient group. So they were quite old because they had to be above 50, and 1/3 roughly were even above 65. More than 40% of patients had a very high body mass index above 30. 50% were smokers or ex-smokers. Many of them had selected comorbidities. And what I also find very interesting is they had a very high disease activity on average. So the DAS28 CRP, which is usually a little bit lower even than the DAS28 ASR, was close to 6. When I look at this demography, these patients, I really do not see anymore in my office with this high disease activity. At least they're extremely rare in my daily clinical. Of course, it's an interesting patient population. And here, the oral surveillance studies showed the co-primary endpoints for adjudicated MACE. You see that the hazard ratio was a little bit higher compared to TNF inhibition. It crossed the 1 line, so it was not statistically significant hazard ratio. However, that is important. The non-inferiority margin for primary comparison showed that this criterion was not met. And the same when you look into malignancies, again, the criterion was of non-inferiority was not met. You see the higher hazard ratios here for tofa 5, 10, and both doses combined compared to the.
Prof. Burmaster,
So
I'm sorry to interrupt. I need to tell you that we're running late. So we're already 5 minutes out of time, please.
Okay, so that was then published, and so the question is, do JAK inhibitors in general, that is discussed in the rheumatological community, more dangerous than TNF inhibitors, or is this something which is not so visible when you look into selective JAK inhibitors, or does tofacitinib have a neutral safety profile? And finally, is this maybe an unusual patient population with a high risk profile and very high disease activity? So other diseases go to PSA with a TYK2 inhibitor. I will be quick, also looking quite promising. And then imaging, PET in psoriatic arthritis, very interesting data. Drug treatment, we look into new drugs. That is my final slide. So some new drugs are on the horizon, and in some countries have already approved, like voclosporin in lupus, anifrolumab in lupus, mepolizumab in eosinophilic erythematosus polyangiitis, avacopan in granulomatosis polyangiitis, and finally also bimekizumab, an IL-17AF inhibitor for PSA. And if you're interested in very new recommendations, as already pointed out by Dennis, these are the EULAR recommendations. Just here a couple of days. With these words, I thank you very much for your attention, and hopefully see you at EULAR 2022. We're really planning for a physical Congress. And with these words, I thank you very much for your.
Hopefully. Thank you. Thank you, Professor Master. I think that for the sake of time, we will skip the questions unless there is a very burning one that we can take quickly. Any questions from the audience? Okay, so if there are no questions, I would like to thank the speakers for the amazing talks that we've had this afternoon. I would like to thank the audience for being patient with a lot of information this afternoon, right after lunch. And I would like to ask you to stay with us to carry on with the next session. Thank you.
Good afternoon, and welcome everybody. Please, you can, if you want, stretch up because this is the last sessions to refresh yourself. Stand up and sit down again. And I'm have pleasure to introduce Dr. Pedro Machado, Associate Professor and Consultant Rheumatologist at University College London. His research interests include in the assessment and prediction of outcome in rheumatic diseases with focus of axial spondyloarthritis. He has published more than 180 peer-reviewed articles. Dr. Machado is the past chair of European Alliance of Association of Rheumatology ULAR Standing Committee on Epidemiology and Health Service Research. He is a member of Research Committee of COVID Global Rheumatology Alliance Steering Committee and the ULAR COVID-19 and COVAX Registry Steering Group. He's a long-standing member of Assessment of Spondyloarthritis International Society ASAS, and in January recently he has elected as a member of ASAS Executive Committee. Dr. Pedro, you have 25 minutes or less to leave a 5 minutes question in the end. You can start, please.
Okay, so thank you very much for the kind introduction, and it's a pleasure to be here today doing this presentation. And today I'll be speaking about axial spondyloarthritis disease activity assessments. So these are my disclosures. And as you know, axial spondyloarthritis is a very interesting disease because it's a multidimensional disease and an umbrella term for a group of diseases that share genetic, immunological, clinical, and imaging features, including chronic back pain, peripheral manifestations such as dactylitis, enthesitis, and arthritis, extra muscle skeletal manifestations such as uveitis, inflammatory bowel disease, and psoriasis, and structural damage, which can affect both the axial and the peripheral skeleton. And as you know, a significant proportion of patients are HLA-B27 positive, and there are several inflammatory pathways that play an important pathogenic role, such as those involving the cytokines TNF-alpha, IL-17, and IL-23, which has in fact led to important therapeutic advances. Now, importantly, it is also a disease where there is a significant, what I would call between patient variability. So that is, patients with the same disease may present in very different ways. But also within patient variability, which means that disease manifestations in the same patient may vary over time. You know, for example, a patient that develops reactive arthritis at the age of 20, and then an episode of uveitis at the age of 25, and then later on inflammatory back pain and with typical axial involvement. But it could be exactly the other way around, starting with inflammatory back pain and then developing later on extra musculoskeletal features, for example. Now, this has consequences. And the consequence is that patient assessment in axial spondyloarthritis is also multidimensional. Now, in a structured view of health outcomes in axial spondyloarthritis, both structural damage and axial inflammation contribute to impairment of spinal mobility. This has been shown. Spinal mobility and disease activity contribute to physical function, and physical function and disease activity contribute to a health-related quality of life. This is a kind of hierarchical model for health domains in axial spondyloarthritis. However, the concept of disease activity is broad. It's a broad one and includes not only signs and symptoms such as fatigue or pain or morning stiffness or peripheral arthritis and enthesitis, but also other things such as the level of acute phase reactants or even the level of MRI inflammation is sometimes taken together with other disease activity measures. Now, in rheumatology, we have frequently witnessed what I would call a reductionist approach to disease assessment, whereby single instruments, such as those represented here, have been transformed to develop multidimensional composites. And this has both advantages and disadvantages, because you may gain in terms of, for example, psychometric properties or psychometric performance and efficiency when you build this composite score, but you also lose some of the subtleties of disease assessment. And what this figure tries to visualize is how several single instruments represented here on the left lower hand side, how these individual instruments can be aggregated into composite indices and scores by a data-driven process, and that data-driven process usually involves some kind of prioritization, exclusion, and weighting, often with statistical methods. And these are represented here by the gray arrows. And there's these single instruments and unidimensional composite scores can be even further aggregated into multidimensional composite indexes or scores, by a similar process of prioritization, exclusion, and weighting. So what you see in this figure is that different colors represent a different dimension. Different tones represent different perspectives. So for example, the patient perspective and the physician perspective. And then the increasing irregularity of the symbols reflects the increasing versatility of the measurements. So what have we used in axial spondyloarthritis? Well, in terms of single instruments, we have, for example, the spinal pain score, which usually assessed either on a 10 centimeter visual analog scale or a 0 to 10 numerical rating scale. You have nocturnal pain, which is assessed in a similar way. You have the patient and the physician global assessment, also both typically assessed on a 0 to 10 numerical rating scale, which is what ASSES prefers compared to the visual analog scale, because it leads to less errors. Sometimes it's difficult to reproduce this 10 centimeter line, and especially if people are using paper sheets, often it gets distorted. The stiffness of the spine, which is another typical assessment, and it can be measured both in terms of intensity or in terms of the duration of the morning stiffness. The number of swollen and tender joint counts and the 44, at least the 44 joint count is usually recommended, although obviously in patients with involvement of the more distal joints of the extremities, you may need to take into account a more extended joint count. The assessment of enthesitis, and there are various scores that have been proposed, specific indices that have been developed, And they're all based on the number, on a certain number on location of the sites assessed. And they all try to optimize which sites should be assessed, often based on the psychometric properties. So you also need to take that into account when you apply these scores to clinical practice, because they may miss an important emphasis on a specific patient. And I just give you here 3 examples, which are the MACES and the SPARC index, but there are others. And then as part of disease activity assessment, it's also important to take into account the eye, the skin, and gut manifestations. And this is something that I always ask to my patients at every single appointment, because that really indeed influences the treatment choices and as management implications. It may lead to the need to liaise with colleagues from ophthalmology, gastroenterology, and dermatology. So it's another component that is always very important to take into account when assessing disease activity, because it has both management and therapeutic implications. And what is maybe a more controversial topic, MRI has also gained a lot of relevance recently, and it can indeed aid the decision making. As you know, it's not taken into account in recommendations and guidelines in terms of the decision to, for example, prescribe a biologic drug, which is classically based on the presence of certain disease activity scores, based either on the ASDAS or the BASDAI or spinal pain. But in clinical practice, it is a tool that we use for decision making by providing information regarding the presence of both active and structural lesions of the spine and the sacroiliac joints. Now, in terms of composite indexes, for status scores, which are also called disease activity states, we have the classical BASDAI, the more recently developed ASDAS categories, and finally a composite disease activity state defined as ASAS partial remission, which is a remission-like state. While for change scores or response criteria, so that implies an observed change in a score, we have the change in the BASDAI or the ASDAS, as well as the ASAS response criteria, which are more used in clinical trials and not used in clinical practice. Just to recap a little bit about the meaning of these indexes. So ASAS partial remission criteria is defined by a value below 20 on a 0 to 100 scale, or 2 on a 0 to 10 scale in each of the following domains. So patient global assessment, pain, function, and inflammation. The ASAS 20 response criteria is a response measured by an improvement of at least 20% and 10 units on a 0 to 100 scale in the same domains that I described before, while the ASAS 40 response criteria requires an improvement of at least 40% in the same domains. And finally, the ASAS 5 out of 6 improvement criteria, again, not very often used, including in clinical trials, where the ASAS 20 and 40 are the most common measures, but it takes into account patient global, pain, function, inflammation, which in this case is represented by the mean of the 5th and 6th question of BASDAI, CRP, and spinal mobility. You all know this. This is just the classical BASDAI, historically the most widely used disease activity measure in axial spondyloarthritis, which includes questions about fatigue, axial pain, peripheral arthritis, enthesopathy, and intensity and duration of morning stiffness. However, we all have had to deal with problems with BASDAI because it measures only part of disease activity. It does not weight individual clinical manifestations. You know, the variables are simply summed up without taking the relative importance and redundancy of the variables into account. And in fact, it lacks specificity for inflammatory processes, and it's fully patient-oriented. And a typical example is a patient with, with chronic, with a chronic pain syndrome or with fibromyalgia, where typically you would get very high BASDAI scores without necessarily having active inflammatory disease activity. Now, due to these limitations, already, quite a few years ago, this process that started now a decade ago, in fact, the ACES group developed a new composite measure for disease activity in axial spondyloarthritis. So this involved a data-driven process with principal component analysis and discriminant analysis, and two ASDAS formula were developed. So ASDAS is the ankylosing spondylitis disease activity score, but when I say ankylosing spondylitis, it applies to the entire spectrum of axial spondyloarthritis. This is just because when it was created, that the concept of non-radiographic axial SPA was still not so present as it is today. Now, the preferred formula is the ASDAS-CRP, and it includes a question about back pain, the second question of BASDAI, duration of morning stiffness, the sixth question of BASDAI, patient global, and the CRP, while the ASDAS-ESR uses the ESR. And the cutoffs for the ASDAS have been developed with the value of 1.3 separating inactive disease from low disease activity. Apologies, where you see moderate, that should be low because this has been changed a few years ago already. A value of 2.1 separates low from high disease activity, and value of 3.5 separates high from very high disease activity. Response criteria have also been developed, and a decrease equal or greater than 1.1 represents a clinically important improvement, and a decrease equal or greater than 2.0 represents major improvement. And the ASDAS scale goes from 0.6, which is the minimum score, up to around 6. And ACES has developed an ASDAS app, and there's also a web calculator and paper calculators that are available in the ACES website. Interestingly, it has been shown at the observational level that there is an association between disease activity and radiographic progression. So, for example, what you see here is data from the OASIS cohort, which is a cohort of patients with ankylosing spondylitis from the Netherlands, Belgium, and France. It's a long-standing cohort. And what you can see here on the y-axis is the change in structural damage measured by the MSAS. So this reflects the increase in structural damage. And in the x-axis, what you can see is time. And if you look at the green line, that represents patients that have, in average, an ASDAS of 1.0, which should be inactive disease. And the red line would be patients that have, in average, an ASDAS of 4.0, so very high disease activity. And what you can see is that for those patients that have inactive disease, you can see that there's an average increase in the MSAS of maybe 3 units, while for those with very high disease activity, it's an increase of around 15 units. So this shows an association between disease activity and the level of radiographic progression. And this is data from the Swiss clinical quality management cohort. So this is a large group of patients, almost slightly more than 200 patients that were treated with TNF inhibitor agents. And they all had at least 1-2 year radiographic interval assessment. And essentially you can see the same thing. So this green plus this green symbol with the cross or a plus sign represents those subjects with inactive disease, while the orange dots are the patients with an ASDAS above 2.1, so high or very high disease activity. And you can see here that those that have inactive disease tend to progress less than those that have high disease activity on a probability plot. And this has, well, not only this, but this has contributed to the concept of treat to target in spondyloarthritis. Although it only provides indirect evidence for that. And there's a lot of debate about it, you know, because you need to, it needs to be taken into account in a critical way, because remission or inactive disease may not be an achievable target in some patients, in which case you would take, for example, low disease activity as the target. And the conceptual framework of treat to target is that you adapt therapy if that state is lost. But obviously, this is a conceptual framework that needs to be adapted to the individual. And at individual level, many other things need to be taken into account, and not only the disease activity score. Comorbidities need to be taken into account, for example, the presence of fibromyalgia, you know, the ESR, CRP, if it's part of the composite score, it can be chronically raised because of other conditions, because of obesity, because of diabetes, etc., etc. So it's a conceptual framework that cannot be read in a very strict way. It needs to be adapted to individual circumstances. And until recently, there were actually no clinical trials testing this strategy in axial spondyloarthritis. This changed with the TICO-SPA study. And in the TICO-SPA study, which compared the treat to target approach with the standard of care approach, the primary endpoint that the authors used was a significant improvement in the ASSES health index, which is a measure of health status that was really recently created by the ASSES group, and there were no differences between the groups, with 47% of them achieving significant improvement in the ASSES health index in the treat to target group versus 36 in the standard of care group, but this was not statistically significant. So what is the message of this trial? Well, although the primary endpoint was negative, there was it was significant for several secondary endpoints. And then there is another issue with this study, I think, which is the fact that the target that was used was an ASDAS below 2.1, which is with the cutoff between low and high disease activity. And that cutoff is actually not very different from a BASDAI cutoff of 4, which is actually what we use well, it depends on the country, obviously, but in many countries, still the cutoff that is used to prescribe biologic therapy, although EULAR, for example, and ASSES recommends using either that or ASDAS, but for historical reasons, it's still, in some countries, it's still the cutoff that you use. And in any case, in clinical practice, the cutoff that you use to prescribe biologics would also be an ASDAS of 2.1. So actually, I think this made the treat to target group very similar to the standard of care group, particularly because the ones, these were all expert centers that were involved in the study. So therefore, the standard of care is a high standard of care anyway, and I think this influenced significantly the results. Whether this would be different if remission had been used as a target, you know, that has still to be shown. So in conclusion, there are several single measures and composite indices available to assess disease activity status and response to therapy in axial spondyloarthritis. Composite indices do have enhanced psychometric properties and may provide a better reflection of the overall disease activity state. However, it's important to bear in mind that there may be times when single measures rather than composites might be more appropriate to judge a specific outcome. For example, when a certain intervention is directed primarily at a specific construct and not necessarily aimed at producing a global change, or when particular components of the composite score are influenced by comorbidities or other factors outside the inflammatory disease process, and therefore parsimony in outcome assessment can sometimes unintentionally lead to loss of subtlety and harm rather than benefit for patients in clinical practice. So it's important that, essentially it's the art of medicine, I think. All these composite indices are very useful. They can improve patient outcomes, but they should be used wisely in clinical practice. Thank you very much for your attention.
Thank you very much. Excellent talk. Now we have a few minutes for a question from the actual audience. If anyone have question, or we'll go to the virtual. If there is any question from the virtual. I have a question for most of the studies to assess the improvement of the diseases of the axial SpA, especially the patient with axial SpA that we have, especially in examination, we don't have very subjective measures that to prove of improvement or significant improvement, like joint swelling, that which is something obvious. For those patients, there is several patients who didn't we don't know in the study that how physiotherapy or hydrotherapy or non-medical therapy was used. We just know the information of the biologics use or DMARDs use. Is it in the studies to be included in the to use the full elements of pharmaceutic treatment in the management of axial SpA, so that we try to eliminate the effect of non-organic pain or nocic pain?
Yeah, so there are actually several questions there. I guess the first point to make is that exercise physical therapy is an essential component of the treatment of axial spondyloarthritis. So non-pharmacological treatment approaches are effective and very helpful. So that's the first point to make. I think your question referred mainly to clinical trials. And it is true that in clinical trials, what happens with those non-pharmacological therapies is that they are delivered as part of standard of care. And what is done is that patients are simply randomized, and randomization, it assumes, it allows to take that into account, because theoretically, the approach is in one group versus the other will be similar. So if in one group there's 10% of the patients doing high levels of exercise, you'd expect more or less the same in the other. If there are 20% of the patients in one group that don't do any physical activity, you'd expect by chance to occur the same in the other group. So that's how you take that into account in a randomized controlled trial. That's the objective of randomization. You could speculate, if you're unlucky, you may end up with imbalanced groups where those interventions are not similar between one and the other. But that's the principle of a randomized controlled trial, and it will be just too difficult to try to control for every other factor on a randomized controlled trial. But there are studies, they are more difficult to make because obviously you cannot make a placebo-controlled trial with exercise, but there are studies showing a clear beneficial effect of exercise, not only in physical function measures and mobility, but also in some inflammatory parameters.
Thank you. Last question from the virtual. Would you actually screen for uveitis and inflammatory bowel disease? So do you screen for uveitis and inflammatory bowel disease for axial SPA who have asymptomatic, no eye or bowel symptoms? Do you do active screening for that?
No. I always screen in terms of my clinical history, medical history. I always ask about symptoms when I see the patient, but I don't actually do screening on patients that do not have any symptoms suggestive of the condition. There's no indication that is a valuable strategy.
Thank you very much indeed, Professor Machado, and we will meet you in person next time, hopefully. Thank you very much.
Thank you. It was a pleasure. Thank you.
Now we will move to the second talk, which is also interesting. The lecture will be on Roma oncology and what you will choose for biological demands and for demands and but also other treatments for patients who have rheumatic disease with oncological disease. So I'm introducing speaker, Professor Christopher Edwards. He's honorary consultant traumatologist at University Hospital, Southampton. And his research interest and expertise in epidemiology and treatment of inflammatory rheumatic diseases, including rheumatoid arthritis, lupus, psoriatic arthritis, and ankylosing spondylitis. He's a member of international committees working to produce guidelines for the best management of rheumatic diseases, leading a systemic review of guidelines for the use of radiology in the diagnosis and management of rheumatoid arthritis for the EULAR, with expertise in the planning and delivery of trials in this area. Professor Edwards has developed strong local and international partnership with clinical and academic colleagues centered on his role as a clinical lead of the Southampton Musculoskeletal Research Unit. So I welcome Professor Edwards, and the floor is yours.
Thank you very much. Thank you very much for the kind introduction. I hope you can all hear me. I assume I'll get some message in the chat telling me if that's not the case. And it's a real pleasure to be with you. So thank you so much for the kind invitation to speak. And actually, I was just enjoying Pedro's talk, and he was mentioning towards the end the importance of clinical medicine and clinical decision making. And I think there's no area probably more like that than when we're weighing up risk and benefit for patients, and we're trying to decide how we treat our individual patients and what the relative risk of therapies or the situation is. I was also reflecting about how oncology, how cancer in patients might have influenced some of the patients I've seen in clinic over the last few months. And just before I was starting, I was sort of jotting down that I've seen 3 different patients with prostate cancer who we've introduced DMARDs at a different time, depending on how bad the prostate cancer was, how bad their rheumatoid was, and the types of therapy we were using. I've seen a Behçet's patient who developed lymphoma, and the concern was this was as of a result of the immunosuppressants used, and we've ended up using a Premolast. And then you get patients coming into the clinic saying, "Doctor, I've read that this drug may increase the risk for cancer." And as a result, they're concerned and they want to discuss that. And finally, a patient with non-melanoma skin cancer who is developing a number of BCCs on their head and around their ears from sun exposure. And the discussion went along the lines of the dermatologists were worried about the methotrexate and we changed to sulfasalazine. So there's all sorts of clinical decisions, and you'll have your own stories and the patients that hopefully come to mind when you're thinking about this. So here are my disclosures. And then here are some questions. And I've mentioned some of these in the patients that I've just mentioned, but these are the sorts of things I thought we might cover. And most of what I'm going to say is around rheumatoid arthritis, but I think some of it also converts into other diseases. And of course, we use similar drugs across a number of different rheumatological illnesses. So the first thing we'd need to know if we're thinking about the risk, particularly of the treatments we use, is what the risk of malignancy is in rheumatoid. And we'll come back to that, but you'll probably know this increased risk of lung cancer and of lymphoma that's associated with the disease. Then we want to know if the treatments we use might modulate the risk. And there is increasingly some overlap as well between the therapies we use and the therapies the oncologists use, such as, for example, rituximab. And then we speak to our oncologists, don't we, around adverse events associated with some of the immunotherapies like the checkpoint inhibitors. So we're starting to understand that more. And then have a look and see what guidelines exist and whether they help us and whether those are specific to drugs of different mechanisms of action, and inform us as to how we should use those. And of course, the elephant in the room at the moment is thinking about JAK inhibitors, the oral surveillance study of tofacitinib. And that, of course, was presented at the ACR Convergence meeting last year and is now in the New England Journal of Medicine. So we'll come to that. And then there's less information about the last one of whilst a patient's being treated for the malignancy, how should we be treating their underlying inflammatory disease? Of course, if you give powerful chemotherapy to patients, often their inflammatory disease gets better as well, but then it starts to flare after a period of time. Okay. So this figure, this cartoon, is there to just get us thinking about how we've explored the way the immune system and immune cells are important in rheumatology, here specifically as an inflammatory arthritis and rheumatoid arthritis. And it makes us think about also the immune understanding around immune surveillance and immune dysfunction that's important in the development of certain cancers. And of course, oncologists and rheumatologists have both been exploring this, sometimes from different directions. Sometimes the oncologists are trying to stimulate the immune system to be more active. At a time, we're trying to suppress it and to change its function in that way. And of course, the other thing that's happened is these pathways that are shown on the left have been used to develop therapies that allow us to treat different sorts of inflammatory arthritis using different drugs with different mechanisms of action. And that leads to us needing to ask the question about whether they're safe in our patients, what the relative benefit is and the relative risk is. And that comes back to being a clinician once again. Now, this sort of slide is familiar to you all, but the reason for putting it up is to think about whether any of the strategies we use might increase or decrease the risk of malignancy. So, for example, if it's true that disease activity increases the risk of lymphoma, which seems to be the case in rheumatoid arthritis, then tight control, setting a target may be a good thing. If we're overzealous with our treatments, and if any of the drugs are toxic and might increase the risk of cancer, then that approach may need to be tempered in certain patients. And that builds on this slide, as you can see, some of these questions coming up around tight control, around achieving remission and low disease activity. And then bottom right, we have a lot of different therapies that I'll come back to in a moment. And we need to ask the question about whether those therapies can ever decrease the risk of malignancy if disease activity is important, or whether they might be associated with an increased risk. And these are important things to ask. So many of us, unfortunately, half of us speaking and in the audience will develop cancer at some stage. This is data from the UK, big headline data, but I suppose it raises the fact that cancer is important, cancer is common, so it's going to be very common to see patients who will develop cancer while they're on our treatments. And we'll increasingly have patients, because increasingly patients survive their cancer, we're going to increasingly see patients who have had cancer and had treatment, and then we have to make a decision about how we immunosuppress them over time. So this is a common thing, and it's going to become more common as people live longer and longer and longer. Now, when we think about the risk of malignancy, we're also thinking about the risks, other risks that are associated with inflammatory arthritis. And here's rheumatoid arthritis here. General safety risks we may be concerned about, the increased risk of infection, the increased risk of a number of comorbidities, and those may be important in relation to cancer therapies or the therapies that we choose as well, such as cardiovascular disease or interstitial lung disease that can be caused by our diseases, but can also be increased by certain chemotherapies as well. And then on the bottom, you can see the common malignancies we might think around solid tumors, such as lung cancer, skin cancers, and dividing those up into non-melanoma and melanoma, and then lymphoma. And then on the top right is the globe. And I always tend to put the globe there because it reminds us that the risks that our patients have will vary region by region, depending on the patient group we look after. And the doctor working in a particular area will know what the risk of particular cancers are, and that risk will change over time. For example, the risk of lung cancer is decreasing in the UK because the amount of smoking is decreasing in the UK. But other cancers associated with obesity, for example, have been increasing, such as cancers like breast cancer have been increasing over time. Now, here's the development of different therapies, and I thought it would be worth just looking at those and thinking. So we tend to think of hydroxychloroquine and sulfasalazine and steroids as not being associated with increased cancer risk. And then we get the development of methotrexate, and sometimes there's a little bit of concern, isn't there, about hematological malignancies over time, a bit more perhaps for azathioprine. And then we had the anti-TNFs and initial signals of concern around lymphoma that seemed to be more related to disease activity than actually the drug itself. And then the development of other biologics, rituximab, because of its origin in the treatment of lymphoma, oncologists are generally fairly comfortable for us to use that. And then some of the other therapies, the anti-TNFs, but also tocilizumab being used to treat the adverse effects of immunostimulatory checkpoint inhibitors. And then we get to JAK inhibitors that we're going to spend a little bit of time talking about, particularly in relation to oral surveillance and tofacitinib. And we're trying to work out what that risk benefit is for JAK inhibitors at the moment. So are there many guidelines? And this was useful, I think, this SLR of a number of different guidelines that mention anywhere. So these guidelines that they looked at, these 39 consensus recommendations, weren't all specifically about cancer, but they all mentioned cancer in some way. And this is work from Houston and from Montreal. And here are the sort of headings they said were mentioned. People were looking at the overall risk, and that maybe there was an increase in risk of certain cancers, the importance of screening and of monitoring. To me, that's always a little bit of a concern, because if you ask people, should we screen more? The answer is always, let's be cautious and let's do it. But the evidence that it makes a difference in our patient group, other than, I suppose, myositis in people over 50, I think is very limited. The management of patients with cancer themselves, and the general comment that you should stop treatment with the immunotherapies while people are being treated for their cancer, while they're having their chemotherapy. And then some general advice about what to do with people with a history of cancer. Okay, so what's the risk of malignancy in rheumatoid? You can find this from a number of different sources, but this sort of headline tends to ring true from most of those sources. Lymphoma seems to be increased, and that lymphoma risk seems to be increased with increasing disease activity. There seems to be an increase in lung cancer, and that seems to be over and above the increase you might see from smoking, because of course smoking is responsible for some of the risk of rheumatoid arthritis and of lung cancer. And then generally a decreased risk in some of the studies for colorectal cancer and some of the other cancers. And I guess the colorectal bit, when you think about that, you think, I wonder if that's the effect of non-steroidals being used in our patients, which is associated with a reduction. So certain cancers up, certain cancers down. So does treatment modulate the risk? So first of all, we might think about how treatments might modulate that risk. So on the left-hand side, we can see things that might increase malignancy. So some of our treatments like cyclophosphamide for ANCA-positive vasculitis is directly toxic and may cause an increase in bladder cancer. Although I have to say I've never seen that in any of my patients, probably because we use lower doses and IV rather than oral now. Immunosuppression might increase certain malignancies, particularly those virus-associated malignancy, human papillomavirus in cervical cancer, for example, or some of the head and neck cancers. And there might also be less immunosurveillance, and that might lead to cancer escape. And then you might see less malignancy if reducing inflammation reduces the likelihood of cancer, and that may be true for lymphoma. Some of this is difficult to prove, isn't it? I mean, when I treat patients with Sjögren's syndrome, if they have very active disease, high immunoglobulins, high ESR, I'm always worried that those white blood cells are being overstimulated, and it tends to make me immunosuppressed to bring down that in a hope that this makes the risk of lymphoma less. I have nothing to justify that that's true, but that's the thought process that I've always been taught. Here's some data that comes from the Karolinska, and this is around VTE in rheumatoid arthritis, showing that patients who have the highest disease activity are most likely to have thromboembolic events. And you can show exactly the same data for lymphoma. The higher the disease activity, the more lymphoma there is, the stimulation of the immune system having an effect. That knowledge was very important in the earlier days of infliximab, of anti-TNF therapies, because there was initial worry that anti-TNFs may increase lymphoma. But the knowledge that it was the increased disease activity, and therefore the patients who had the worst disease were most likely to get anti-TNF, and those were more likely to have lymphoma, was very important in reassuring us about the relative risks of biological therapies. So what about specific issues and guidelines regarding specific mechanisms of action? This is a piece of work that was shown as an abstract a year and a half ago at EULAR in 2020, and it's an enormous piece of work, and it involves a number of different colleagues from 4 different countries, Spain, US, Germany, and the UK, big databases. And they looked at all-cause cancers and did some forest plots on the right-hand side to look at relative risk. So they said that the risk of cancer, all-cause, in hydroxychloroquine versus methotrexate looks about the same. Same with sulfasalazine and methotrexate. So perhaps reassuring us that the evidence that methotrexate increases cancer risk was not high. Interestingly, they saw a slight reduction with leflunomide. So that's something maybe to think about, whether that stands up in other studies. We can wait and see. But overall, their view was that the CSD mods we use don't seem to increase cancers very much. Lymphoma, here's French data, and they were trying to pull out risk factors for lymphoma, but also the drugs themselves. And the headline was that methotrexate and TNF inhibitors didn't seem in their data to increase it. Higher disease activity, erosions, seropositivity was associated with more. And they wondered whether this was a channeling bias, but they saw more lymphoma in those on hydroxychloroquine. So either people with a bigger risk were channeled to hydroxychloroquine, or perhaps hydroxychloroquine just isn't potent enough to control the disease activity and reduce the lymphoma risk. And I have to say, I have a bias for that, which is one of the reasons why I favor methotrexate over sulfasalazine in almost everyone, if I can get away with using it. Okay, so this is probably the biggest headline slide, isn't it? So this is taken from oral surveillance, which is now in the New England Journal of Medicine, published a couple of months ago. And it allows us to look at that work that was published, first of all, in ACR Convergence, and try and look at a little bit more detail. And I've tried to highlight a few of the things. So you'll remember that this was a study of people over 50 with at least one cardiovascular risk. So they were being enriched. It was an FDA-inspired study to try and look at safety over time. It was a non-inferiority design, and it failed to meet non-inferiority for MACE and for cancers, which is what we're going to talk about now. And you can see on the left-hand side the number of cases. So there were 122 cases of cancer out of 2,900 for tofacitinib combined doses. And on the right-hand side, there were 42 out of 1,400 on the TNF inhibitors, which were either adalimumab or etanercept, depending on where this was done. And that gave an overall hazard ratio at the top of 1.48. And because of the confidence intervals, this failed the non-inferiority that had been pre-specified. And then if you look over on the right-hand side, you can get a little bit more detail. And I think some of this is important in trying to work out what this tells us to do in the longer term. So at the bottom, I've ringed it in red, that you can see what this says is the numbers needed to harm. So over a 5-year period, you need to treat an extra 55 patients with tofacitinib compared to giving them anti-TNF to get 1 extra case of malignancy. Just think about that for a moment. And then on top of that, the group in whom this was most likely to occur were the older people who were over 65. Because then you start to say, what do I do with this information? So this could say, now I'm worried I'm going to avoid JAK inhibitors. I'm certainly going to avoid tofacitinib. Or you could say, actually, this number needed to harm risk suggests that actually I have to treat a lot of patients before I get 1 event. I'm not worried about this. And in particular, it might mean that we reduce the risk by using JAK inhibitors in this setting, certainly tofacitinib, after TNF inhibitors, or we might avoid it in those at highest risk, such as the oldest population. And I guess we're trying to work this out, because don't forget this, what this data says is a relative risk. So it may be that TNF inhibitors are just particularly good at reducing the risk of malignancy rather than tofacitinib increasing. Okay, so I'm going to move on. Now, this isn't shown in all of the data. There's a similar study to oral surveillance running for baricitinib at the moment, and it's going to take a few years for us to get information. But if you look at the long-term follow-up for those other JAK inhibitors at the moment, they don't seem to show a signal for malignancy. So I guess we're going to have to wait a little bit of time to decide whether we treat this as a class effect or not. And there are differences between the FDA that's expressed more concern and the European Medicines Agency that's expressed less concern. Okay, so a couple of quick things to finish off with. So are there guidelines that tell us what to do in relation to our therapies? And of course, most of these have been written prior to the information around JAK inhibitors. So it's mainly about biologics. Here's the BSR in the UK saying biologic therapy shouldn't be commenced while people are being treated for malignancy. And you should be cautious about that. But actually, the evidence base isn't strong to suggest biologics have any problem in relation to risk. Here's another piece of work that comes from that systematic review from the BSR guidance around patients predisposed. So here are from BSR Biologics Registry and the Danish Registry, looking at women who've had cervical neoplasia and seeing whether on biologics they were likely to develop another event. Doesn't seem very common. So even though they're predisposed, that risk doesn't seem to be very high. And then the last bit is about evidence of any use while patients are under treatment for malignancy. And actually, this is quite difficult to find this information. I think this is more in the realms of our own personal experience, and maybe questions about that could come. So this is a piece of work looking and seeing how likely it is that patients who have autoimmune diseases who go on to checkpoint inhibitors, immune stimulatory therapies for cancer, are to have a flare. And their suggestion is that most don't have a flare. And of course, we have the experience of treating with tocilizumab and anti-TNF therapies the inflammatory consequences of the use of immune checkpoint inhibitors, and advice about that has now been given by organizations. Here's the EULAR guidance from last year, giving advice about the sort of therapies, TNF inhibitors, IL-6 inhibitors, that can be used for these rheumatic manifestations of cancer checkpoint inhibitors. Okay, so last few things. So we've talked a bit about the risk of active disease in promoting lymphoma risk. So this is not just about we reduce risk by not using therapy. If we don't treat our patients, some of the cancers are probably going to increase, such as lymphoma. For most of the therapies, the risk of malignancy doesn't seem high. Finally, on the right-hand side, in all our patients, thinking about reducing the things that increase cancer in general, not just controlling disease, but stopping smoking, screening where necessary through national screening programs, and for example, the HPV vaccination, which is given to younger people now, particularly to younger women, to reduce cervical cancer risk. I've mentioned these factors already and how tight control may have benefit if the cancer is associated with disease activity. And finally, here's the summary slide where we've talked through the risk of malignancy, lung and lymphoma more. Does treatment modulate the risk? I think it's a bit undecided. I suspect that some cancers are reduced by better disease control, and we're trying to get our head around exactly what the tofacitinib data means. A degree of caution seems reasonable at the moment. And then we have some evidence around the use of therapies while people are under treatment, and some that we're more comfortable with, such as tocilizumab and rituximab, and for checkpoint inhibitor symptoms, TNF inhibitors as well. So with that, thank you very much for your attention. Very happy to take questions.
Thank you very much. Great talk and topic. If any from the attending audience have any question. Okay, Dr. Adiba.
It's good to see you again.
Hello.
I'll just go back to the point that you mentioned that during malignancy, whether you treat with biologics or not, and if you can elaborate more on that. And if you want to treat till cancer is cured, then for how long do you treat? Then you can resume or start your biologic treatment.
Yeah, I think those are really good questions. And I think probably we started off being quite prescriptive about this, didn't we? If you think when we first used biological therapies, anti-TNFs, we would say there needed to be a 10-year gap after the cancer before we should use it. And then guidance said, make it 5 years. And I have to say now, I think it's more nuanced. And I think it depends on both the severity of the cancer and what the oncologist thinks. You know, I speak to my oncologist a lot about these things. And the need of the treatment of the rheumatic disease. So if someone has terrible rheumatoid arthritis, it's very hard to think we shouldn't treat them for 2 years or 5 years until we're sure their cancer isn't going to recur. We can't sit and wait while their joints are damaged while that's going on. And so right at the beginning, I mentioned these 3 people with prostate cancer that I've looked after. I have one in whom their rheumatoid was so bad and they had very severe depression about their rheumatoid arthritis that we treated very soon after their prostate cancer was first treated. Another one, we waited a year until everybody was sure of the extent. And then another where the patient was concerned about the cancer risk more than the rheumatoid. And then they've waited a good few years afterwards. And I think this is nuanced. I think it's a weighing up of risk and benefit, and it's hard to be prescriptive. Sorry, that's a long answer, but I think it's trying to highlight the importance of the clinical decision making.
Thank you. I have a question. You showed in the data interesting information for men and women. For men, there is more risk with lung cancer with using of TOFA or JAK inhibitors, and for women, breast cancer with anti-TNF. And now do you think we can utilize this information in starting, in given for us option to start, which for example, we have a new failure of a patient in DMARD and he need biologics in a men to start, for example, anti-TNF rather than JAK inhibitor, and that's
yeah.
something for women.
I mean, I think they're little clues, aren't they? I mean, I think with the oral surveillance, we're trying to decide how do we use that information. And if we were being cautious, we might say, okay, if we use anti-TNF therapies first, a biologic first, and we use JAK inhibitors second, I think that removes some of the risk. Whether that's necessary in all patients or whether we just select out those that are higher risk, such as those over 65, that would be another approach that would mitigate risk. I think the little clues about them seeing more lung cancer in as the most common of the cancers that were seen in oral surveillance with tofacitinib. I'm not sure that proves direct causation, but it might say, well, if that's the most common, either does that tell us that the disease isn't suppressed quite as well, or it tells us that we should be keeping an eye out for those patients and really encouraging our patients to stop smoking, you know, to reduce other cancer, lung cancer related risk. But I think all of these bits of information are there for us to try and decide, to weigh up what we're going to do. And some of it needs a bit more time, and for the other studies, for the other JAK inhibitors to come out.
Well, and I have to conclude this session. No more question, and I thank you very much, Professor Christopher. And we will see you in next year, hopefully. And thank you very much.
Thank you very much. Shukran. Thank you.
Shukran. And now we will move, last but not least, I want to have pleasure to introduce Professor Ali Jawad. He's a consultant traumatologist at Royal London Hospital. He has won several research grants investigating the role of cytokines on bone in rheumatoid arthritis. He published several books, chapters, and more than 270 articles in their journals. He is MRCP clinical examiner and external examiner for Imperial College London. Also, he's a member of so many committees, and he was appointed recently in OPE in 2022, a New Year honors list. Professor Ali Jawad will give us a talk in the advances and osteoarthritis. I hope he will give us more information and exploring the facts and eliminating for us the fiction about osteoarthritis, this is so many questions we got in the clinic from patients with osteoarthritis. Welcome, Professor Ali Jawad.
Thank you very much. Indeed, thank you again for inviting me to the meeting. I wanted to ask a question, Chris, before he left, because I have a patient with Lynch syndrome. So he's already developed 5 different cancers and has active rheumatoid. But anyway, that's for another day. I will try and in fact, I have no other declarations to make. I'll try and make this topic really less painful, because talking about the different aspects of the science of osteoarthritis could be taxing at the end of 2 exciting days. So I'm going to define osteoarthritis, talk about normal cartilage, aging, pathogenesis, risk factors, and then obviously try and answer, can we modify the question whether we could modify osteoarthritis and look at some investigative therapies. So the whole idea is to understand the effect of aging on articular joints, pathogenesis, and possible treatment. Now, osteoarthritis is primarily characterized by focal cartilage damage. There is also peri-articular, you can see the peri-articular sclerosis and secondary synovitis. It's strongly associated with age. In fact, by the age of 16, nearly every one of us will have osteoarthritis in at least one joint. And but one has to remember, although it's associated with aging, but in fact, the bone and cartilage changes in osteoarthritis are slightly different from those of normal aging. In fact, they occur on top of normal aging. And it's the premature aging of the chondrocyte and the matrix probably plays a crucial role in the initiation and progression. And so radiologically, I think it's best to start from the clinical and go into the science. If you look at the early changes, and this is an X-ray of a patient, and you could see the early change in the bone is the subchondral sclerosis and trabecular thickening, and the presence of osteophytes, you could see. And the cartilage change, we already see there is narrowing of the joint space due to thinning. This is the same patients 5 years later, the same joint. And you could see that when it comes to the cartilage has almost completely been lost. But if you look at the changes in the bone, there is remodeling of the surface, and the osteophytes have gone bigger, and there's already cystic changes occurring in the bone itself. And if you said, you could see this is the same patients, the same joint, and the changes over a period of 5 years. Now, so really osteoarthritis results from articular cartilage failure, which is induced by a number of factors: genetics, metabolic, biochemical, and biomechanical factors. But also this is associated with periarticular bone changes in the form of sclerosis and remodeling. But there is a secondary component of inflammation in a significant number of patients. Now, the genetics have been sorted from monogenic studies and the genome-wide study association, and but however, there are many genes that have been found to be involved, but their contribution is really modest to the overall risk. And to estimate the contribution of genetics to common osteoarthritis, it's between 39% to 65%, with the first-degree relatives having a twofold or threefold increase of disease. And the genes that appear to be important are the ones that relate to the skeletal development, such as the BMPs, signaling proteins, and others related to cartilage metabolism, as one would expect. Now, hemochromatosis really provides evidence for all the factors that I've mentioned. This is a patient who is around 51 years old, who was seen with early osteoarthritis in the hips. He decided to go on recreational running. He was running a few miles every day, and 18 months later, you can see what has happened. Both hips have become severely osteoarthritic. No joint space, sclerosis of the articular surfaces. Look at the cystic changes there and the osteophytosis. So this is, you could say, the hemochromatosis is a genetic disease. There is metabolic changes. There is biochemical factors, biomechanical factors through the running, and obviously they get calcium pyrophosphate crystal deposition with inflammation. So you can see all the factors have operated in this patient, and within 18 months, his joints were completely damaged. In contrast, if we look at acromegaly, for example, because in acromegaly, obviously there is excessive growth hormone formation, but also the growth factors are increased as well. And here, interestingly, you do see osteophytosis. This is the patient's acromegaly. And you can see the joint space has hypertrophy. There is not only preservation, but hypertrophy of the joint space compared with a similar patients of the same age, where you could see significant osteoarthritis. So one wonders whether the osteophytosis, the osteophyte formation, is very much part of the process of osteoarthritis, or is it really separate? No doubt it must be induced by growth factors. Now, to understand in a way what goes on within the joint, we need to understand the hyaline cartilage. The hyaline cartilage is made up of two things: the matrix, which is the pink structure here, and the lacunae, where the chondrocytes reside. And you have to remember that there is in every part of the body, there is a process of repair which is continuous. It's really very clear, for example, in the bone cycle takes 6 months. We remove a lot of bone is removed, is resorbed within a couple of weeks, and it takes another 5.5 months to repair what has gone. The same applies with cartilage, and the extracellular matrix of cartilage is made up of 2 components: the type 2 collagen, which gives it tensile strength, and aggrecan, which is a proteoglycan, highly hydrated, and therefore allows the cartilage to resist compressive loads. So under physiological conditions, as I said, it's constantly remodeled through degrading of the matrix and the aggrecan and the synthesis of collagen and aggrecan. And the reason why these cycles occur in bone and cartilage and many other parts of the body is to avoid, in a way, damage to the parts. But obviously, when we get older, the repair process becomes poor, and in a way, the degeneration exceeds repair. Now, when it comes to extracellular matrix, it wears away both in osteoarthritis and in inflammatory arthritis. And the loss of aggrecan is the primary event which leads to the destruction of cartilage. And aggrecan is damaged through proteinases or agglutinases, or we also call them metalloproteinases. And in a way, you could see the repair process is obviously driven by growth factors. So this is why when we look at a new treatment for osteoarthritis, we're all looking at agents that will block the enzymes, the proteases and the metalloproteinases, and we're looking for growth factors to enhance the repair process. Now, there are 2 enzymes or 2 metalloproteinases that are capable of degrading aggrecan, and they are ADAMTS4 and ADAMTS5. And there are 2 studies were done, in fact, now 15 years ago, but there hasn't really been much advance since by Stanton and Glasson. Stanton looked at a model of arthritis following really destroying the cruciate ligaments and the cartilage, and Glasson looked at a model where they induced arthritis, inflammatory arthritis. And then they looked at various types of mice, some that were deficient in ADAMTS4 and the others deficient or with ablated ADAMTS5. And interestingly, those who had ablation of ADAMTS5, those patients were protected against erosion of cartilage and the occurrence of both inflammatory and degenerative arthritis. While if you get rid of ADAMTS4, this had no protective effect. So therefore, in fact, over the last 15 years, researchers have been trying to look at ways of ablating ADAMTS5 to protect erosion of cartilage and the occurrence of arthritis, especially for post-injury in humans. Now, again, we mustn't forget the bone, the subchondral thickening or sclerosis, and we do know that, for example, in patients with severe pain, we could see juxta-articular bone marrow edema in those patients. Now, just here, I thought, just to explain the clinical relevance of each radiographic finding in osteoarthritis. For example, when it comes to the hip, it's narrowing of the joint space that is closely correlates with pain. While in the knee, it is the osteophytes that correlate best with pain. And in general, if there is joint space narrowing, it best correlates or predicts disease progression. The presence of cysts correlate with night pain and therefore the need for joint replacement. And even in the hands, narrowing of the joint space and the presence of Haberdine and Bouchard's nodes, which are osteophytes, they correlate very well with pain in nodal osteoarthritis. Now, let's look at the risk factors. Now, when it comes to aging, we have to look at aging of the matrix and also aging of the cells, which are mainly the chondrocyte. So if we look at the matrix, this is normal cartilage, and this is osteoarthritic cartilage. And you could see there is thinning of the cartilage with age, it's dehydrated, and there is, which we can't see, it's the accumulation of the advanced glycation end products. These are very harmful products, and they are very common, for example, in patients with diabetes. And most of the musculoskeletal manifestation of diabetes is associated with the advanced glycation end products. And there is evidence that patients who develop atherosclerosis and lupus, they have high level of IgEs. Now, also in addition, the 30% of us by the age of 75 will have calcium pyrophosphate crystal deposition, and that adds in a way to the aging of the extracellular matrix. Now, the cells, the DNA has a limited age, and eventually there is DNA damage, and there is also dysfunction of the mitochondria, mainly due to oxidative stress. And there is also, with age, the cells' response to growth factors is reduced. So in a way, even if you give them growth factors, it seems the cells have become too tired to respond. And in addition, these two factors, the mitochondrial dysfunction and reduced responsiveness to growth factors, lead to a catabolic activity. There is increased degeneration, and which is mediated and enhanced by pro-inflammatory mediators and the proteases and the metalloproteinases. So you could see all these factors, the aging in the matrix and the cellular aging, contribute significantly to joint damage. Now, we have already talked about the aging when it comes to a risk factor, but obesity is another risk factor, not only for the hips and the knees, but also for nodal osteoarthritis. So that is really important as well. Now, when it comes to joint injury, the injuries that really cause increases the risk for later osteoarthritis are meniscal tears, fractures through the articular surface, dislocation, and cruciate ligament tears. So these are really the ones that cause osteoarthritis, especially in footballers. Osteoarthritis is more common in women, especially the loss of estrogen with the menopause. In fact, estrogens are protective against osteoarthritis. And the only, in fact, in a way, intervention that could slow down nodal osteoarthritis is hormone replacement in patients. Obviously, if we get mutations in collagen 2, or 9 and 11, that will cause osteoarthritis. And anatomical factors, acetabular dysplasia is very common. And in fact, one of the famous tennis players who had a hip replacement had acetabular dysplasia, and varus and valgus knees also predisposed. In addition, the loss of proprioception, patients who have had, for example, L4 root compression with damage on EMG, they are more likely to develop osteoarthritis of the knee if it's L4, or if it's L5, it's the ankle. And if that is combined with ligamentous instability, especially in footballers and other high impact sports, then there is acceleration of osteoarthritis. And this is really exemplified by, around 12 years ago, we were excited when the nerve growth factors, because at the time, a number of eminent people, rheumatologists, used to say, well, osteoarthritis is just a pain syndrome. If we block the nerve, the pain, the patients would improve. So tanezumab and fasinumab were developed with our humanized Ig2 monoclonal antibody, which blocks the nerve receptors. And in fact, these patients had very little pain. However, they had rapidly progressive osteoarthritis. And so that they are no longer used or no longer investigated. Can we modify osteoarthritis? Well, we have to look at structural modification. We'll have to look at cartilage catabolism and anabolism, bone remodeling, and we have to look at the inflammatory pathways. But as I have said, the inflammatory pathways are only secondary to the other factors. So if we look at these 9, in a way, factors have been looked at, and the BNP is really important because it regulates cellular linkage, commitment, morphogenesis, and differentiation. However, when they have been used, there was a trend towards symptomatic relief, but no significant, really long-term benefit. And when fibroblast growth factors were used, because as I said, the growth factors are important to see whether we could stimulate the chondrocyte. In fact, there is very little evidence. Obviously, our friends, the matrix, well, they are our enemies, matrix metalloproteinases. If we could inhibit them, maybe that will stop the extra cellular matrix. However, they have been used, but they cause intolerable side effects in the form of, in fact, the tendons tend to overgrow. By the way, in fact, when we corticosteroids do inhibit matrix metalloproteinases, and I think they do have some benefit, obviously, in patients with osteoarthritis. Now, the mitogen activated protein kinase inhibitor, these were used. However, there was significant hepatic and neurotoxicity, and they were abandoned. Cathepsin K inhibitors, we use them for osteoporosis, but so far the studies have had a variable outcome. The WNET signaling pathways inhibition, because WNET proteins regulate again cell growth, function, and differentiation. There are some promising patients-reported outcomes, decrease in pain, improve in function, but more studies are needed. As I said, the ADAMTS5 ablation is being tried. The results look promising, but there is a long wait. Using tissue gene C, there is some statistically significant improvement in pain and function. However, there doesn't seem to be any improvement in structure change. Now, platelet-rich plasma is widely used in private practice. I see in the Gulf, in Southeast Asia, and even in Europe. And it's based on the fact that you take the buffy coat, you centrifuge the patient's blood, you take the buffy coat, which is rich in platelets, and the activated platelet, and you inject it into the joint. The activated platelets will release intracellular granules, and it's full of growth factors. You can see all these, the TGF, the fibroblast growth factor, the platelet-derived growth factor, the VEGF, and so on. However, there has been well-designed trials conducted, but they do not support its use in osteoarthritis and tendon injuries. So I think people are wasting their money. Now, what about remodeling bone? Well, calcitonin was tried without many benefit. Strontium was really very promising. And I remember going to Paris because it was made by a French company and looking at the evidence around maybe 15, 16 years ago. However, there was the adverse cardiovascular side effects were very significant and it's been abandoned. Bisphosphonates, well, potentially they are useful for symptomatic relief and disease modification, but the studies are difficult. However, recently we have had at least 2 studies which showed that the use of bisphosphonate is associated with less knee replacement. And as we know, joint replacement is very relevant, and it's a good hard endpoint when it comes to studies in osteoarthritis. So we really need more studies because they are safe, the bisphosphonate. Now, what about looking at inflammatory pathways? As we said, inflammation osteoarthritis is only secondary. And people looked at TNF factor because TNF is really involved in almost in every immune-mediated disease that is associated with arthritis. But you could see, for example, with an RA, it's not only TNF-alpha, but IL-6, but when it comes to inflammatory bowel disease, is TNF-alpha and interleukin-23, and so on. However, really it's not appropriate to use them, but they have been found to be useful in a small subset where they have erosive OA. And as we said, erosive OA, maybe it is seronegative inflammatory arthritis. Now, interleukin-1 beta, because studies inhibitors, because interleukin-1 beta induces metalloproteinases. So if we inhibit IL-1, it may help. However, absolute neutropenia has been a problem, and the studies have been abandoned. The inducible nitric oxide synthase inhibitors showed no benefit, and there is a drug called incatibinat, which is a bradykinin receptor B2 antagonist. It's the stage phase 1 trials seem to be promising, but we are still awaited. Now, I was at a meeting at the Royal Society of Medicine only 3 days ago, and they were looking at, and one of our colleagues have, in fact, a macrophage 2 inhibitor. And if we look at, which is now being tried in patients with scleroderma, and where the macrophage, second type of macrophage, macrophage 2, is the dominant cell. And in fact, the dominant cell in the synovial fluid from patients with arthritis is full of macrophages, although it is hypocellular. And one wonders whether using macrophage 2 inhibitor would be of any value. So to summarize, osteoarthritis is generally characterized by focal cartilage damage with associated periarticular bone sclerosis and secondary synovitis. It is strongly associated with age, but the bone and joint changes in osteoarthritis are slightly different or occur on top of the normal aging process. And this is really official. No pharmacologic agents have been approved by any regulating authority for disease modification in osteoarthritis as yet. And the trials have failed to detect clinical efficacy of potential disease-modifying drugs in osteoarthritis, either because there is lack of responsive outcome measures, but although some of them have some improvement in pain, function, or joint structure. Though there has been progress, I said, with potential in new therapies, but the availability of a potential structural modifying agent appears very distant. Thank you very much.
Thank you very much, Professor Jawad. We will First, have a room for questions for the attending for the people, and then we'll go for the virtual questions. Dr. Ahmed.
Thank you very much for the very thorough look at osteoarthritis management and the current available therapies. I have a question about some of the new therapies we've seen in the region here. And there is some, there's like a phospholipid cream, Flexisec or something. And I could see some paper by Philip Conahan in the UK on the evidence of that paper. And they claim that phospholipid cream just get absorbed and then go to the joint and help improving the osteoarthritis. Have you come across that at all? Supposedly if they reached to Philip Conahan trials and Leeds, probably you've heard about that as well. Yeah.
Well, I think there are many things being tried. And in fact, we have a part of of our experimental rheumatology academic department. In fact, we have a group working on osteoarthritis, and they are looking at several new leads. But really, I reviewed all the evidence that is published, and there isn't anything that looks promising as yet. I think people are still looking. I think the best bet would have been, in a way, blocking metalloproteinases. However, the blockers that are being used, they cause problems with tendons and other features. And the growth factors, the problem with using growth factors is the chondrocyte itself ages because of mitochondrial dysfunction and the DNA damage, and therefore it becomes less responsive for these growth factors. And as I said, I think there is still in many parts of the world you could have the RPR, but again, I think there is really no solid evidence to show that any of the above is working. There are 2 or 3 promising perhaps avenues, but we really need to be convinced. I think the trials on RPR have been very well conducted, but really the results are disappointing.
Do you think that disappointing results actually because of the wrong way we classify osteoarthritis? It's probably not a one disease, it's multiple diseases, because we speak about premature degeneration in young, generally relatively young people in comparison to an accepted aging process that should happen anyway, you cannot stop it. There's the nodal osteoarthritis, there's the knees osteoarthritis. Are we simply looking from the wrong angle, and that's why we got the wrong results? As we did with lupus when we used wrong outcome measures, and even with effective therapies, we didn't get good results. Simply, we're not looking in the right way.
Well, this is why when I was asked to give this talk, I really looked at the clinical aspect, and in a way then went into the molecular aspect of the condition, because it is difficult to answer that. There is no doubt the DNA we have, you see, over the years, even 2,000 years ago, the upper limit of survival was around 100, 105 years. And now in 2022, still the upper limit has not changed, but the number of people reaching 100 has increased. Why? Because we're not meant to last. Essentially, because our DNA, and Dolly the sheep is the best example. And I think the aging process has a factor. There is a factor in that. To try and classify, and no doubt, if you look at diseases associated with presenility, for example, progeria, for example, patients with progeria who age quickly, they get osteoarthritis very, very quickly. Yes, I think we may need to look at osteoarthritis in a different manner. no doubt. I said the genetics seem to be there. There is a significant element from around 39% to around 65%. But perhaps I think what we really need is to try and reclassify osteoarthritis and look at the different types. I think nodal osteoarthritis we need to study, because why should it be worsen with obesity, for example? We can understand knees and hips and so on. So perhaps I think your suggestion is valid. Perhaps we're looking at too many diseases, too many subtypes, and we need to individualize these types of into syndromes and look at them separately.
We are already run out of time, but this is the last session, so we'll utilize the benefit of it. We'll have a question from Dr. Adiba Al-Hirs, and then just one question from the virtual. Too many questions actually from the virtual, but we will take one question. So Dr. Adiba, your question, please.
I have a few, you can hear me? I have a few patients, not very old, like 40s, 50s, and they have aggressive nodal and very rapidly progressive osteoarthritis. Now, I've tried different DMARDs for them, including biologic DMARDs. They do feel better, but you can never stop the progression of the disease. Every year they feel it's worse radiographically and by ultrasound. So I know there is no good evidence, but from your experience, how do you feel about those patients and using DMARDs for them? And what's your preference in terms of DMARDs?
Yes, I mean, I think with these patients, I would look at them. First of all, are they obese? Have they got type 2 diabetes? Has their ovarian function? Have they had premature menopause? I would look at quite often a patient comes in maybe 39, 40 years old. I've got a few patients who come in with nodal osteoarthritis, and then when you take the full history, you find that they had an early menopause, for example. These patients, I would treat them with hormone replacement at least until the age of 51. Some of them are obese. I strongly advise them to lose weight, because no doubt their obesity is associated with nodal osteoarthritis. If they have type 2 diabetes, they ought to, because with type 2 diabetes, as I said, the GEMs, the glycosylated end products increase, and therefore you have to control that diabetes to reduce these proteins. Now, when it comes, if none of the above is operative, then I usually put them on hydroxychloroquine, because hydroxychloroquine helps the pain, and it may help. The inflammation there is not very severe. And I would try them for 6 months on an anti-TNF. But I don't think methotrexate will make any difference, or leflunomide, but certainly worth trying, I would say, hydroxychloroquine. But they are difficult to treat. And if you take the history, a lot of them, their maternal relatives have had a similar problem. They are difficult to treat, no doubt.
Okay, last question from the audience. Any advances in the oral supplement, glucosamine and chondroitin, or the viscous supplement?
Absolutely not. I think they have been proven to be of no benefit. And one has to be careful with the glucosamine. If you take too much glucosamine, it may damage your the beta islet cells. There is a risk of diabetes with it. So please don't use them. They are really useless. Make sure that the patients have adequate vitamin D, because vitamin D is important. No doubt, vitamin D deficiency can accelerate osteoarthritis. And if the patient has an early menopause, I'll give them hormone replacement at least until the age of 51. But there is very little else that would modify the disease. Maybe a high fish diet will decrease the pain, but it may not modify the disease. So a high fish diet will reduce the pain, but it will not modify the disease.
Thank you very much. And in the end, this is the end of our meeting, BEST ACR Convergence 2021. And thank you for all attendee and all virtual attendee. In the end, I thank the organizing committee and the scientific committee for this conference in the top Emirate Rheumatology Academy, and several other activity you are invited for this month. There is it's all face-to-face, not virtual. For in 18 and 19 March, the first advanced connective tissue disease meeting here in Dubai. And the other meeting after it is the first SPA meeting in, from 25 to 26 March in here in Dubai. Thank you very much all for the attending, and see you next February 2000 for the BEST ACR 2022 next year. Thank you.